9 Psychological Aspects of the Menstrual Cycle. Margaret F. Jensvold, M.D. Karina E. Dan, R.N., B.S.N. Biomedical researchers have commonly viewed the menstrual cycle as a confounding factor in research rather than as a legitimate subject of scientific study. This view has contributed to the exclusion of women of reproductive age from much health research. Kinney et al. 1981. At the same time, a plethora of media articles have conveyed primarily negative images of the menstrual cycle and of premenstrual syndrome, along with conflicting diagnostic and treatment information and jokes. Chrysler and Levy 1990. If women and their healthcare providers are confused about the menstrual cycle, there is good reason. Nevertheless, we do have some knowledge. Research during the past couple of decades has helped clarify what the questions are and has pointed to directions for future research. This chapter is intended not to be entirely comprehensive, citing all research findings, but rather to present current research findings and illustrative points to provide a framework for clinicians, researchers, and healthcare consumers for conceptualizing the role of the menstrual cycle in psychiatry. Many, if not most, physiologic parameters vary in a circadian manner, example body temperature, cortisol level, thyrotropin-releasing hormone level, sleep-wake, usually without causing symptoms and often with the person not even aware that the changes are occurring. Likewise, many physiologic parameters vary over the course of the normal menstrual cycle, not causing symptoms and often with the woman being unaware of the change. Cultural factors are well documented to have a significant influence on expectations. 177-178 Psychological Aspects of Women's Healthcare, 2nd edition, and Perceptions Related to the Menstrual Cycle. With both physiologic and cultural factors contributing to changes over the menstrual cycle, how is one to make sense of pathology related to this cycle? This chapter addresses the physiology, cultural considerations, and diagnosis and treatment related to the menstrual cycle with attention to methodologic and political concerns. Physiology. Normal menstrual cycle. The core events of the normal menstrual cycle are an integrally interconnected neuroendocrine feedback loop, the hypothalamic, pituitary, ovarian axis. 1 Readers are referred elsewhere for detailed accounts of the endocrine events of the normal menstrual cycle. Severino and Molin 1989, Sparoff et al. 1982. The menstrual cycle can be thought of as consisting of 2 phases, the follicular phase and the luteal phase, with cyclicity occurring in a number of organs and tissues, figures 9:1 and 9:2. What is happening suprahypothalamically over the course of the menstrual cycle is less known to us, but animal research shows that neurotransmitters cycle catamenially too in various parts of the brain. McEwen 1988. The uterus is not a core player in the normal menstrual cycle, but rather is a target organ for hormonal action. Its regular, recurrent menstrual flow is an external indicator to the woman that yet another menstrual cycle has been completed and that a new one is beginning. What constitutes the endogenous time clock of the menstrual cycle is relatively unknown at present. The suprachiasmatic nucleus and associated structures are suspected. Kawakami et al. 1980. Circadian cycling is thought to be driven by the suprachiasmatic nucleus, with light input through the retinohypothalamic tract serving as a Zeitgeber, or entraining factor, that affects the cycle length but not the presence or absence of the circadian cycle altogether. In the absence of light, dark cues the circadian time clock free runs, still cycling in a regular circadian manner but with a slightly longer cycle length on average, 27 hours free running compared with 24 hours day, night entrained. Whether ovarian input to the brain serves as a Zeitgeber simply entraining the timing of a catamenial cycle that would free run without ovary. 1A hypothalamic, pituitary, gonadal axis exists in men as well, of course, the hypothalamus, pituitary, testicular axis. That it has no external indicator of its timing does not in itself mean that it does not have an endogenous timing mechanism. 2 Catamenial means of or related to menses or the menstrual cycle. Psychological aspects of the menstrual cycle. 179 Figure 9:1. The normal menstrual cycle. Hormonal, ovarian, endometrial, and basal body temperature changes and their relationships throughout the normal menstrual cycle are shown. E2 equals estradiol, FSH equals follicle stimulating hormone, LH equals luteinizing hormone, P equals progesterone. Source: reprinted from Carr B.R., Wilson J.D., Disorders of the Ovary and Female Reproductive Tract, in Harrison's Principles of Internal Medicine, 11th edition. Edited by Braunwald E., Isselbacher K.J., Petersdorf R.G., et al. New York, McGraw-Hill, 1987, p. 1823. Copyright 1987, The McGraw-Hill Companies. Used with permission. An input or whether ovarian input is integral to the continued catamenial cycling of the brain is not entirely known. There is some evidence in each direction. Gonadotropin-releasing hormone, GnRH, agonist treatment EV 180 Psychological Aspects of Women's Healthcare, 2nd edition figure 9-2. Hypothalamic, pituitary, ovarian axis. The pathways of endogenous and exogenous hormones are shown. FSH equals follicle stimulating hormone, GnRH equals gonadotropin releasing hormone, LH equals luteinizing hormone. Psychological aspects of the menstrual cycle 180 Wundens indicates that when ovarian input is removed, catamenial cycling of central nervous system symptoms stops, Hamar-Back and Backstrom 1988. On the other hand, a study of patients with premenstrual syndrome using a progesterone antagonist, RU486, showed that when the normal hormonal milieu of the latter quarter of the menstrual cycle is removed, thus displacing the timing of menstrual flow, menstrually related mood symptoms still occur at the usual time in some patients, Schmidt et al. 1991. This indicates either that endocrine events earlier in the cycle ordain the timing of the cyclic mood symptoms or that central nervous system cycling continues independently of the peripheral hormonal milieu, at least for a time. An exogenous factor affecting the menstrual cycle that has been studied is the presence of other cycling females. The tendency towards synchrony of cycles among females who spend an extended time together is mediated by pheromones produced by the women themselves that expedite or delay the onset of the ovarian cycle, McClintock 1984. Variability in the normal menstrual cycle and occasional anovulatory cycle or shortened luteal phase is not uncommon. However, certain groups are more prone to menstrual irregularities, including heavy exercisers, anorexics, and women taking neuroleptic medications, Sullivan and Lukoff 1990, or abusing substances. At least for heavy exercisers, anovulatory cycles appear to be associated with increased bone loss. Cultural aspects. Evidence for a strong cultural influence on our view of the menstrual cycle comes from several fronts. Menstrual taboos have existed across cultures and across time, including today. Deutsch, 1944, discussed the psychologic meaning of menstruation, pointing out the reasons why women deny and hide it and also pointing out the tendency to prefer to view the menstrual cycle as a biologic function rather than as having great psychologic significance for the woman. The words we use to describe the menstrual cycle convey our tendency to view it negatively, rather than positively, Martin 1987. Premenstrual syndrome seems to be to the 20th century what neurasthenia was to the 19th century, a nebulous disorder primarily of women that involves the menstrual cycle, has numerous symptoms, etiologies, and treatments proposed, and conveys a negative view of women, King 1989. 182 Psychological Aspects of Women's Healthcare, 2nd edition. Premenstrual syndrome meets the criteria for a culture-bound syndrome. It constitutes a negotiated reality, that is, its reality is that negotiated between those who treat it and those who suffer it, Morokoff 1991. Premenstrual syndrome is unique in the extent to which the societal negotiation process has been overt and public with research, debates, protests, letters back and forth, and papers supporting various points of view. The tentative compromise solution placed late luteal phase dysphoric disorder, LLPDD, in the appendix to DSM-3R, American Psychiatric Association 1987, highlighting its negotiated and controversial status. In DSM-4, American Psychiatric Association 1994, premenstrual dysphoric disorder, PMDD, is listed as an affective disorder, with recognition of this entry as a criteria set and axes provided for further study. This latest placement is being debated by researchers and clinicians who are concerned about categorizing this cohort of women as depressed. Severino 1996. In general, the inclusion of PMDD in the main body of DSM-4 is seen as a step forward in improving the diagnosis and treatment of this disorder. Steiner 1997. Symbolic analysis of culture-bound syndromes provides an understanding not afforded by the biomedical approach alone. Morokov 1991, Severino 1996. Johnson, 1987, argued that premenstrual syndrome addresses the traditional concepts of women and work, reinforcing the cultural double-bind of the imperative for women to be both productive and reproductive. Although women with premenstrual syndrome may be unable to work for a limited period of time, they must still relate to others in a manner that is pleasing, as is culturally mandated, most of the time. Formal evaluations of cognitive functioning in women with premenstrual syndrome indicate no reduction in cognitive performance even though the women reported increased feelings of inadequacy. Morgan et al. 1996. What is new is not the negative view of women as being weak, emotional, and unable to work, which in premenstrual syndrome is captured in the premenstrual phase, but rather the positive view of women as strong, powerful, and capable, which is captured in the non-premenstrual phases of the menstrual cycle. Interpreted literally, premenstrual syndrome allows women access to power most of the time, while invalidating them and their experience part of the time. However, a regularly disabled woman is not seen as a capable woman, and the woman with premenstrual syndrome may be angry or assertive premenstrually and submissive the rest of the time, whether or not appropriate to the circumstances, including oppression. Morokov, 1991, argued that premenstrual syndrome captures our cultural ambiguity regarding women and conception, with symptoms occurring at the time of greatest ambiguity. Psychological aspects of the menstrual cycle 183 about whether the woman has conceived and, more important, whether the woman should conceive. Premenstrual syndrome appears to constitute a transitional compromise for a culture in which women's roles have changed and men's roles have not. Studies show that women report more negative symptoms when they believe they are premenstrual than when they are led to believe that they are not premenstrual. A study analyzing women's perception of perimenstrual impairment found that with positive reframing of changes that occur perimenstrually, impairment decreased. Morse 1997. Studies also indicate that women report more premenstrual symptoms when they are aware of the focus of the study than when they are not. Hamilton et al. 1989. These findings substantiate an expectancy component to symptom reporting. This psychosomatic aspect of symptom occurrence may complicate research findings. Mortala 1998. Pathology and the menstrual cycle. Does a unique disorder of primarily psychologic symptoms occurring only premenstrually exist? If so, what is the relationship of it to other psychiatric and medical disorders? Do other psychiatric and medical disorders themselves vary with the menstrual cycle? A brief history of the term premenstrual syndrome is necessary to put into context our modern conceptualization of these questions. When Frank coined the term premenstrual tension in 1931, he distinguished between what he considered to be three different groups of women. The first group had mild symptoms premenstrually, such as fatigue, that he considered to be normal. The second group included women with systemic illnesses that varied with the menstrual cycle. He cited two examples, a patient with catamenial asthma and one with catamenial epilepsy. The third group was a small minority of women who experienced what he called premenstrual tension, a disorder of severe emotional symptoms occurring premenstrually, including suicidally, a personality change, and or reckless behavior for which they later had remorse. Relief of these symptoms occurred with onset of menses. Subsequent writers from the 1930s to the 1950s added progressively more and more symptoms to the list of possible premenstrual tension symptoms, such that by the 1950s it was recommended that any and all symptoms that vary with the menstrual cycle be considered as falling under the rubric of premenstrual tension, including asthma attacks and seizures. Dalton first used Premen 184 Psychological Aspects of Women's Healthcare, 2nd edition Struhl syndrome in medical literature in 1953, a change that emphasized the wide variety of possible symptoms, both physical and psychologic. As all symptoms related to the menstrual cycle became lumped together, a great deal of confusion followed and it became necessary to ask certain questions. Is there really a single premenstrual syndrome, or many? Is progesterone the drug of choice for all cases of premenstrual syndrome, as claimed by Dalton, 1964? Franks, 1931, original delineation of a severe syndrome with primarily psychologic symptoms, distinct from either systemic illnesses varying with the menstrual cycle or normal, mild symptoms, was lost in the confusion. In recent years research has started bring us out of the confusion, and, in the process, has pointed us back toward Frank's forward-looking original impressions. Disorders varying with the menstrual cycle. Dysmenorrhea. Dysmenorrhea is defined as recurrent, catamenial pelvic pain. Primary dysmenorrhea occurs in the absence of discrete pathophysiology and secondary dysmenorrhea occurs in the presence of discrete pathophysiology, including uterine fibromyomas and endometriosis. Now that primary dysmenorrhea is known to be caused by an excess of prostaglandins in the endometrial tissue and is treatable with prostaglandin synthetase inhibitors, it should no longer be considered a manifestation of neurosis or dismissed as just part of being a woman or just a symptom of premenstrual syndrome. Medical disorders. The frequency or intensity of symptoms of a number of medical disorders vary by menstrual cycle phase, including lupus erythematosus, acute intermittent porphyria, herpes genitalis, pneumothorax, and others. M. Jensvold and G. V. Foster, unpublished manuscript, 1984. Among women with migraines, 10%, 70% have migraines occurring regularly during or just before menses. Degra and Damasio 1987, Locken et al. 1997. In a study of asthma, 35% of reproductive-age women with asthma reported that their asthma symptoms worsened just before or at the time of menses. Daily spirometry only confirmed significant deterioration in airway resistance at the time of menses in the group who reported an association of symptoms to the menstrual cycle, Hanley 1981. Psychological aspects of the menstrual cycle. 185 Psychiatric disorders. What evidence indicates that psychiatric disorders vary with the menstrual cycle? A few studies have begun to address this question. Bulimia. In 2 prospective studies of binging behavior in bulimic women, one study found a modest but statistically significant premenstrual exacerbation of binge eating, without an increase in depression, Gladys and Walsh 1987. One prospective study found a significantly increased frequency of binge episodes in the luteal phase, Price et al. 1987. A third study analyzing the clinical similarities of PMDD and bulimia found a comorbidity of 16.6% for PMDD and bulimia and only a 2.3% comorbidity for women not affected by PMDD. The researchers also found a common personality dimension, harm avoidance, to be more frequent in women with PMDD and bulimia, suggesting that similarities exist between the two disorders. Vary et al. 1997. A report of 2 patients contrasted one whose bulimic binging increased regularly premenstrually and one whose bulimic binging showed no association to the menstrual cycle, McDaniel 1989. Panic disorder. In 3 studies of panic disorder, 40%, 90% of the women studied retrospectively reported worsening of panic or anxiety premenstrually. Using prospective ratings, 2 of the studies found no evidence of menstrual cycle-related changes in panic, Cook et al. 1990, Stein et al. 1989, but the third found significant worsening in intensity of full situation panic attacks, with other parameters not showing significant variation. The authors concluded that actual fluctuations in anxiety symptoms across the menstrual cycle were rather small. Cameron et al. 1988. Yonkers' 1997a analysis of PMDD and panic concluded that women with premenstrual syndrome experienced increased occurrence of panic attacks and that biological mechanisms or vulnerabilities are shared in women with panic and women with PMDD. P62, affective disorders. A great deal of evidence links affective symptoms and the menstrual cycle. Overlap exists among symptoms reported by women with PMDD and those reported by women with other affective disorders. Yonkers 1997b. Prevalence rates for premenstrual depression were found to be 65% by several groups examining prevalence in patients with current or lifetime diagnoses of affective disorder. In patients complaining of premenstrual depression, 39% exhibited depression through daily ratings and 36% showed intermittent depression throughout the cycle. Macmillan and Pill 186 Psychological Aspects of Women's Healthcare, 2nd edition 1987. Patients who pursued treatment for premenstrual depression were found to be at high risk for suicide attempts because of the increased severity and intensity of symptoms. Stout et al. 1986. Additionally, one recent study of 113 women found a correlation between premenstrual suicide attempts and a history of previous psychiatric illness. Baca et al. 1998. Lifetime diagnoses of major depressive disorder were found to have prevalence rates of 57%, 100% among women in 5 different samples who suffered from premenstrual depression. Complaints of premenstrual depression have been found to have predictive value in terms of future depression. Grays et al. 1990. Halbreich, 1997, has suggested that premenstrual syndrome symptoms constitute an expression of vulnerability traits, P20, that may also indicate traits for depression or anxiety. Data suggest a susceptibility to psychopathologic cycling among women. Most people with rapid cycling bipolar disorder are women, where et al. 1988. The same is true of those with seasonal affective disorder. However, the mood disorders of only a few of these women cycle in relation to the menstrual cycle. Conrad and Hamilton 1986, Koukopoulos et al. 1985, Ware et al. 1988. The reasons for women's increased susceptibility to cyclic disorders are not known, and the mechanisms of the interrelationships between mood and cycling are not well understood. Post-traumatic stress disorder and dissociative disorders. SOMEV evidence exists of a menstrual cycle, related pattern in post-traumatic symptoms and dissociative disorders in some women who present complaining of premenstrual syndrome. Jensvold et al. 1989. Premenstrual syndrome and premenstrual dysphoric disorder. 2 definitions of premenstrual syndrome are currently in use in the research and clinical literature, a common definition and PMDD. A third definition, LLPDD, was briefly in use while the disorder was listed in the appendix to DSM-3R. For the purposes of this chapter, we will indicate the name used in the cited report with an understanding that LLPDD and PMDD are very similar. The definition of PMDD includes one more symptom than that of LLPDD, a subjective sense of being overwhelmed or out of control. Severino 1996. The common definition mentioned above requires a combination of common psychologic and physical symptoms that occur premenstrually and are absent during the follicular phase. Commonly cited psychologic symptoms include sadness, irritability, and tension or anxiety. Psychological aspects of the menstrual cycle 187 and commonly cited physical symptoms include bloating and breast tenderness. PMDD, in contrast, has been used to date only in some of the most recent mental health literature, as would be expected, because it is a recently available diagnosis. It emphasizes psychologic symptoms. Physical symptoms are optional, includes a severity criterion, and requires confirmation on daily perspective ratings. See Figure 9-3. Figure 9-3. Meeting diagnostic criteria by self-report and daily ratings. Is there a unique disorder, PMDD, that can be distinguished from other disorders? Women can be identified who report severe symptoms, including occupational or social impairment, that occur only premenstrually, who are confirmed to fulfill PMDD criteria on prospective ratings, and who do not seem to have another current psychiatric illness. Steiner 1997. Recent placement of PMDD in the main body of DSM-4 indicates its reliability and validity as a diagnostic category. Based on phenomenology and course, studies 188 psychological aspects of women's healthcare, second edition support classification as a depressive mood disorder. Whether PMDD, as conceptualized, is the optimal taxonomy continues to be explored. Halbreich et al. 1983, Hamilton and Gallant 1990, Spitzer et al. 1989. Certainly, rigor is needed in our categorization so that research and treatment may be most appropriately directed. What is the relationship of PMDD to other psychiatric disorders? One of the diagnostic criteria for PMDD is that the symptoms are not attributable to another psychiatric disorder. However, in the presence of another psychiatric disorder, it is hard to know whether the premenstrual symptoms are attributable to that psychiatric disorder. Categorization of PMDD as a mood disorder in DSM-4 is supported by study findings of low serotonin and melatonin metabolism as well as numerous studies reporting symptom improvement with selective serotonin reuptake inhibitors, Perry 1997. In one comparison of PMDD and depression, PMDD is suggested to be an expression of traits indicating vulnerability to depression, Halbreich 1997, whereas another study suggests that biologic cognitive studies and treatment response factors help to differentiate PMDD from other mood disorders, Yonkers 1997b. The true nature of the relationship between concurrent PMDD and other psychiatric disorders remains to be elucidated. Findings in premenstrual syndrome research prevalence of symptoms. Several studies have shown at least 75% of women reporting at least one symptom occurring premenstrually. However, the number of women who report that symptoms are severe or bothersome enough to warrant treatment is much lower. Psychologic symptoms are often reported to be the most distressing. Positive changes also occur premenstrually, Stewart 1989, but are often overlooked. Two studies have examined the prevalence of women who fulfill diagnostic criteria for LLPDD. One study, a community-based survey with prospective ratings, found that 3.4% of reproductive age women reported severe symptoms, R.F. Haskett, unpublished data, May 1987. In the other study, 4.6% of college-age women reported severe symptoms, Rivera-Tovar and Frank 1990, suggesting that 5% of women of reproductive age may meet criteria for LLPDD. A more recent study of women with PMDD also endorsed the 5% figure, Gillard and Hartledge 1997. Prevalence of Axis I and Axis II disorders. Only one study has examined lifetime prevalence of both Axis I and Axis II disorders in women meeting criteria for LLPDD. Depression was found to be more prevalent in psychological aspects of the menstrual cycle 189 women with LLPDD in this study than in those in the community-based epidemiologic catchment area study, although the prevalence of other psychiatric disorders was similar in both studies. Of women meeting LLPDD criteria, 78% had a lifetime history of Axis I disorder, with prior depression being most prevalent. 10% met criteria for Axis II disorders, with avoidant personality being most prevalent, and 20% had current psychiatric disorders despite attempts to exclude women with current psychiatric disorders, Perlstein et al. 1990. In a study in which data were pooled from 5 institutions, Hurt et al. 1992, 670 women who sought treatment for premenstrual syndrome were examined, of whom 39% were found to have only past psychiatric disorders, 27% had a current psychiatric disorder, and 33% had no psychiatric history. The authors concluded that LLPDD was not synonymous with another psychiatric disorder and that past psychiatric history increased the risk of LLPDD. Present psychiatric disorder was not shown to increase the risk of LLPDD over that observed in women with no psychiatric history. The prevalence of LLPDD varied substantially as a function of the four methods of analyzing daily ratings data, Hurt et al. 1992. Hormone studies. Numerous studies have been conducted but have shown no consistent abnormalities in peripheral hormone levels in women with premenstrual syndrome, Rubinow et al. 1988. Some evidence exists of a hormone axis instability, Royburn et al. 1987, and several studies have now shown abnormalities in serotonin metabolism, Ashby et al. 1990, whereas others have linked fluctuating serotonin receptor concentrations with changes in estrogen and progesterone levels, Beagan et al. 1980. Circadian phase shifts may be implicated in some patients, Perry and Ware 1987, Perry et al. 1997. The concept of multiple cyclic change occurring as a diversified, dynamic, time-related process, Halbreich et al. 1988, p.183, is probably more accurate than any hypothesis of unitary abnormalities in accounting for the diversity of symptoms reported with premenstrual syndrome. One recent study found hypothalamic and pituitary hormone differences between women with premenstrual syndrome and control subjects that suggested neurobiologic vulnerability in women who experience premenstrual syndrome symptoms, Rosenstein et al. 1996. A second study found a decrease in premenstrual syndrome symptoms with ovarian suppression, indicating that women with premenstrual syndrome may be experiencing atypical sensitivity to normal hormonal changes, Schmidt et al. 1998. In a recent analysis of existing hormonal studies and treatment modalities, Mordala, 1998, suggested that premenstrual syndrome is the result of a complex interaction between ovarian steroids and neurotransmitters, p. 256. 190 Psychological Aspects of Women's Healthcare, 2nd edition. Methodologic and Political Issues in Premenstrual Syndrome Research. Prospective ratings. The method used to analyze daily ratings greatly affects the percentage of women meeting the diagnostic criteria. Currently, daily ratings are seen as the standard for diagnosis, with negative prospective ratings automatically taking precedence over the woman's positive self-report. Cases with discordant retrospective self-report and prospective ratings should be examined more closely for the presence of any of a number of factors contributing to the discordance. Reasons to trust prospective ratings over self-report are the evidence of misattributions and negative expectancies. However, several reasons exist for not assuming that prospective ratings are necessarily the ultimate conveyor of truth, including the possibility of inadvertently creating false positives or false negatives by setting cutoffs too low or too high, intercycle variability, and evidence that as many men as women fulfill diagnostic criteria for premenstrual syndrome on the basis of prospective ratings, Gallant 1991. Approaches to discordant cases should be individualized. For example, if a psychiatric disorder is present in the follicular phase, treatment of that disorder is indicated. Some evidence indicates that more severe cases show greater concordance in self-report and daily ratings and less severe cases show greater discordance. In one well-designed study, retrospective reports of premenstrual syndrome were predictive of future major depression even in women without a past history of depression and without a family history of depression. Retrospective reports were a better predictor in this study than daily ratings, Grays et al. 1990. Diagnostic options. Official psychiatric diagnostic nomenclature has denoted a unique disorder of primarily psychologic symptoms premenstrually, PMDD. Alternatives to the current denotation are still being debated among clinicians and practitioners. These include a psychiatric disorder with a menstrually related or catamenial pattern, similar to the seasonal pattern denotation in DSM-4, or a category of hormone-related disorders in which male disorders related to hormones could also be denoted. Chasm between research and practice. Current research practices automatically exclude from most premenstrual syndrome research women whose self-report and daily ratings are discordant and women who choose not to comply with 2 months of daily ratings. The diagnosis of PMDD, as currently specified, diagnoses moderate cases women who have impairment psychological aspects of the menstrual cycle 191 premenstrually but who can tolerate and are willing to complete 2 months of ratings prior to treatment. However, clinicians are presented with cases that run the full spectrum of severity. Thus a chasm exists between research, which needs rigorously defined homogeneous patient populations, and clinical needs, with the mandate to help all women who present for help. Political issues. Stotland, unpublished paper, 1991, has pointed out 2 main categories of risks to women from an LLPDD/PMDD diagnosis. The first of these is the risk to all women if common, menstrually related experiences are pathologized. The second risk is that of the impact of a narrowly defined LLPDD on the majority of women who now present for treatment of PMS who would be excluded. To say either that all women who have menstrual cycles have a disorder or that no women who have menstrual cycles have a menstrually related disorder is to minimize the subject and to fail to listen to women's experience. Symptoms are not synonymous with syndromes and must be distinguished. The media often portray as mild or moderate premenstrual syndrome what researchers would call normal, Chrysler and Levy 1990. Concern that women with normal menstrual cycles and minimal or no symptoms will be declared to have disorders is not lessened by the fact that some symptom rating scales still used in the field classify all women as having varying severities of premenstrual syndrome and provide no way of classifying a woman as not having premenstrual syndrome. No other diagnosis requires prospective ratings to confirm the patient's self-report. Mandatory compliance with daily ratings of patients with other disorders has not been studied, Stotland 1991. The assumptions that prospective ratings are always correct and that discordance between prospective ratings and the woman's retrospective self-report automatically invalidates that self-report may be discriminatory. Hormones contribute to disorders or symptoms in men, such as aggressivity, but do not receive attention as such. Law. Use of premenstrual syndrome as a legal defense has succeeded in Canada and England, but this defense has been controversial and generally unsuccessful in the United States and barriers to its successful use seem to be formidable, Severino and Molin 1989. Concern has been expressed that, with its use, all women will be on trial. Numerous questions remain about the implications if premenstrual syndrome is successfully used as a defense. For example, what should be done with the premenstrual syndrome offender who fails or refuses to obtain court-ordered treatment? Is there clear evidence treatment will succeed in light of the enigmatic pathophysiology? 192 Psychological Aspects of Women's Healthcare, 2nd edition. Treatment and the menstrual cycle. Chronotherapy. Chronobiology has been described as the broad spectrum of interacting and interdigitating rhythms that all together comprise the time structure of a living organism. By learning the patterns of biological variations we can compare, correlate, and finally predict their course. This development makes it necessary and possible for physicians to concentrate more closely on the individual needs of their patients through patient monitoring and time-specified medications. Hen 1988, p. 7, studies of the timing of melatonin release in women with PMDD have revealed that nocturnal melatonin concentrations are lower in women with PMDD compared with those in control subjects. Perry 1997. Perry, 1997, suggests that changing sleep cycles and using light therapy can alter melatonin circadian rhythms, thus affecting mood changes. The issue of chronotherapy, or timing therapy, has received much less attention in psychiatry than it deserves. The question arises that if symptoms occur during certain menstrual cycle phases for a particular woman, when should treatment be administered? Should it be administered constantly, throughout the menstrual cycle, periodically, recurrently, example premenstrually only, or at varying times, example with increased dosages premenstrually? The question also arises whether fluctuations in symptoms are caused by physiologic variables, which would occur in any woman with a normal menstrual cycle, pathologic variables, which would occur only in persons with the disorder, or as an interactive process between the two. If the latter, What is the nature of this interaction? Lithium treatment illustrates these concepts well. Individual cases document that for some women with bipolar illness, mood symptoms and lithium levels vary according to menstrual cycle phase. One woman's bipolar illness was in good control when she was receiving a constant dose of lithium except for a premenstrual recurrence of symptoms, at which time her serum lithium levels dropped premenstrually. When her lithium dosage was increased premenstrually, her serum levels remained constant with good control of symptoms. Conrad and Hamilton 1986. In another case, a woman with bipolar illness had regular recurrence of hypomania earlier in the cycle, depression later in the cycle, and symptomatic relief with onset of menses. Her lithium levels were lowest when she was hypomanic, highest when she was to psychological aspects of the menstrual cycle 193 pressed, and intermediate with euthymic mood, Koukopoulos et al. 1985. Do physiologic factors account for these changes in lithium levels? A study of lithium levels in regularly menstruating women found that serum lithium levels following administration of a single dose of lithium were identical regardless of the phase of the menstrual cycle and regardless of whether the women were receiving oral contraceptive medication, Chamberlain et al. 1990. This finding indicates that physiologic factors in the normal menstrual cycle do not account for menstrual cycle-related changes in lithium levels and that these changes are probably more related to changes in pathology, i.e., manic or depressive, rather than luteal or follicular. In a study of 54 persons with rapid cycling bipolar illness, 92% were women, but none was found to switch moods in relation to the menstrual cycle, highlighting the fact that not all women with bipolar illness cycle in relation to the menstrual cycle, where et al. 1988. Also, Haydo-Tani et al. 1983, found an association between mood and the menstrual cycle in bipolar patients but found that mood was sometimes slightly out of synchronization with the menstrual cycle. This raises the question of how mood and the menstrual cycle are really associated. Why does bipolar illness entrain to the menstrual cycle in some regularly menstruating women but not all? What accounts for cycling that moves in and out of synchronization with the menstrual cycle? What is the role of oral contraceptive medication in entraining pathology to the menstrual cycle or in freeing it from entrainment? The data raise as many questions as they answer. Interaction between endogenous hormones and psychotropic medications. Women take more medications, including more psychotropic medications, than do men, but even when corrected for the number of medications taken, women have more adverse effects to medications than do men. Almost certainly one of the contributing factors to this is a lack of attention to the menstrual cycle. By not taking the menstrual cycle into account, the clinician risks either overtreating or undertreating the patient. If the phase of the menstrual cycle is not considered, cycle-dependent symptoms may be misinterpreted as side effects or ineffectiveness of the medication. Clinically significant side effects in relation to gender or hormone levels are known for mood stabilizers, lithium, antidopaminergic and antipsychotic drugs, anticonvulsants, example phenytoin, some benzodiazepines, example diazepam, propranolol, and alcohol, Hamilton 1991. One patient's premenstrual depression was documented to require a varying dose of antidepressant. 194 Psychological Aspects of Women's Healthcare, 2nd edition medication throughout the cycle. She tolerated a constant low dose of tricyclic antidepressant well, but this dose was only partially effective. A constant higher dose was effective for premenstrual symptoms, but was not tolerated in the follicular phase. Finally, a varying dosage of tricyclic antidepressant, with higher dosage premenstrually, was both effective and well tolerated, Jensvold et al. 1992. One study of the effects of benzodiazepines over the menstrual cycle in women with premenstrual syndrome found a decreased sensitivity at the gamma-aminobutyric acid/benzodiazepine receptor complex, indicating a decreased treatment effectiveness that was especially marked during the third week of the menstrual cycle, Sundstrom et al. 1997. Women with catamenial epilepsy had a marked decrease in phenytoin during menses compared with control subjects and with women with non-catamenial epilepsy. Recurrent premenstrual failure of migraine prophylaxis was associated with lower steady-state serum levels of propranolol during menses. Some drugs do not show clearly significant menstrual cycle effects, including salicylates, aminopyrine, nitrazepam, and paracetamol. Without systematic monitoring of drug-hormone interactions, the drug differences that have come to our attention can be considered to be the tip of the iceberg. Future studies will find that some drugs do not show any substantial menstrual cycle-related effects, but we do not yet know which drugs those are. When menstrual cycle-related effects have been found, they often occur in subgroups of women, example those receiving lithium or phenytoin, with reported effects generally tending toward increased clearance premenstrually, Hamilton 1991. Sex steroid hormones can have differential effects on partial pathways for various metabolites. Competition between drugs and hormones for the same metabolic sites may account for some of the differences in metabolic rates, Hamilton 1991, in women as compared with men or over time. Inter-individual differences in the use of alternative metabolic pathways or in the levels of or sensitivity to endogenous sex steroid hormones may explain why only some women experience menstrual cycle-related effects, Hamilton 1991. Interaction between exogenous hormones and psychotropic medications. Oral contraceptives. In a review of interactions between oral contraceptives and other medications, Teichmann, 1990, concluded that medications showing clinically psychological aspects of the menstrual cycle. 195 significant interactions included antidepressant medications, antihypertensives, insulin, synthetic glucocorticoids, theophylline, and caffeine. The Medical Drug Reference, Ellsworth et al. 1997, lists clinically significant interactions between oral contraceptives or estrogens and 16 medication classifications. Oral contraceptives tend to increase clearance of drugs metabolized by glucuronidation, example some benzodiazepines, and decrease clearance of drugs metabolized by oxidative pathways, including the P450 cytochrome oxidase system, example imipramine, diazepam, caffeine, and chlordiazepoxide. Of women of reproductive age in the United States, 27% receive oral contraceptive medication, which means that a number of women presenting to psychiatrists are using or will use chemical contraceptive agents, Hatcher et al. 1994. Psychiatric side effects of oral contraceptives were more frequent in older, higher dosage preparations, but mood effects have been observed in the lower dose preparations, and we have observed these low-dose oral contraceptive mood effects to be responsive to antidepressant medication. Oral contraceptives may entrain psychopathology to the menstrual cycle in some cases or free symptoms from entrainment to the menstrual cycle in others. In one large study, 276 oral contraceptive users were compared with 276 non-users. Research indicated that oral contraceptive users experienced longer patterns of perimenstrual negative mood than did non-users, Bancroft and Rennie 1993. In some cases, a woman may need to stop hormonal therapy in order to know what role the oral contraceptive is playing in her symptoms, whether exacerbating them, ameliorating them, or having no effect at all. Contraceptive medications now available to women in the United States include combination medication, estrogen and progestogen for 21 days followed by a hormone-free week, the most commonly used preparations, sequential medication, including triphasic pills, varying dosages of hormone sequentially, also commonly used, many-dose progesterone, daily oral micronized progesterone, which has fewer side effects but is less commonly used because of its slightly decreased effectiveness as a contraceptive agent, long-acting subcutaneous progesterone injection, Depo-Provera, and long-acting subcutaneous progesterone implant, Norplant. Other long-acting progesterone derivatives and chemical contraceptive agents are being tested and used in Europe, Scandinavia, and elsewhere, Hatcher et al. 1994. Postmenopausal hormone replacement therapy. In a survey study, 32% of postmenopausal women were found to use hormone replacement therapy, HRT, Harris et al. 1990. HRT differs from oral contraceptives in that it uses natural conjugated estrogens that do not affect 196 psychological aspects of women's health care, second edition the cytochrome P450 oxidase system, whereas oral contraceptives use synthetic estrogens, example ethinyl estradiol, that do affect that system. Also, the dosages of hormones are about 1.1 to 2.5 times higher in oral contraceptives than in HRT. Hormone replacement therapy can cause mood effects, with progesterone thought to be responsible for recurrent dysphoric moods associated with HRT, Mugos et al. 1986. However, estrogen has been shown to trigger rapid mood cycling in vulnerable women, Oppenheim 1984. Consequently, women with histories of affective disorders should be monitored closely for mood effects when HRT is started. Postmenopausal hormone therapy is known to cause symptoms similar to those of premenstrual syndrome in some women, Mugos et al. 1986, in effect, an iatrogenic premenstrual syndrome. This leads some women to present to psychiatrists for treatment of new onset or recurrent premenstrual-like symptoms or mood symptoms. We have found that symptoms can be minimized by decreasing the hormone dose or changing the timing, for example, changing the 10-day interval of progestogen from once monthly to once every 3 months. If these interventions do not provide sufficient relief, then stopping HRT or adding a psychotropic agent should be considered. Gonadotropin-releasing hormone agonists. Potent agonists bind powerfully to GnRH receptors at the level of the pituitary, thus blocking the pulsatile action of GnRH. After transiently increasing release of luteinizing hormone and follicle-stimulating hormone from the pituitary, GnRH agonists then paradoxically block the pituitary's normal response to GnRH, thus affecting a chemical oophorectomy. This therapy must be used with extreme caution. Use of GnRH for endometriosis and other conditions is growing. 3 forms of GnRH agonists are now available: intramuscular, intranasal, and depot GnRH. The forms vary with respect to ease of administration and in how much control one has over the administered dose. Estrogen deficiency, related symptoms, including hot flashes and osteoporosis, are considerations. GnRH agonists have been reported to help severe premenstrual symptoms, although some women experience transient worsening during the first month of treatment. One woman's first hypomanic episode was precipitated by GnRH. Some women's mood disorders, previously linked to the menstrual cycle, have become unlinked from cycle on GnRH. A recent study at the National Institute of Mental Health concluded that GnRH administration successfully improved the symptoms of premenstrual syndrome. Symptoms. Psychological aspects of the menstrual cycle. 197 recurred with administration of estradiol and progesterone, indicating that the interruption of the body's natural hormonal changes can improve premenstrual syndrome symptoms. Schmidt et al. 1998. Gynecologic versus psychotropic medications for the treatment of premenstrual symptoms. Because the hypothalamic, pituitary, ovarian axis is an interconnected feedback loop, interventions at different levels of the feedback loop may, at least theoretically, affect a particular targeted menstrually related symptom. Gynecologic treatments. Several methods that prevent ovulation have been tried for the relief of premenstrual syndrome. Surgical ovarectomy, Casson et al. 1990, and chemical ovarectomy using GnRH, Hamarbach and Backstrom 1988, Schmidt et al. 1998, appear to provide lasting relief of severe premenstrual psychologic and physical symptoms, although their use is inappropriate for most patients with premenstrual syndrome and requires psychiatric screening and long-term follow-up studies. Hysterectomy without ovarectomy provides more variable results, as would be expected, because it removes menses, the external time cue, but the hormonal cycle remains intact. Danazol, an androgenic agent, inhibits ovulation and provides relief for some premenstrual symptoms, particularly mastalgia, but appears to cause or exacerbate depression and irritability in some patients. Oral contraceptives appear to worsen premenstrual syndrome in some women, have no effect on others, and perhaps ameliorate symptoms in others. Progesterone as a treatment for premenstrual syndrome is now essentially disproven. Numerous double-blind, controlled studies have failed to show its superiority over placebo, HERT et al. 1992, and a progesterone antagonist study disproved the hypothesis that luteal-phase progesterone plays a role in causing catamenial mood symptoms, Schmidt et al. 1991. Psychotropic agents. A study of fluoxetine treatment for LLPDD found that premenstrual physical symptoms as well as psychologic symptoms were helped by fluoxetine, Stone et al. 1991. Further studies of serotonin reuptake inhibitors such as fluoxetine and sertraline have indicated that both symptomatic and functional impairment decrease with treatment, Yonkers et al. 1997. Other studies have 198 psychological aspects of women's health care, second edition, shown efficacy of both alprazolam and desipramine treatment over placebo for LLPDD/PMDD. Non-biologic treatments of menstrually related symptoms. Dynamic issues regarding the menstrual cycle and what it means to the individual woman are important in some cases. Menstrual cyclicity can have an indirect impact on psychotherapy as well, with some psychotherapeutic work being more possible, more necessary, or more or less effective during certain phases. One example is the woman with state-dependent, recurrent premenstrual flashbacks of earlier trauma, Jensvold et al. 1989. If expectancies or misattributions are thought to play a significant role with a particular patient, then cognitive therapy techniques, interpersonal therapy, or feminist therapy, which examines the woman in her environmental context, including societal influences, rather than narrowly focusing on intrapsychic factors, may be helpful. Support groups may also play a useful role in treatment because group members recognize dysfunctional behavioral or emotional patterns or expectancies and develop increased insight and confidence and improved coping. Conclusion. It seems now that Frank was forward-looking in 1931 in distinguishing among women with a unique psychologic disorder occurring premenstrually, women with mild symptoms, and women whose systemic illnesses varied with the menstrual cycle. Excessive lumping together of disorders over subsequent decades has caused confusion among researchers, clinicians, patients, and the public. State-of-the-art research is now sorting out various threads and addressing questions implied by Frank's clinical observation. Is there validity to a single diagnostic category describing psychologic symptoms occurring only premenstrually? Do other psychiatric disorders vary with the menstrual cycle? How can one address real problems without stigmatizing women and without playing into the already excessively negative views of the menstrual cycle and of women? What are the roles of gynecologic agents and of psychotropic agents in treating psychiatric disorders related to the menstrual cycle? Psychiatric symptoms and the menstrual cycle represent a confluence in which mind, body issues can be addressed in interesting and important ways, with the potential for much to be learned about chronovial psychological aspects of the menstrual cycle. 199 OGI, brain, endocrine interactions, and cultural overlay, as well as the promise of improving the health of women patients. References: American Psychiatric Association, Diagnostic and Statistical Manual of Mental Disorders, 3rd edition revised. Washington, D.C., American Psychiatric Association, 1987. American Psychiatric Association, Diagnostic and Statistical Manual of Mental Disorders, 4th edition. Washington, D.C., American Psychiatric Association, 1994. Ashby C., Carr L., Cook C., et al., Alteration of 5-HT uptake by plasma fractions in the premenstrual syndrome. J. Neural Transm. Gen. Sec. 79:41, 50, 1990. Baca G., Sanchez A., Gonzalez P., et al., Menstrual Cycle and Profiles of Suicidal Behavior. Acta Psychiatriscand 9732, 35, 1998. Bancroft J., Rennie D., The Impact of Oral Contraceptives on the Experience of Perimenstrual Mood, Clumsiness, Food Craving, and Other Symptoms. J. Psychosome Res. 37:195, 202, 1993 Biegan A., Berkovitz H., Samuel D., serotonin receptor concentration during the estrous cycle in the rat. Brain Res 187:221, 225, 1980 Cameron O., Kutesh D., McPhee K., et al., Menstrual Fluctuation in the Symptoms of Panic Anxiety. J. Effect Disorder 15:169, 174, 1988 Kassan P., Han P., Vug D., et al., Lasting Response to Ovarectomy in Severe Intractable Premenstrual Syndrome. AMJ Obstet Gynecol 162:99, 105, 1990 Chamberlain S., Han P., Kassan P., et al., Effect of Menstrual Cycle Phase and Oral Contraceptive Use on Serum Lithium Levels after a Loading Dose of Lithium in Normal Women. AMJ Psychiatry 147:907, 909, 1990 Chrysler J., Lovey K., The Media Construct a Menstrual Monster, a content analysis of PMS articles in the popular press. Women Health 16:89, 104, 1990 Conrad C., Hamilton J., Recurrent Premenstrual Decline in Serum Lithium Concentration, Clinical Correlates and Treatment Implications. JAM Academic Clin Psychiatry 26:852 853, 1986 Cook B., Noyes R., Garvey M., et al., Anxiety and the Menstrual Cycle in Panic Disorder. J. Effect Disorder 19:221, 226, 1990 Dalton K., The Premenstrual Syndrome. Springfield, Illinois, Charles C. Thomas, 1964 Deutsch H., The Psychology of Women, A Psychoanalytic Interpretation. New York, Gruen and Stratton, 1944 Degra K., Damasio H., Menstrual Migraine, Differential Diagnosis, Evaluation, and Treatment. Clin Obstet Gynecol 30:417, 430, 1987 Ellsworth A., Dugdale D., Witt D., et al., Medical Drug Reference. St. Louis, Missouri, Mosby Yearbook, 1997 200 Psychological Aspects of Women's Healthcare, 2nd edition Frank R., The Hormonal Causes of Premenstrual Tension. Arch Neurol Psychiatry 26:1053, 1057, 1931 Gallant S., The Role of Psychological Factors in the Experience of Premenstrual Symptoms. Presented at the Society for Menstrual Cycle Research Biannual Meeting, Seattle, Washington, March 1991 Gillert S., Hartledge S., A Design for Studying the DSM-4 Research Criteria of Premenstrual Dysphoric Disorder. J. Psychosome Obstet Gynecol 1836, 44, 1997 Gladys M., Walsh B., Premenstrual Exacerbation of Binge Eating in Bulimia. AMJ Psychiatry 144:1592, 1595, 1987 Grays K., Ney J., Endicott J., Premenstrual Depression Predicts Future Major Depressive Disorder. Acta Psychiatricand 81:201, 205, 1990 Haney, ed. Chronopharmacology of Reversible Airways Obstruction. Frankfurt, Germany, University of Munich, 1988 Halbreich U., Premenstrual Dysphoric Disorders, a Diversified Cluster of Vulnerability Traits to Depression. Acta Psychiatricand 95:169, 176, 1997 Halbreich U., Endicott J., Ney J., Premenstrual Depressive Changes, Value of Differentiation. ArchGen Psychiatry 40:535, 542, 1983 Halbreich U., Holzai, Paul L., Premenstrual Changes, Impaired Hormonal Homeostasis. Neurol Clin 6:173, 194, 1988 Hamilton J., Clinical Pharmacology Panel Report, in Forging a Women's Health Research Agenda, Conference Proceedings. Edited by Blumenthal S.J.P., Perry B., Hamilton J., ETAL Washington, D.C., National Women's Health Resource Center, 1991, pp 1-27 Hamilton J.A., Gallant S.J., Debate on Late Luteal Phase Dysphoric Disorder. AMJ Psychiatry 147:1106, 1990 Hamilton J., Gallant S., Lloyd C., Evidence for a menstrual-linked artifact in determining rates of depression. J. Nerve Mentis 1779:359, 365, 1989 Hamarbach S., Backstrom T., Induced anovulation as treatment of premenstrual tension syndrome. Acta Obstet Gynecol Scan 67:159, 166, 1988 Hanley S., Asthma Variation with Menstruation. BRJ Dischest 75:306, 308, 1981 Harris R., Laws A., Reddy V., et al., Are Women Using Postmenopausal Estrogens? A Community Survey. AMJ Public Health 80:1266, 1268, 1990 Hatcher R., Trussell J., Stewart F., et al., Contraceptive Technology. New York, Irvington, 1994 Haidotani N., Kitayama I., Inuke, et al., Psychoneuroendocrine Studies of Recurrent Psychoses, in Neurobiology of Periodic Psychoses. Edited by Haidotani N., Nomura J. Tokyo, Japan, Igakushoin, 1983, pp 77-92 Hurt S., Schnur P., Severino S., et al., Late Luteal Phase Dysphoric Disorder in 670 Women. AMJ Psychiatry 149:525, 530, 1992 Psychological Aspects of the Menstrual Cycle 201 Jensvold M., Muller K., Putnam F., et al., Abuse and PTSD in PMS Patients and Controls. Presented at the International Society of Psychosomatic Obstetrics and Gynecology Biannual Meeting, Amsterdam, Netherlands, May 1989 Jensvold M.F., Reed K., Jarrett D.B., et al., Menstrual Cycle, Related Depressive Symptoms Treated with Variable Antidepressant Dosage, a Case Report and Case Series. Journal of Women's Health 1:109, 115, 1992 Johnson T., Premenstrual Syndrome as a Western Culture-Specific Disorder. Culture, Medicine, and Psychiatry 11:337, 356, 1987 Kawakami M., Arita J., Yoshida E., Loss of estrogen-induced daily surges of prolactin and gonadotropins by suprachiasmatic nucleus lesions in overectomized rats. Endocrinology 106:1087, 1092, 1980 King C., Parallels between neurasthenia and premenstrual syndrome. Women Health 15:1, 23, 1989 Kinney E., Trotman J., Gold J., et al., Underrepresentation of Women in New Drug Trials. And in turn Med 95:495, 499, 1981 Kukopilos A., Mina G., Muller-Erlinghausen B., The Influence of Mania and Depression on the Pharmacokinetics of Lithium, a longitudinal single-case study. J. Effect Disorder 8:159, 166, 1985 Locken C., Holm J., Myers T., The Menstrual Cycle and Migraine, a time series analysis of 20 women migraineurs. Headache 37:235, 239, 1997 Mugos A., Brinkat M., Sta J., Treatment of the Premenstrual Syndrome by Subcutaneous Estradiol Implants and Cyclical Oral Norethisterone, Placebo-Controlled Study. BMJ 292:1629, 1633, 1986 Martin E., The Woman in the Body. Boston Mott, Beacon Press, 1987 McClintock M., Estrus Synchrony, Modulation of Ovarian Cycle Length by Female Pheromones. Physiology 32:701, 705, 1984 McDaniel W., Premenstrual Exacerbation of Bulimia, Letter. AMJ Psychiatry 146:807 808, 1989 McEwen B., Basic Research Perspective, Ovarian Hormone Influence on Brain Neurochemical Functions, in the Premenstrual Syndromes. Edited by Guys L.H. New York, Churchill Livingstone, 1988, pp 21-33 Macmillan M., Hill R. Premenstrual depression, a distinct entity. J. Abnorm Cycle 96:149, 154, 1987 Morgan M., Rapkin A., Delia L., et al., Cognitive Functioning in Premenstrual Syndrome. Obstet-Gynecol 88:961, 966, 1996 Morokov P., Premenstrual Syndrome, Representation of a Cultural Conflict. Washington, D.C., Society for Behavioral Medicine, 1991 Morse G., Effect of Positive Reframing and Social Support on Perception of Perimenstrual Changes Among Women with Premenstrual Syndrome. Healthcare Women in 18:157, 193, 1997 202 Psychological Aspects of Women's Healthcare, 2nd edition Mortala J., Premenstrual Syndrome, Pathophysiologic Considerations. An English J. Met 338:256, 257, 1998 Oppenheim G., A Case of Rapid Mood Cycling with Estrogen, Implications for Therapy. J. Clin Psychiatry 4534, 1984 Perry B., Psychobiology of Premenstrual Dysphoric Disorder. Semin Reprod Endocrinol 15:55, 68, 1997 Perry B., Ware T., Therapeutic Effect of Sleep Deprivation in Patients with Premenstrual Syndrome. AMJ Psychiatry 144:808, 810, 1987 Perry B., Verga S., Mustofi N., et al., Plasma Melatonin Circadian Rhythms During the Menstrual Cycle and After Light Therapy in Premenstrual Dysphoric Disorder and Normal Control Subjects. J. Biorhythms 12:47, 64, 1997 Perlstein T., Frank E., Rivera Tovar A., et al., Prevalence of Axis I and Axis II Disorders in Women with Late Luteal Phase Dysphoric Disorder. J. Effect Disorder 20:129, 134, 1990 Price W., Turam M., DiMarzio L., Premenstrual Exacerbation of Bulimia. Psychosomatics 28:378, 380, 1987 Rivera Tovar A., Frank E., Late Luteal Phase Dysphoric Disorder in Young Women. AMJ Psychiatry 147:1634, 1636, 1990 Rosenstein D., Calogaras K., Colafute M., et al., Peripheral Measures of Arginine Vasopressin, Atrial Natriuretic Peptide and Adrenocorticotropic Hormone in Premenstrual Syndrome. Psychoneuroendocrinology 21:347, 359, 1996 Royburn P., Rubinow D., Hoban C., et al., TSH and prolactin responses to TRH in patients with premenstrual syndrome. AMJ Psychiatry 144:480, 484, 1987 Rubinow D., Hoban C., Grover G., et al., Changes in Plasma Hormones Across the Menstrual Cycle in Patients with Menstrually Related Mood Disorder and in Control Subjects. AMJ Obstet-Gynecol 158:5, 11, 1988 Schmidt P., Neiman L., Grover G., et al., Lack of Effect of Induced Menses on Symptoms in Women with Premenstrual Syndrome. An English J. Met 324:1174, 1179, 1991 Schmidt P., Neiman L., Donacia M., et al., Differential Behavioral Effects of Gonadal Steroids in Women with and in those without premenstrual syndrome. An English J. Met 338:209, 216, 1998 Severino S., Premenstrual Dysphoric Disorder, Controversies Surrounding the Diagnosis. Harv Rev Psychiatry 3:293, 295, 1996 Severino S., Molan M., Premenstrual Syndrome, A Clinician's Guide. New York, Guilford, 1989 Sparoff L., Glass R., Kays N., Clinical Gynecologic Endocrinology and Infertility. Baltimore MD, Williams, and Wilkins, 1982 Spitzer R.L., Severino S.K., Williams J.B.W., et al., Late Luteal Phase Dysphoric Disorder and DSM-3 RAMJ Psychiatry 146:892, 897, 1989 Psychological Aspects of the Menstrual Cycle 203 Stein M., Schmidt P., Rubinow D., et al., Panic Disorder and the Menstrual Cycle, Panic Disorder Patients, Healthy Control Subjects, and Patients with Premenstrual Syndrome. AMJ Psychiatry 146:1299, 1303, 1989 Steiner M., Premenstrual Syndromes. Anu Rev Med 48:447, 455, 1997 Stewart D., Positive Changes in the Premenstrual Period. Acta Psychiatry Scan 79:400 405, 1989 Stone A., Perlstein T., Brown W., Fluoxetine in the Treatment of Late Luteal Phase Dysphoric Disorder. J. Clin Psychiatry 52:290, 293, 1991 Stout A., Steege J., Blazer D., et al., Comparison of Lifetime Psychiatric Diagnosis in PMS Clinic and Community Samples. J. Nerve Mentis 174:517, 522, 1986 Sullivan G., Lukoff D., Sexual Side Effects of Antipsychotic Medication, Evaluation and Interventions. Hospital and Community Psychiatry 41:1238, 1241, 1990 Sundstrom I., Ashbrook D., Backstrom T., Reduced Benzodiazepine Sensitivity in Patients with Premenstrual Syndrome, a Pilot Study. Psychoneuroendocrinology 22:25, 38, 1997 Teichmann A., Influence of Oral Contraceptives on Drug Therapy. AMJ Obstet Gynecol 163:2208, 2213, 1990 Varie, Napi R., Valero E., et al., Premenstrual Dysphoric Disorder and Eating Disorders. Cephalalgia 17, Supple 2025, 28, 1997 Ware T., Sack D., Rosenthal N., et al., Rapid Cycling Affective Disorder, Contributing Factors and Treatment Responses in 51 Patients. AMJ Psychiatry 145:179, 184, 1988 Yonkers K., Anxiety Symptoms and Anxiety Disorders, How Are They Related to Premenstrual Disorder? J. Clin Psychiatry 58, Supple 62, 69, 1997 A Yonkers K., The Association Between Premenstrual Dysphoric Disorder and Other Mood Disorders. J. Clin Psychiatry 58, Supple 19, 25, 1997 B. Yonkers K., Halbreich U., Freeman E., et al., Symptomatic Improvement of Premenstrual Dysphoric Disorder with Sertraline Treatment, a randomized controlled trial. Sertraline Premenstrual Dysphoric Collaborative Study Group. JAMA 278:983, 988, 1997 This page intentionally left blank 10 Infertility and the New Reproductive Technologies Jennifer I. Downey, MD. Infertility, defined as 1 year or more of unprotected coitus without pregnancy, is a common health problem. Medical authorities such as Sparoff et al., 1994, estimated that 10%, 15% of couples in the reproductive age group are affected by infertility. The only population-based survey of infertility in women, the National Survey of Family Growth, found in 1988 that the proportion of those who were infertile was 18% among childless couples in which the wife was 15 to 44 years of age, Mosier and Pratt 1990. The demand for infertility treatment is growing because of postponed childbearing, increases in the proportion of infertile couples seeking care, the shrinking supply of adoptable infants, new techniques for treating infertile couples, and heightened public awareness of these treatments. In the past, most infertility problems were attributed to women. In reality, 40%, 50% of cases are wholly or in part due to a male factor, Jaffe and Jewell-Wiz 1991. Psychologic Effects of and Adjustment to Infertility Menning, 1980, proposed that infertility investigation and treatment bring on a life crisis because infertility poses a threat that is not solvable in the immediate future and that may tax the couple's existing problem-solving resources, threaten their achievement of important life goals, and awaken unresolved key difficulties from the past. She has described a series of feelings experienced by many couples, from surprise to denial, anger, isolation, guilt. 205-206 Psychological Aspects of Women's Healthcare, 2nd edition, and grief, followed by resolution if the feelings are worked through and overcome. Some couples may fail to resolve the problem and continue to seek new treatments, even after every potentially beneficial method has been tried. This model of infertility as a life crisis for many couples is helpful because it enables the clinician to think about the problem without pathologizing it and to organize data by phase in the process of resolving the problem. The impact of infertility on marriage appears to vary greatly. It is unknown at present which couples are at risk for marital difficulties when facing involuntary childlessness. Cook et al., 1989, found that 71% of women participants reported that infertility had affected their marriage, but among those affected, the proportion of women who felt this impact to be positive was similar to the proportion who felt it be negative. In some cases, the shared stress of infertility may strengthen a couple's bond. Medical diagnosis and phase of treatment may also affect the likelihood of harmful marital effects. For example, Connolly et al., 1987, found that marital difficulties were more likely if the cause of infertility was a male factor and that longer duration of treatment was associated with decreased emotional well-being of the couple. When infertility affects a marriage, a key area that often deteriorates is sexual functioning and enjoyment. Negative effects on the sex life of couples have been widely reported, including impotence, anorgasmia, and lessened sexual desire. Berger 1980, Kai 1984, Lalas et al. 1985. Up to 10% of cases of infertility may be partially or completely explained by sexual dysfunctions of the man, such as premature ejaculation and impotence. Siebel and Tamor 1982. Among both women and men, planned intercourse for medical tests, such as the postcoital examination of cervical mucus, has been found to have an adverse impact on sexual functioning. De Vries et al. 1984, Drake and Grunert 1979. Most investigators have found that women tend to be more distressed by infertility than are their male partners. Kai et al., 1981, reported that 57% of women but only 12% of men thought that infertility was the worst thing they had ever had to face in life. McEwen et al., 1987, found that 40% of women but only 13% of men evinced psychologic symptoms of clinical severity and that the women who were most disturbed were younger patients without a clear diagnosis of the infertility problem. This difference in the level of reported distress between men and women is found throughout the phases of infertility evaluation and treatment. Wright et al., 1991, found that at the time of a couple's visit to an infertility clinic, women had significantly more overall psychiatric symptoms, depression, anxiety, and hostility, and reported more stress and less self-esteem than did infertility and the new reproductive technologies. 207 men. Assessing men and women after the failure of a first episode of in vitro fertilization, IVF, treatment. The other end of the spectrum usually reached after years of unsuccessful treatment. Newton et al., 1990, reported that 25% of women experienced mild or more serious depressions, as defined by scores on the Beck Depression Inventory, Beck 1978, of 10 to 18 for mild depression and scores of greater than 18 for serious depression. Only 10% of male participants were depressed, and most of these were only mildly so. Effects on the infertile couple's family and social relationships can be profound. The couple's parents are often eager for grandchildren and apply spoken or unspoken pressure on their grown offspring to reproduce. Cultural and religious affiliations that place a high value on bearing children may increase the infertile couple's sense of failure and public embarrassment. Siblings and friends who have already conceived and born children may be avoided because exposure to them exacerbates the infertile couple's sadness or because they are objects of envy. Because fertility is inevitably linked to sexual function, affected couples may feel embarrassed to reveal their problem or to have others allude to it. A frequent result is social isolation as the couple begins to avoid family gatherings at which their childless state may be mentioned and other social events at which pregnant women and small children may be present. The financial burden of infertility can be considerable. Because of the ambiguous status of infertility as a medical problem, government-sponsored medical insurance programs such as Medicaid usually do not cover infertility treatment. Private insurance may reimburse only part of it. For example, treatments with IVF which currently cost between $8,000 and $12,000 per cycle in the United States are usually not covered. Adoption is also expensive. Legal and other fees often average above $20,000 and may be considerably more if the adoption is privately arranged. As a result, infertility treatment is usually available only to couples of at least middle-class financial status, and couples undergoing treatment may make significant financial sacrifices such as foregoing vacations and using the money they had saved for a down payment on a house. Months and sometimes years of infertility treatments affect patients' views of reality in sometimes subtle ways. Commonly, couples may become so focused on pregnancy as the concrete solution to their dilemma that they develop the attitude that all their life problems will be resolved if pregnancy occurs. Such patients can be particularly resistant to psychiatric interventions when needed because they believe that pregnancy is the only treatment necessary for whatever is bothering them. 208 Psychological Aspects of Women's Healthcare, 2nd edition. Studies on the psychologic sequelae of successful fertility treatment are limited, but clearly the consequences can be deleterious. Pregnancy may be unexpectedly uncomfortable and fraught with excessive anxiety. Shapiro 1986. Parenthood may not have been anticipated in a realistic way. Use of the new reproductive technologies is associated with an increased incidence of multiple births, which carry their own risks of physical and psychologic morbidity. Athia and Downey 1992. These pregnancies are often complicated, with treatment requiring months of bed rest. Once the babies are born, the parents find that having more than one infant to care for can be physically, emotionally, and financially overwhelming. Garrel et al., 1997, in a follow-up study of mothers with triplets, found that at 4 years after delivery all of the mothers were distressed and fatigued and that a significant minority regretted having triplets, were depressed, and were taking antidepressants. Furthermore, it is unclear whether offspring conceived via infertility treatment grow up unharmed. The secrecy surrounding techniques such as artificial insemination by donor and the uncertainty about parentage that affects all involved parties when gametes are anonymously donated constitute risks to a happy childhood and family life. Sokoloff 1987. A small Australian study, Kovacs et al. 1993, of children aged 6 to 8 years who were conceived by donor insemination showed no abnormal findings on the child behavior checklist. Achenbach 1978, Achenbach and Edelbrock 1983, but little other research has been done. More detailed and extensive studies on the psychologic well-being of children conceived using the new reproductive technologies are desperately needed. Specific infertility interventions and their psychologic effects. Infertility evaluation usually begins with a history taken from the couple, a physical examination of the female partner, and a few basic studies. These include a basal body temperature chart kept by the woman for 1 to 2 months. The temperature is taken each morning before the woman rises and is charted on a graph. Days on which intercourse occurs are also noted. The rationale for this study is that a rise in temperature signals the time of the surge of luteinizing hormone and ovulation, thus indicating the beginning of the woman's fertile period. Other early studies almost invariably include a postcoital examination or a sperm count. For the postcoital examination, a sample of cervical mucus, usually collected within 8 hours of the last intercourse, is infertility, and the new reproductive technologies 209 assessed for its receptivity and for the number of sperm per high-power field that are present and moving. Semen specimens may also be examined to assess the number of motile sperm and the percentage of those sperm that has normal morphology. These early studies may be repeated numerous times in the course of infertility evaluation and treatment, and although simple both in concept and execution, they are associated with psychologic morbidity. The need to take and chart one's temperature daily is a constantly repeated reminder of the couple's failure to conceive and leads in many cases to a loss of spontaneity and enjoyment in sexual intercourse, the timing of which is determined by fertile days on the chart. The postcoital examination also requires scheduled sexual activity and has the additional drawback of symbolically inviting a third person, the physician and/or laboratory technician, as an observer to the sexual act. Under these conditions, the incidence of both female anorgasmia and male impotence increases. Semen specimens usually must be studied within hours after collection, and production of semen by masturbation in a bathroom at the medical facility near the laboratory is often suggested. Under these conditions of intense performance anxiety, a significant number of men have difficulty obtaining the specimen, and the infertility evaluation becomes acutely embarrassing. The female partner's failure to ovulate regularly is a relatively common cause of infertility, occurring in 40% of the cases in which the infertility is attributable to the woman. Treatment consists of one of several hormonal regimens. If the woman does not have ovarian failure, i.e., if she has not already undergone menopause, in which case no hormonal therapy will work, clomiphene, a nonsteroidal drug that blocks estrogen receptors, is usually the first drug used. The psychiatric side effects of this drug include nervousness, insomnia, and depression. Human menopausal gonadotropin preparations by daily injection are often used if clomiphene is ineffective. This treatment is expensive, however, costing several $1,000s per cycle for the drug alone, and is associated with multiple ovulation. 30% or more of pregnancies achieved with the drug are multiple, and 3 or more fetuses are present in 5% of these cases. Ovarian hyperstimulation syndrome is a potentially life-threatening complication of treatment with human menopausal gonadotropins, and close monitoring by a knowledgeable physician is essential. As with clomiphene, ovulation and conception may not occur during the first cycle, in which case repeated cycles become necessary. In some cases, bromocriptine or gonadotropin-releasing hormone administered intravenously with a pump may be used to induce ovulation. See the latest edition of Speroff et al. 1994 210 Psychological Aspects of Women's Healthcare, 2nd edition Clinical Gynecologic Endocrinology and Infertility for additional information. To date, virtually no published reports exist that describe the psychiatric side effects of ovulation-inducing agents. The astute clinician will recognize, however, that hormonal treatments affecting the pituitary axis have the potential for effects on mood and thinking. Furthermore, the associated stresses are significant. These regimens of medication must be taken month after month despite multiple physical side effects, require close medical monitoring, are very expensive, require scheduled intercourse, have health risks, and may produce a multiple pregnancy if conception occurs. Thus, in the usual clinical situation, the couple will show signs of psychiatric distress, but the potential contributing factors to blame will not be immediately evident. If the female partner has normal cervical mucus and appears to ovulate, and the male partner has normal sperm count and morphology, a hysterosalpingogram, radiographic examination of the female reproductive tract using radiopaque dye, and/or laparoscopy, direct visualization of the female reproductive organs performed under anesthesia during which a laparoscope is inserted through a small incision, may be performed to establish whether any anatomic abnormalities exist that might hinder the successful movement of an ovum through the fallopian tubes to the uterus. Such abnormalities include adhesions from previous pelvic surgery or infections, endometriosis from implants of the uterine lining that have seated elsewhere in the reproductive tract, and congenital anomalies such as a bicornuate uterus. Obstruction of the fallopian tubes is a common factor in female infertility, 30%, 50% of cases. Thin adhesions and implants from endometriosis may be removed using the laparoscope. In other cases, hormonal therapy to shrink endometrial implants or surgery to restore the patency of the tubes, tuboplasty, may be attempted. Hormones used to suppress endometriosis include estrogen-progestin combinations, birth control pills, given continuously, medroxyprogesterone acetate, and danazol, an androgenic compound derived from the steroid 17-alpha-ethanyltestosterone. All of these compounds may cause symptoms of depression or emotional lability. The success of tuboplasty, which may require microsurgical techniques, is variable depending largely on the preoperative condition of the tubes, and it cannot be relied on to produce a successful pregnancy. About 5% of cases of infertility are attributed to cervical factors after a series of poor postcoital tests. This type of infertility is sometimes caused by excessively thick cervical mucus, which can be modified by treatment with low-dose estrogen or circumvented by the intrauterine insemination of sperm. In other cases, sperm allergy, on the part of either the male or the female infertility and the new reproductive technologies 211 partner, may be suspected. Interventions have included corticosteroid therapy, use of condoms for periods of time to reduce exposure to semen, and intrauterine inseminations of washed sperm. All have been of equivocal benefit so far. A major contributing factor when postcoital tests are poor is often poor coital technique. A careful sexual history may reveal an impotence problem and that vaginal intercourse may not occur, or that the couple is using vaginal lubricants, which may have a spermicidal effect. Among the assisted reproductive technologies, ART, are IVF and gamete intrafallopian transfer, GIFT, interventions that are generally used after years of unsuccessful infertility treatment. With IVF, the woman is usually treated with ovulation-enhancing drugs and undergoes laparoscopy for the retrieval of eggs. The retrieved eggs are cultured, fertilized in vitro with the man's sperm, and implanted in the uterus. GIFT is a similar technique, except that fertilization takes place in the fallopian tube, into which follicles and sperm have been placed. In zygote intrafallopian transfer, ZIFT, the fertilized egg is returned to the tube. Such treatment is intense and expensive, and success is uncertain. For years, pregnancy rates from a single cycle of IVF have hovered around 15%, a single cycle of GIFT yielded a viable pregnancy about 25% of the time. Society for Assisted Reproductive Technology and the American Fertility Society 1991. Technical advances are beginning to improve these odds, however. Couples who conceive are at high risk of having a multifetal gestation, with its attendant increases in medical risks, rate of pregnancy loss, expense, and difficulties of simultaneously raising more than one child. Couples who fail to conceive after spending years and large amounts of money in a go-for-broke situation are at risk for significant psychologic sequelae. For instance, Newton et al., 1990, reported that both men and women experienced increased depressive and anxiety symptoms and depressive disorders after unsuccessful IVF treatment, and that childless women were at particular risk. The new reproductive technologies acquire an increased degree of psychologic risk when the gametes, sperm or eggs, are donated or a surrogate is involved to carry the pregnancy. Donor insemination, called artificial insemination by donor, is actually not new and is medically very simple to perform. It is also highly successful in producing pregnancy when the female partner's fertility is intact but the male partner has a low sperm count, oligospermia, or no viable sperm, azoospermia. Egg donation is a much newer and more elaborate procedure and involves locating an anonymous donor or a cooperative friend or relative. The donor and the infertile woman are then treated with medications to synchronize their cycles. At the appropriate time, the 212 psychological aspects of women's health care, second edition eggs are removed from the donor using a laparoscope, and an IVF or GIFT procedure is used to fertilize the egg with the male partner's sperm. The infertile woman then carries the pregnancy. In cases where the infertile woman has sufficient eggs but for some reason cannot carry a pregnancy, a reverse of this procedure may be employed and a gestational surrogate may be found to lend her uterus for the duration of the pregnancy. In another variation, donor insemination is used to impregnate the surrogate, who then both contributes the egg and carries the pregnancy to delivery. Oocyte donation was originally used in women of childbearing age who had experienced premature ovarian failure. More recently, it has been employed to impregnate women over 50 years of age who are postmenopausal, Sauer et al. 1995. This is an example of how infertility technology may outstrip an understanding of its consequences. We know that pregnancy for women past menopause has more physical hazards such as hypertension and gestational diabetes, Flamignat and Borini 1995, but the psychologic and social risks to the offspring conceived and to the couple, especially if both members are old, are not well understood. Ethics Committee of the American Society for Reproductive Medicine 1997. After many years, during which treatments for male infertility remain scant, a new technique has recently become available. This procedure, intracytoplasmic sperm injection, ICSI, employs an IVF procedure in which eggs removed from the female partner under laparoscopic visualization are injected with carefully selected sperm. The sperm is delivered inside the cell membrane, thus enhancing chances of successful fertilization. An early report comparing couples who chose ICSI with those who chose donor insemination showed that couples employing ICSI did so because the technique allowed them to conceive a child who is biologically theirs, whereas couples choosing donor insemination did so because they could not afford IVF, Scover et al. 1996. This is another example of how economic factors play a major role in determining what kind of infertility treatment couples receive. Berger, 1980, has reported on the severe stress couples experience when the male partner is diagnosed as azoospermic or severely oligospermic. Of the men studied, 60% developed transient impotence, and their wives reported a high frequency of rageful dreams and fantasies of leaving the infertile partner. Donor insemination is so medically simple to perform that couples may proceed with it before fully exploring their feelings about incorporating a, usually, unknown man's genetic heritage into their relationship. In addition to the couple's shame at their deficiency, legal and religious ambiguity about the status of the procedure may induce the couple to try to keep it secret. Total SE infertility and the new reproductive technologies 213 Cressy is a burden to maintain, however, and in the heat of some family crisis, the fact of the insemination is likely to be blurted out in a harmful way, Sokoloff 1987, especially when couples who plan to keep donor insemination secret from the offspring confide in family and friends, as a significant percentage do. For instance, Amutu et al. 1990, reported that 50% of couples conceiving through donor insemination had told at least one person in their social circle. Knowledge of one's genetic parentage is increasingly being seen in the United States as the birthright of every adult individual, a situation that complicates the task of maintaining secrecy. On the other hand, when the donor of the gametes is known, which is much more likely if the donor is female, other complicating factors arise: the infertile couple's ongoing relationship with the donor's feeling of emotional proprietorship, and the possibility that the offspring may have multiple parents to deal with. Additionally, when the woman who carries the pregnancy will not keep the baby, she may encounter unforeseen difficulties in relinquishing it to the parents. This is understandable, because women who volunteer to be surrogates are often motivated not only by financial need, the desire to be pregnant, and the wish to give a baby to an infertile couple, but also by the desire to master unresolved feelings about a previous pregnancy loss. Parker 1983, Scover et al. 1991. Psychologic treatment issues for infertility patients. Numerous studies have suggested that one response to infertility treatment, especially if unsuccessful, is depressive symptoms. An episode of depression by DSM-4 criteria, American Psychiatric Association 1994, must of course be distinguished from feelings of distress and discouragement that commonly occur and do not constitute an episode of depressive disorder, Downey et al. 1989. Mood swings may occur, with or without the presence of exogenous hormones and with or without a history of premenstrual mood symptoms, over the course of the month as women grow hopeful or anxious during the days before and after ovulation, only to become frustrated and disappointed with the onset of menstruation. Women may appear to have moderately severe agitated depressions around the time of menses but become asymptomatic 2 weeks later and repeat the cycle every month. Any complaint of depression needs careful evaluation, especially with regard to severity, because in a small number of infertility patients, both male and female, psychiatric illness may develop or be exacerbated by the stress of 214 Psychological Aspects of Women's Healthcare, 2nd edition. The Infertility Workup. Some episodes will be manageable with the physician's support and variations in the pace of infertility treatment. Others will require psychotherapy and, in a few, the addition of psychotropic medications. At this point, great tact on the part of the mental health practitioner is necessary, as well as the support of the gynecologist or urologist, because infertility treatment is often deferred when patients are receiving other medications, and patients bent on achieving fertility may refuse any medication that would delay their efforts to conceive. Although few women or men undergoing infertility treatment will develop a psychiatric disorder, many are so focused on achieving their goal of pregnancy that they will lose the ability to keep the problem in perspective with the rest of their lives. An infertile couple may feel that time is so pressing that even a respite of a few weeks during which they do not pursue treatment is unacceptable. The psychiatrist may be able to help such exhausted or symptomatic couples take a holiday from treatment. This is often the first intervention when distress seems to be building toward dysfunction, and in some cases it may be the only intervention needed. It is important that the treating clinician not have preconceptions about how the infertility problem will affect the couple's relationship. Some women are more anxious about being childless than are their partners and feel isolated as a result. Other women find that facing this life crisis with their partners has strengthened their relationship. The emotional benefits of approaching infertility as a shared problem suggest that when one member of an infertile couple seeks psychologic help, it is valuable for the clinician to see both partners, at least as part of the initial assessment, so that the less symptomatic partner can be brought into the treatment as needed. Couples undergoing infertility treatment may be under such pressure to perform sexually in order to comply with the many requirements of the evaluation and treatment that they begin to develop sexual dysfunctions such as impotence, anorgasmia, or lack of sexual desire. Frequently, the sexual symptoms will lessen with relatively simple interventions, such as limiting the taking of basal body temperature or taking 1 to 2 months break from treatment. Persistent, severe sexual dysfunction needs more extensive exploration. One of the most common problems infertility patients face has to do with the relaxed attitude often advised by their friends and family as an aid to enhancing fertility. It is innately stressful and not at all relaxing to be struggling to reach a difficult goal such as conception. Although it may be beneficial to learn relaxation techniques to enhance coping strategies, no good evidence has yet shown that relaxation enhances fertility. Adoption, although infertility and the new reproductive technologies 215 it may relieve the pressure to conceive, has also not been shown to enhance fertility beyond allowing additional time during which unprotected intercourse may lead to conception. Collins et al. 1983, Lem and Lurgans 1979. Couples seeking conception are prone to accept responsibility for the infertility problem when it does not have to do with their behavior, for instance, by assuming that conflicts about pregnancy may be causing their infertility. Clinicians can be most beneficial to such patients by clarifying that stress and conflicts do not ordinarily affect fertility, and that difficulties conceiving are not the patient's fault. A perceived loss of control is perhaps the most common stress of infertility. For women accustomed to planning their careers and other aspects of their lives, infertility may be experienced as their first major disappointment and as an unjust shock. Envy of friends and family members who conceive easily is common. Why them and not us? Couples ask. Anger toward the treating physician is also common, and one of the tasks of the mental health professional is helping the infertility patient determine when his or her expectations of the physician are unrealistic. A central task in the clinical management of infertility patients is helping them to achieve a sense of mastery in managing their treatment. As more and more new reproductive technologies become available, it becomes increasingly difficult for patients to decide when enough is enough. Taylor 1990. The internal pressure to persist, no matter what the emotional and financial cost, is intense. As Becker and Nachtigal, 1994, point out, It is common in our society for individuals to take risks by engaging in medical treatment to avoid regret. As they seek a clear statement from the physician on the chances of achieving pregnancy, couples may need help from a mental health professional so that they can make an informed decision. Once they have this information, couples may need assistance in weighing the benefits and costs for themselves in relation to the other alternatives open to them, such as adoption or living without children. The appropriate mode of psychiatric treatment, if indicated, will depend on the couple's or patient's presenting symptoms, their psychiatric history, and their characterologic strengths and deficits. Conjoint marital or sexual therapy may be indicated, as may individual psychotherapy or briefer periods of counseling. Support group-oriented therapies available in an infertility clinic setting, Stewart et al. 1992, or given under the aegis of Resolve, the National Self-Help Organization for Infertile Couples, are appropriate when 216 psychological aspects of women's health care, 2nd edition couples are willing to seek help in a group setting and are not too anxious and suggestible. Sparoff et al. 1994, have stated the goals of infertility treatment in their text for gynecologists, to seek out and correct the causes of infertility, to provide accurate information, to give emotional support for the couple, and to counsel them about the proper time to discontinue investigation and treatment. Inherent in this advice is the idea that for all of us who treat patients with infertility problems, the goal is not to achieve pregnancy at any cost but rather to assist couples in resolving their infertility crisis and becoming able to move on in life. This may mean having a birth child, adopting or fostering a child or children, or living child-free in a manner in which their creativity and urge to contribute to the benefit of the next generation can find expression. References: Achenbach T.M., The Child Behavior Profile, 1, Boys aged 6, 11. J. Consult Clin Psychol 46:478, 488, 1978. Achenbach T.M., Edelbrock C.S., Manual for the Child Behavior Checklist and Revised Behavior Profile. Burlington, Vermont, University of Vermont, 1983. American Psychiatric Association, Diagnostic and Statistical Manual of Mental Disorders, 4th edition. Washington, D.C., American Psychiatric Association, 1994. Amusa B., Laxova R., Shapiro S.S., Pregnancy Outcome, Health of Children, and Family Adjustment After Donor Insemination. Obstet-Gynecol 75:899, 905, 1990. Atia E., Downey J., Psychological Consequences of Successful Treatment, a case report of a pregnancy assisted by in vitro fertilization, embryo transfer. Psychosomatics 33:218, 221, 1992. Beck et. Depression Inventory. Philadelphia, PA, Center for Cognitive Therapy, 1978. Becker G., Nachtigall R.D., Born to be a Mother, The Cultural Construction of Risk in Infertility Treatment in the U.S. SOC Psymed 39:507, 518, 1994. Berger D.M., Couples' Reactions to Male Infertility and Donor Insemination. AMJ Psychiatry 137:1047, 1049, 1980. Collins J.A., Rickson W., Janes L.B., et al., Treatment-Independent Pregnancy Among Infertile Couples. An English J. Met 309:1201, 1206, 1983. Connolly K.J., Edelman R.J., Cook I.D., Distress and Marital Problems Associated with Infertility. J. Reprod Infant Psychol 5:49, 57, 1987. Cook R., Parsons J., Mason B., et al., Emotional, Marital, and Sexual Functioning in Patients Embarking upon IVF and Aid Treatment for Infertility. J. Reprod Infant Psychol 7:87, 93, 1989. Infertility and the New Reproductive Technologies 217. DeVries K., Degany S., Evskitz I., et al., The Influence of the Postcoital Test on the Sexual Function of Infertile Women. J. Psychosome Obstet Gynecol 3:101, 106, 1984. Downey J., Yingling S., McKinney M., et al., mood disorder, psychiatric symptoms, and distress in women presenting for infertility evaluation. Fertile Sterile 52:425, 432, 1989 Drake T.S., Gruner G.M., A Cyclic Pattern of Sexual Dysfunction in the Infertility Investigation. Fertile Sterile 32:542, 547, 1979 Ethics Committee of the American Society for Reproductive Medicine, Ethical Considerations of Assisted Reproductive Technologies. Fertile Sterile 67, Supply, 3, 1s9s, 1997 Flamignacy, Boranaye, Counseling Postmenopausal Women for Donor In Vitro Fertilization and Hormone Replacement Therapy. Hum Reprod 10:1237, 1241, 1995 Garrel M., Salobir C., Blondel B., Psychological Consequences of Having Triplets, a 4-year follow-up study. Fertile Sterile 67:1162, 1165, 1997 Jaffe S.B., Jewelwiz R., The Basic Infertility Investigation. Fertile Sterile 56:599, 613, 1991 Chi W.R., Psychosexual Responses to Infertility. Clin Obstet Gynecol 27:760, 766, 1984 Chi W.R., Dieneris A., Wilson T., et al., Psychosexual Responses to Infertility, Differences between Infertile Men and Women, Abstract. Fertile Sterile 36:426, 1981 Kovacs G.T., Mushin D., Kane H., et al., A Controlled Study of the Psychosocial Development of Children Conceived Following Insemination with Donor Semen. Hum Reprod 8:788, 790, 1993 Lalas A., Lalaso, Jacobson L., et al., Psychological Reactions to the Medical Investigation and Surgical Treatment of Infertility. Gynecol Obstet Invest 20:209, 217, 1985 Lam E.J., Lurgens S., Does Adoption Affect Subsequent Fertility? AMJ Obstet Gynecol 134:138, 144, 1979 McEwen K.L., Costello C.G., Taylor P.G., Adjustment to Infertility. J. Abnorm Psychol 96:108, 116, 1987 Menning B., The Emotional Needs of Infertile Couples. Fertile Sterile 34:313, 319, 1980 Mosier W.D., Pratt W.F., Fecundity and Infertility in the United States, 1965 to 1988. Advanced Data 192:1, 6, 1990 Newton C.R., Hearn M.T., UPA, Psychological Assessment and Follow-up After In Vitro Fertilization, Assessing the Impact of Failure. Fertile Sterile 54:879, 886, 1990 Parker P.J., Motivations of Surrogate Mothers, Initial Findings. AMJ Psychiatry 140:117 118, 1983 Sauer M.V., Paulson R.J., Lobo R.A., Pregnancy in Women 50 or More Years of Age, Outcomes of 22 Consecutively Established Pregnancies for Oocyte Donation. Fertile Sterile 64:111, 115, 1995 Scover L.R., Collins Re., Quigley M.M., et al., Psychological Follow-up of Women Evaluated as Oocyte Donors. Hum Reprod 6:1487, 1491, 1991 218 Psychological Aspects of Women's Health Care, 2nd edition Scover L.R., Thomas A.J., Miller K.F., et al., Preferences for Intracytoplasmic Sperm Injection versus Donor Insemination in Severe Male Factor Infertility, a Preliminary Report. Hum Reprod 11:2461, 2464, 1996 Siebel M.M., Tamor M.L., Emotional Aspects of Infertility. Fertile Sterile 37:137, 145, 1982 Shapiro C.H., Is Pregnancy After Infertility a Dubious Joy? Social Casework 67:306 313, 1986 Society for Assisted Reproductive Technology and the American Fertility Society, in vitro fertilization, embryo transfer, IVF, ET, in the United States during 1989. Fertile Sterile 55:14, 1991 Sokoloff BZ, Alternative Methods of Reproduction, Effects on the Child. Clin Pediatric 26:11, 17, 1987 Sparoff L., Glass RH, Case NG, Clinical Gynecologic Endocrinology and Infertility. Baltimore MD, Williams and Wilkins, 1994 Stewart D., Boydell K.M., McCarthy K., et al., A Prospective Study of the Effectiveness of Brief, Professionally Led Support Groups for Infertility Patients. Int J Psychiatry Med 22:173, 182, 1992 Taylor P.J., When is Enough Enough? Fertile Sterile 54:772, 774, 1990 Wright J., Duchesne C., Sabrin S., et al., Psychosocial Distress and Infertility, Men and Women Respond Differently. Fertile Sterile 55:100, 108, 1991 11 Induced Abortion in the United States Nada L. Scotland, MD, MPH. Introduction and definitions. The termination of a pregnancy is a powerful act, with significant psychologic meanings and implications arising from personal psychodynamics and experience, religion, interpersonal relationships, and biology. Induced abortion is an act enmeshed in its social surroundings in every respect, etiology, performance, and sequelae. Although, as elaborated in this chapter, pregnancies have been terminated at every time in history and on every continent of the world, the psychologic aspects of abortion are so closely culture-bound that it is not possible either to discuss it generically or to do justice to more than one culture and its legal system. Therefore, this chapter focuses on induced abortion in the United States, which in itself contains a wide range of attitudes and practices. Abortion is a medical intervention that evokes a great amount of feeling in the United States. Elections for public office are won and lost on the basis of candidates' positions toward abortion funding, access, availability, acceptable grounds, and the right of potentially concerned parties other than the pregnant woman herself to be informed of or to consent to the procedure. Tribe 1990. Both the intensity of feeling about abortion and the avoidance of the subject are reflected in confusing terminology. The term abortion is used by gynecologists to describe both induced abortion and spontaneous abortion, or miscarriage. Induced is a more accurate descriptor than elective. Abortion is also induced in cases of fetal defects incompatible with life and of 220 Psychological Aspects of Women's Health Care, 2nd edition Medical Complications Threatening the Life of the Mother. The term abortion as used in this chapter refers to induced abortion. Role of psychiatry. The psychologic causes and experience of abortion are parallel to those of the other reproductive events discussed in this book, but with more publicity, passion, and misperception. Psychiatrists have been involved in access to the procedure, and organized psychiatry, as represented by the American Psychiatric Association, APA, has taken an official position on induced abortion. This position, adopted in 1978 and reconfirmed in 1992 and 1995, is as follows: the emotional consequences of unwanted pregnancy on parents and their offspring may lead to long-standing life distress and disability, and the children of unwanted pregnancies are at high risk for abuse, neglect, mental illness, and deprivation of the quality of life. Pregnancy that results from undue coercion, rape, or incest creates even greater potential distress or disability in the child and the parents. The adolescent most vulnerable to early pregnancy is the product of adverse socio-cultural conditions involving poverty, discrimination, and family disorganization, and statistics indicate that the resulting pregnancy is laden with medical complications which threaten the well-being of mother and fetus. The delivery that ensues from teenage pregnancy is prone to prematurity and major threats to the health of mother and child, and the resulting newborns have a higher percentage of birth defects, developmental difficulties, and a poorer life and health expectancy than the average for our society. Such children are often not released for adoption and thus get caught in the web of foster care and welfare systems, possibly entering lifetimes of dependency and costly social interventions. The tendency of this pattern to pass from generation to generation is very marked and thus serves to perpetuate a cycle of social and educational failure, mental and physical illness, and serious delinquency. Because of these considerations, and in the interest of public welfare, the American Psychiatric Association 1. Opposes all constitutional amendments, legislation, and regulations curtailing family planning and abortion services to any segment of the population. 2. Reaffirms its position that abortion is a medical procedure in which physicians should respect the patient's right to freedom of choice. Psychiatrists may be called on as consultants to the patient or physician in those cases in which the patient or physician requests such consultation to expand mutual appreciation of motivation and consequences. And 3. Affirms that the freedom to act to interrupt pregnancy must be considered a mental health imperative with major social and mental health implications. American Psychiatric Association 1978, induced abortion in the United States 221. Several other medical specialty and practice organizations, including the American College of Obstetricians and Gynecologists, have taken a similar stance. The American Medical Association, after considerable debate, decided to leave attitudes about induced abortion to the individual physician. Although the official APA position probably represents the stance of a sizable majority of psychiatrists, there are those whose cherished values and beliefs are violated by it. They question the appropriateness of such a stance within a profession dedicated to the preservation of life, the relevance of abortion policy to psychiatry in particular, and the effectiveness of access to abortion in eliminating or reducing the problems to which the APA statement addresses itself: child abuse, neglect, and deprivation. On the other hand, some psychiatrists regard abortion as such a fundamental human right that they threaten to boycott a psychiatric convention scheduled in a state in which the legislature had passed statutes limiting abortion access. Of particular importance to the practice of psychiatry are the psychosocial factors in unplanned pregnancies, the decision-making process, the effect of pregnancy and abortion on women's mental well-being, physician-patient confidentiality, the right and obligation of physicians to see that patients have access to and knowledge about all therapeutic options without barriers, and the autonomy of the pregnant woman, regardless of her age, to make decisions about her care in consultation with the health professionals who provide that care. Conceptual and methodologic issues. The issue of abortion is so contentious that fundamental realities are often overlooked. Consideration of these realities is essential not only for policy making but also for clinical practice and scientific study. First of all, abortion is performed only on women who are pregnant. If an abortion is not performed, and barring complications such as spontaneous abortion, these women will go on to deliver. Study of the outcome of abortion without comparison with the sequelae of labor, delivery, and motherhood has very limited scientific validity and practical utility. The only truly appropriate control group for such studies is women who found their pregnancy similarly problematic, who sought abortion, and who were unable to obtain it. Findings from the few such studies that have been performed are summarized here. Women considering abortion are not only pregnant, but pregnant under circumstances they experience as untenable. The circumstances also make a substantive contribution to outcome. The abortion procedure does not have 222 psychological aspects of women's health care, second edition, and impact in isolation. Last, the effects of social and medical context on the experience and outcome of abortion are often overlooked. These considerations are discussed further in the section on psychiatric issues. Gynecologic and public health issues. Data in this section are taken from Public Health Policy Implications of Abortion, American College of Obstetricians and Gynecologists 1990, a handbook for health professionals that was developed collaboratively by a group of medical organizations, including the American College of Obstetricians and Gynecologists, the American Medical Association, and the APA, and published in January 1990. It can be obtained through those organizations. Statistics were derived from the Centers for Disease Control and Prevention, Kunin et al. 1998, and the National Center for Health Statistics. Procedures to terminate a pregnancy vary somewhat by trimester. Until recently, second trimester abortions were generally induced by the intrauterine installation of chemical agents, such as urea or saline, that precipitated the onset of uterine contractions and the expulsion of the fetus. Currently, second trimester pregnancies are also terminated by methods similar to those used in the first trimester, cervical dilation and uterine evacuation. Since 1981, 90% of all abortions have been performed using suction curettage. Under local anesthesia, the cervix is dilated and the uterine contents removed by suction. The procedure takes 10 to 12 minutes. This procedure cannot be performed late in pregnancy. At least half of all induced abortions in the United States are performed within the first 8 weeks, and 90% within the first trimester of pregnancy. During this time, the risk of medical complications is less than 0.5%. Abortions performed after 20 weeks of gestation constitute fewer than 1% of all such procedures. Most of these occur at 21 to 23 weeks. Most abortions are performed in freestanding, non-hospital clinics, where the cost is about one-third, average, $213, of that in a hospital. The safety is equivalent, for early and uncomplicated abortions, and the access and psychologic experience easier, and less complicated by the presence of protesters. Maternal mortality from abortion performed under safe conditions is 0.5 per 100,000 procedures. The rate from childbirth is 25 times greater. During the 1960s, before abortion was legalized in the United States, illegal abortion led to approximately 20% of pregnancy-related admissions to hospitals in major population centers and 20% of all deaths from pregnancy and childbirth. These kinds of statistics are induced abortion in the United States. 223 still obtained in areas of the world where safe abortions are not available. Access to abortion is geographically uneven. The vast majority of abortion providers are in urban areas. Of all counties in the United States, 82% lack a facility performing abortions. The 30% of women who live in a county without a provider obtain, on average, substantially fewer abortions than women in areas with a provider. Most general hospitals perform no abortions at all, and those that do perform very few. Other barriers to service include the federal ruling that Medicaid funds cannot be used for abortion services except to save the mother's life and requirements for notification or consent of the patient's parents. As growing numbers of women enter military service, the prohibition on abortion services at military hospitals, even when privately financed, affects greater numbers of women. Evidence indicates that such barriers deter timely and safe care and lead to adverse public health consequences. Berger 1978. The antiprogestin mifepristone, Ru-486, is 95% effective in inducing abortion when taken orally and followed by a dose of prostaglandin. It is associated with minimal side effects and with no known complications or long-term health implications. It is available and in use in China and in France. Clinical trials are underway in other countries all over the world. The U.S. Food and Drug Administration has approved the use of mifepristone, Rosenblatt et al. 1995, and a private, non-profit consortium has been founded to undertake the research and distribution of Ru-486 within the United States. Anti-abortion groups have reportedly threatened to initiate major actions, including boycotts, against any pharmaceutical company that seeks to market the drug in this country. Some women prefer surgical procedures because they are definitive and immediate, but most prefer medical abortion because it feels more private and less intrusive. There is a federal ban on the study of other abortifacients. Epidemiology. The World Health Organization estimates that as many as 53 million induced abortions are performed globally every year. World Health Organization 1997. Rates of induced abortion in the United States have been compiled according to race, age, and marital and reproductive status. The figures quoted here were published by the American College of Obstetricians and Gynecologists in 1990 and updated with the latest available figures from the Centers for Disease Control and Prevention, Kunin et al. 1998. Of women who own 224 Psychological Aspects of Women's Healthcare, 2nd edition Durgo abortions, approximately 58% are white, 45% are nulliparous, 89% have 2 or fewer children, and 54% have not undergone an induced abortion previously. 79% of all women and 96% of teenage women obtaining abortions are unmarried. Marriage precipitated by pregnancy places teenagers at higher risk for abuse, school failure, and dependence on public support than their unmarried agemates, Zirovin 1991. Over 60% of women undergoing abortion are younger than 25 years, 42% of pregnancies in teenagers are terminated by induced abortion. Although women over 40 become pregnant more rarely and account for relatively few induced abortions, 51% of their pregnancies are terminated by induced abortion. The numbers and rates of induced abortion remain fairly constant throughout the 1980s and approximate those before abortion was legalized. In 1986, approximately 33 million legal and 27 million illegal abortions were performed throughout the world, Tietze and Henshaw 1986. History and anthropology. Induced abortions have been performed throughout recorded history in every part of the world and in virtually every sort of culture. An exhaustive cross-cultural study performed by Devereux, 1976, revealed a wide range of methods by which pregnancy termination is attempted or achieved and an equally wide range of social regulations, from those that proscribed abortion to those that mandated it under certain circumstances. Discussion of abortion practices and beliefs in selected cultures serves to put the practice into some perspective, Newman 1991. Induced abortion is mentioned and proscribed in the Hippocratic Oath. Therefore, it must have been practiced and discussed in ancient Greece, Edelstein 1989. Moving to the 20th century, in the former Soviet Union, an officially atheist state that sought to increase its population, abortions were provided by the state health system, although supplementary, sub rosa fees were required for anesthesia, and women underwent an average of 9 abortions each, page 1989. In China, it is reported that the number of induced abortions is at least equal to the number of live births. Population control is a national priority in China, and considerable pressure may be exerted on women or couples when conception has occurred without prior approval by their respective work group, Engelhardt 1989. Abortions are also widely performed in Roman Catholic countries, where they are illegal, only illicitly available, and lead to thousands of maternal deaths, Bromham and Oloto 1997. Induced abortion in the United States 225. In contrast, induced abortions are legal, common, safe, and accepted in Japan. This accepting social context is not associated with a lack of feeling and meaning, however, Class and Heath 1997. Japanese religious and cultural beliefs hold that the soul of the embryo may cause health and other problems for the mother if not laid to rest in a religious observance. There is a goddess who takes a special interest in embryos and young children, and shrines dedicated to her are hung with offerings of baby toys and bibs, Onuki Tierney 1984. In the United States, abortion was first the province of the lay midwife who was responsible for most of women's reproductive health care. Around the middle of the 19th century, as medicine was increasingly professionalized and organized, obstetrics and gynecology became recognized as a medical specialty and physicians moved to establish hegemony over women's reproductive functions. Textbooks described menstruation and childbirth as debilitating events that made women vulnerable to medical disorders and unsuited to stresses such as those associated with higher education, lest their reproductive functions be impaired. Women of the lower classes, who performed heavy labor inside and outside the home even when pregnant and postpartum, were thought to have more primitive physiologies. With a focus on the middle and upper classes and the assumptions that childbearing within marriage was women's God-given duty and that conception outside marriage was sinful, abortion began to be decried by organized medicine. Eventually, it was outlawed. Nevertheless, the practice of abortion continued. Women's magazines of the 19th and early 20th centuries regularly carried thinly disguised advertisements for purported abortifacients. Abortion went underground, sometimes performed secretly by licensed physicians and more often by shadowy practitioners to whom women were referred by their physicians, friends, and relatives. In areas where legal scrutiny was tight, elaborate arrangements were made that involved meetings in out-of-the-way locations, blindfolded transport to unknown locations, and exchanges of cash. Anesthesia was rarely used because it lengthened the time for the clandestine procedure and made it difficult for the woman to flee in the case of a police raid. Serious complications and deaths were common. Until the early 1970s, most large hospitals had entire wards full of patients being treated for septic abortions. Care was complicated by the fact that the women were both unwilling and unable to give accurate histories when they presented hemorrhaging and/or infected for emergency care to often judgmental hospital staff. In cities such as Chicago, elaborate networks served to direct and bring women to quality. 226 Psychological Aspects of Women's Health Care, 2nd edition. Keans who would risk losing their medical licenses by performing abortions to prevent these dire complications. Because many of the state laws prohibiting abortion allowed for exceptions when continued pregnancy was thought to threaten the life or, less commonly, the health of the woman, psychiatrists played a significant role in providing more affluent and/or sophisticated women access to medically safe abortion. As medical knowledge improved, medical illnesses once incompatible with successful pregnancy outcomes, such as diabetes, became manageable in the context of pregnancy. It was difficult to establish medical grounds for termination without blatant falsification of laboratory results and other verifiable findings. Psychiatric conditions, on the other hand, were not so verifiable. The earliest versions of DSM had just appeared, with highly subjective criteria for various diagnoses. If a psychiatrist asserted that a woman would commit suicide or suffer other psychiatric sequelae if her pregnancy were not terminated, there was little way to prove otherwise. In many hospitals, committees were formed for the sole purpose of making decisions in these cases. Nearly always, a pregnant woman had to make her case to a panel of male physicians. Some of these women have written poignantly about the humiliation of presenting their painful stories to the gatekeepers who controlled access to the procedure they so desperately wanted. One of these women had 3 preschool children when she became pregnant for the 4th time. Her husband, who was the sole support of the young family, insisted that he would abandon the family if another child was born. This woman, Kate Michelman, went on to head the National Abortion and Reproductive Rights Action League. Legal issues: up to 1.5 million induced abortions are performed in the United States each year. This number was estimated to be much the same before the Roe v. Wade decision by the Supreme Court legalized abortion in 1973. The absolute numbers have fallen 15% since 1990, and the percentage of pregnancies terminated by induced abortion has continued to decline since 1987, Kunin et al. 1998. The Roe v. Wade decision declared a right to privacy between a woman and her physician concerning the decision of whether to have an abortion and an unencumbered right to abortion during the first 12 weeks of pregnancy. During the 2nd trimester, the state was permitted to regulate abortion only to protect maternal well-being. Induced abortion in the United States. 227. The passage of Roe v. Wade has had some paradoxical consequences over the years. The collective memory of the consequences of outlawing abortion faded. People who favor rights to abortion became complacent. People who opposed abortion mobilized and made abortion an acknowledged and unacknowledged symbol of other social agendas. In response, the United States Congress has enacted legislation enjoining the use of federal funds to support abortion services. The Supreme Court, as its composition changes, has upheld various state laws limiting access to abortion. Laws requiring that the husband or father of the fetus be informed or give consent have been overturned. Other laws requiring that the parents of a pregnant girl under the age of majority be informed and/or give consent have been upheld, with the provision, called a judicial bypass, that the young woman can gain access to abortion by presenting herself to a judge with evidence that she is mature enough to make the decision and is independent of or abused or neglected by her parents. Laws that require waiting periods between the time that abortion is sought and the time that it is performed are allowed, as are those requiring that government-generated statements be provided about the stages of gestation and the availability of support for mothers and children in the state. Under the guise of public health statistic keeping, some states record the names of physicians who perform and patients who undergo abortions, data that is not kept for other procedures and that can be, and is, used to harass the physicians and patients and their families. The latest attempt to curtail access is the debate over late-term abortion, Epner et al. 1998. The successes of the anti-abortion movement in obtaining restrictions on abortion have led some women to feel that the Roe v. Wade decision is more a facade than a guarantee of access, an impression that is to some degree accurate. However, the activities of anti-abortion groups at women's clinics have also been constrained by legislation, generally precipitated by violence at those clinics, thus mitigating some with the additional stress imposed by clinic harassment. Ethical perspectives. As mentioned, access to abortion services has become the subject of heated controversy. Irreconcilable factions argue that abortion is murder or that legal access is an imperative not only for justice for women but also for their very survival. Induced abortion has come to signify major social concerns and fears, the continuity of the nuclear family structure and traditional gender 228 psychological aspects of women's health care, second edition roles, the erosion of sexual morality, the liberation of women from oppression and abuse, and the opportunity for children to enter the world as wanted members of loving families with the resources to provide for them. Cultural icons have crystallized around these positions, the fetus for groups self-identified as pro-life, the bloody coat hanger of the back alley abortionist for those who are pro-choice. These symbols are also reflections of levels of discourse about the ethics of induced abortion. Because the opposing points are irreconcilable, no attempt to reconcile them is made here. It is important, however, that the issues be delineated. The levels of discourse reflect the medical, psychologic, and social complexities of the procedure, B. Brody 1982, Warren 1982. At the most basic level are the biologic, medical, and legal realities. Abortion is the termination of a pregnancy. Society has an interest in the successful propagation of the species. A particular pregnancy may advance or deter that goal. Pregnancy almost always occurs as the result of sexual intercourse between a man and a woman. This intercourse may be more or less consensual or coercive, and the sexual partners may have congruent, divergent, or contradictory investments in procreation and intentions with regard to the parenting of a potential child. Fertilization may also take place deliberately, without intercourse, by recourse to more, in vitro fertilization, or less, artificial insemination by turkey baster, sophisticated technologic means. It always involves the genetic material of a male and a female human individual, although the genetic, gestational, and social parents may all be different persons. Because procreative maturity precedes legal maturity, the age of majority, pregnancy can and does occur in minor women whose capacity to weigh alternatives and whose moral rights to make decisions about their own care and futures is another ethical and legal question. Another level of discourse concerns the ethical responsibilities of the medical profession. Induced abortion may be performed by a lay attendant, attempted by the pregnant woman herself, or carried out by a physician or other medically trained and licensed professional health care provider. This array of possibilities raises analogous ethical problems for the gynecologist and psychiatrist alike. Abortion may be viewed as a service that doctors are obligated to provide on request, a procedure for which physicians are the appropriate gatekeepers. Many court decisions and official organization positions stipulate that the decision is to be made by a woman and her doctor, or a prima facie violation of medical ethics. The substantial dangers of abortion performed outside the medical system, an eventuality that seems unavoidable given the available anthropologic and demographic evidence, are induced abortion in the United States 229 sometimes weighed in ethical decisions as well, Jacobson 1988. Another question concerns the woman's responsibility for conception and the embryo thus engendered. A more or less explicit image persists of the sexually wanton female who seeks to rid herself of the predictable outcome of her lifestyle at the expense of her child's life. In point of fact, however, many realities constrain women's control over sexual activity and contraception. These include not only rape and incest but also lack of access to information about reproduction and contraception, lack of access to contraceptive devices and medical services, and sexual activity in which financial, social, and psychologic coercion falls short of narrowly defined sexual assault. Devanzo et al. 1991. Contraceptives also fail. An alternative image exists, that of the virtuous woman who accepts responsibility, maintains the pregnancy once conceived, and makes the personal sacrifice involved in the experience of pregnancy, labor, delivery, and either child care or child relinquishment to adoption in the interest of her child. Vox 1989. This stance imbues the woman in the earliest stages of pregnancy with the role and moral obligations of the parent of a child already born. It also raises the issue that pregnancy, delivery, parenthood, and the potential child become the instruments by which the woman is punished for sexual intercourse. The argument that most sentimentalizes attachment to the potential child sometimes conceptualizes that child as a retribution rather than a blessing. The question of when human life begins overlaps with the question of the definition of human life. A fertilized ovum is living matter with the genetic composition of a human being and the potential to develop into a human being. To date, however, that development can happen only within a woman's body. Embryologic research indicates that the differentiation of cells resulting in the formation of a normal organism can occur only in a given sequence and in the matrix and structure of embryonic development as a whole. The cells that are to differentiate into, for example, liver cells can do so only if the rest of development is proceeding normally around them at each of the requisite stages. Put another way, one relevant to the ethics of abortion, the cells and tissues of the pre-embryo and embryo are not inevitably destined to become a human being. Even given the circumstances of normal development, no clear or consensual definition of human life exists. It may be defined by genetic composition, human form, the appearance of brain waves, the ability to experience sensation, or the awareness of the self and other people as human. What distinguishes human life from other forms of life, and what privileges, if any, 230 psychological aspects of women's health care, 2nd edition, does our humanity confer on us? Both humans and animals experience pleasure and pain, and both exert strenuous effort to stay alive. Although cells biopsied from human tissue are alive, capable of reproduction, and endowed with a full complement of human chromosomes, it would be difficult to argue that such a collection of cells constitutes human life or a human being. The assertion that any particular stage of human development constitutes the beginning of human life is fraught with problematic implications. Fetal viability has been raised as an issue both by ethicists and lawmakers. Publicity about the survival of some infants born extremely prematurely has led the public to believe that the medical community is steadily moving back the point in pregnancy at which the fetus can live outside the mother. Scientific evidence does not support this belief, however, and some perinatologists think it likely that we have already approached the limits of our abilities to support extrauterine life in prematurely born infants. All of these problems complicate attempts to apply the usual standards of beneficence, autonomy, and justice to the consideration of the ethics of abortion. The APA's position statement seems to imply that not allowing a potential child to come into being can be beneficent for that child. Abortion ends a potential or an actual life as well as the hopes and interests of those who wanted to see it realized, although it may further the good both of the woman whose pregnancy and potential motherhood are experienced as intolerable and of others for whom she is responsible or to whose lives she can make a contribution. The availability of abortion may hurt society because it undermines respect for potential life and for support during pregnancy and child-rearing. It may benefit society because it diminishes the social burden of unwanted and poorly cared for children and the loss or injury of women who resort to unsafe attempts to terminate their pregnancies. Psychiatric sequelae. Psychiatrists help patients make decisions about problem pregnancies and deal with their short and long-term reactions to induced abortion. In 1988, C. Everett Koop, Surgeon General of the United States, was charged by President Bush to determine the medical and psychological effects of abortion on American women and to publish a review of the findings. Dr. Koop, who was personally opposed to abortion, solicited opinions and scientific information from a wide variety of medical and interest groups, including the APA, and concluded that there was insufficient information to assert that abortion had negative sequelae. Koop, 1991. Induced abortion in the United States. 231. The public is nevertheless very concerned about the psychiatric sequelae of abortion. The popular press and anti-abortion groups have published allegations that abortion causes serious, disabling, permanent psychological damage, and abortion trauma syndrome, de Weber et al. 1991. This term, which is absent from the peer-reviewed literature, seems to have been coined to resemble post-traumatic stress disorder. Allegations that the medical community is deliberately withholding or overlooking data supporting this position have also been made. Pro-Life Action Ministries, undated. Patients and the general public may turn to psychiatrists for accurate scientific findings concerning the psychologic sequelae of induced abortion. Stotland, 1996. Confusion often arises because of the failure to differentiate between passing negative feelings and psychiatric syndromes and because of the misattribution of the distress some women feel about an abortion. The first problem is compounded by semantic ambiguity. In the English language, depression is used both as a description of a mood and as a technical term to denote the diagnosis of a major psychiatric illness. With regard to the second problem, abortion is performed only on women who are pregnant and pregnant in problematic circumstances. Women's reactions to induced abortion arise not only, and perhaps not mainly, from the procedure itself but also from psychologic, social, major et al. 1997, and political circumstances and the communicated attitudes and behaviors of the personnel who perform the procedure. The psychosocial impact of finding oneself to have conceived an unanticipated and undesired pregnancy is considerable. The process of arriving at the conclusion that the pregnancy cannot or should not be maintained is an additional stress, often involving confrontation with realities such as poverty, the implications of interrupting one's work or education, the end or threatened end of the relationship with one's partner, who may be the father of one's other children, genetic defects, or overwhelming burdens of caring for other young children. A woman's religion or significant others may disapprove of abortion, even to the point of excluding a woman who has undergone an abortion from membership in the religious community or from the protection and regard of the family. Abortion may be accessible only illicitly or only through a complex process such as obtaining parental approval, judicial bypass, or medical justification. Of particular importance for psychiatric study is the fact that women may choose abortions because they have psychiatric illnesses that make pregnancy and motherhood problematic. Given these realities, it is difficult or even impossible to assess the impact of the abortion in isolation. Published studies of psychologic reactions to induced abortion have to 232 psychological aspects of women's health care. Second edition, some degree paralleled prevailing social attitudes and expectations. For example, a large, 479 women, Swedish study revealed that 75% of the subjects had experienced no regrets or self-reproach and all of the 1% with psychiatric problems had had prior psychiatric illness. Ekblad, 1955. Despite such findings, authors tended to assume negative effects until the early 1960s. Since that time, a succession of studies have been published, and methodology has been consistently improved. All studies agree that negative emotional effects are nearly always transient, Butler, 1996, that most women who choose abortion tend to feel increasingly relieved and comfortable with their decisions, and that in many cases their overall life satisfaction and success are improved. Adelson, 1973, H. Brody et al. 1971, Ford et al. 1971, Lask 1975, Martyr 1970, Niswander and Patterson 1967, Osofsky and Osofsky 1972, Peck and Marcus 1966, Schusterman 1976, Simon et al. 1967, Whitmore 1995. Women who were denied abortion tended to have poorer outcomes, especially if the burdens of motherhood were compounded by great multiparity or lack of social support, Pear and Raven 1970. The incidence of major psychiatric illness following induced abortion has been studied and compared with the occurrence of major psychiatric illness after delivery and in patients denied abortion. A large study in Great Britain reported that the incidence of psychosis was 0.3/1,000 after abortion and 1.7/1,000 postpartum, Brewer 1977. All other such studies report similar findings. A 1989 study performed by a researcher at Johns Hopkins University followed up adolescents who presented to a school health clinic seeking pregnancy tests, Zobin et al. 1989. Some were not pregnant. Of those who were, some chose to abort and some to carry to term. Those who terminated their pregnancies experienced the most favorable outcomes in terms of psychologic adjustment and completion of education, better outcomes than women who had not even been pregnant. The authors, surprised by this finding, theorized that vulnerability to unfounded fears of pregnancy might be correlated with other psychologic vulnerabilities. No specific illness or pattern of pathologic response to induced abortion has been described, other than anecdotally, in the scientific literature. Risk factors for psychiatric illness following induced abortion include prior psychiatric illness, pressure or coercion to undergo the abortion, marked ambivalence about the decision, and a lack of social supports, Blumenthal 1991, Major et al. 1997. Negative attitudes of those who provide care during and after the procedure also increase patients' risk of psychiatric sequelae. Psychiatrists treating patients who are considering abortion can best help them by providing information and collaborating with them. And with significant auth-induced abortion in the United States, 233 ERS of their choosing to arrive at autonomous but socially supported decisions that reflect their own circumstances, religious beliefs, and values. The reactions of men to their partners' induced abortions have not been well studied. Male partners are often overlooked and their psychologic needs not attended to. In one study of men accompanying women to an urban hospital abortion service, the men reported that the circumstances surrounding the abortion had constituted a developmental challenge. Some men retreated to dependence on their parents, leaving their wives or girlfriends to obtain the necessary information and make the decision largely without their support. Most mastered the challenge, however, and emerged from the experience with an enhanced feeling of fatherliness and responsibility, Rothstein 1991. Like women who undergo abortion, they had decided that parenthood should be the result of a considered decision that one could provide for a child and should not be undertaken by chance. Psychiatric implications of legal constraints. Restrictions on abortion services threaten all women with unintended motherhood or illegal abortion, outcomes likely to be psychologically stressful. Because restrictions limit access for some women but not others, they raise ethical and public health questions for all physicians. For example, the so-called Hyde Amendment passed by the United States Congress proscribes the use of federal funds for abortion services. Therefore, Medicaid funds other obstetric and gynecologic services but not abortion. Because few medical facilities operate without federal funds, this legislation affects a large proportion of the population, relegating them to second-class medical care. Women with social support, means, and sophistication have always been able to obtain safe abortions. Why is abortion a psychiatric issue? There are several reasons. The procedure is medical, and psychiatrists are physicians. In times and places where abortion services are not freely available to women, abortion may be allowed only when deemed medically necessary in the interest of a woman's health. Where abortion is permitted only to save the mother's life, suicidal patients may qualify. Before abortion was generally legalized, sophisticated patients sometimes used psychiatrists to gain the consent of hospital review boards. As a result, Psychiatric grounds were perceived by some authorities to be underjustified and overused, and some states and the military specifically disallowed psychiatric grounds for abortion. Other laws have been more liberal. 234 Psychological Aspects of Women's Health Care, 2nd edition, allowing psychiatric factors to be considered on a par with other medical factors that have a significant likelihood of impairing the mother's health if the pregnancy continues, Shepler 1991. Each of these circumstances is problematic for psychiatry. Excluding suicide or mental health indications isolates psychiatric illness from the rest of medicine and reinforces both the misconception that mental illnesses are not real and the stigma surrounding psychiatric patients and practitioners. Allowing psychiatric indications for abortions places psychiatrists in an untenable position. Suicidality and other adverse psychiatric outcomes, like all medical outcomes, are not entirely predictable, especially when the patient who is providing the data for the decision is in the midst of a crisis and has a vested interest in obtaining a particular procedure. Several decades ago it was possible for a psychiatrist to write a letter indicating that a patient was suicidal without entering this information in her permanent medical record. Today, a psychiatrist's observation that a patient is mentally ill and/or suicidal will follow her through life and may threaten her career opportunities and her ability to obtain life and health insurance. Given the current scrutiny of psychiatric care and the widespread role of religious groups opposed to abortion in supporting medical services, the psychiatrist who declares a pregnant patient suicidal may be constrained to hospitalize her for a time or even until she delivers. The psychiatrist may be in a bind because the clinical evidence in a case may not warrant the conclusion that the patient is suicidal, although the patient or the psychiatrist, or both, may feel strongly that an abortion would be in the patient's best interest. The psychiatrist must then either lie about the findings or see the patient denied abortion. Studies indicate that patients who are denied abortions requested on psychiatric or psychosocial grounds, as well as their children, suffer adverse outcomes as compared with control families, but that these patients seldom complete the act of suicide during the pregnancy, DAG 1991. Psychiatrists have a particular interest and expertise in the circumstances associated with the unplanned pregnancies. These circumstances range from ignorance, poverty, and lack of contraceptives to abuse, immaturity and impulsivity, various degrees of interference with reality testing, and more individual and interpersonal psychodynamics. Psychiatrists treat patients with histories of severe psychiatric complications of pregnancy and delivery. We treat patients who appear or have been shown to be unable to master the responsibilities of motherhood, including patients who have suffered terrible emotional pain and exacerbations of psychiatric illness after losing custody of children in the past. We treat patients for whom we have prescribed psycho-induced abortion in the United States. 235 tropic medications in the early days and weeks before pregnancy could be diagnosed, with unknown effects on the embryo and fetus, see Chapter 5, and patients who require psychotropic drugs to forestall repeated decompensations. Limitations on access to abortion may put the psychiatrist in another sort of legal bind as well. The 1989 United States Supreme Court decision affirming the Missouri law in the case of Webster v. Reproductive Health Services let stand language stating that public funds may not be used to advise or counsel a woman to have an abortion. This language, which has been repeated in the laws of other states, could be interpreted to mean that a psychiatrist caring for a woman with a history of severe postpartum psychiatric illness, loss of custody, severe psychiatric vulnerability, or treatment with psychotropic drugs in early pregnancy may not inform the patient of the full range of therapeutic options. When a patient's care is publicly funded, or takes place in a publicly funded facility, few medical facilities, including private offices, have no public funding. Such a law may proscribe the discussion of abortion. Anti-abortion activists have threatened to visit doctors' offices with simulated psychiatric histories in order to expose physicians who violate the law. As noted earlier, U.S. Supreme Court decisions since Roe v. Wade in 1973 have precipitated the passage of state laws restricting abortion access. Some legislative and judicial restrictions on abortion are couched in terms of notification and consent of third parties. The Pennsylvania legislature passed a bill requiring the signature of a woman's husband that was vetoed by the governor. Several states have enacted laws requiring the notification and/or consent of the parents of a minor woman seeking abortion that have been found to be constitutional so long as they include a provision for judicial bypass. Scheffler 1991. These laws have a clear emotional appeal to the public's sentiments about parental protection of minor children and the sanctity of the family. However, they ignore realities about adolescent development, troubled families, and the judicial process. All of the major medical organizations endorse the physician's role in advising and helping pregnant young women to inform and enlist the support of their families when that is in their best interest. Most young women do so. Unfortunately, adolescents from abusive and neglectful families are at increased risk of unintended pregnancy. Forcing them to tell their parents further exposes them to the risk of abuse, expulsion from the home, and self-destructive behavior, including suicide. Mandating parental involvement is also a contra-therapeutic intrusion in the physician-patient relationship, whether the physician in question is an obstetrician, pediatrician, family practitioner, or psychiatrist. 236 Psychological Aspects of Women's Health Care, 2nd edition. Judicial bypass requires that an adolescent without adequate family support, and in the middle of the crisis precipitated by an unwanted pregnancy, be aware of the judicial bypass procedure. She must locate the court, make excuses for her absence from home and/or school, and present herself at the court. In rural areas, she may have to travel a considerable distance. Once at the court, she must make her intentions known to staff so that she can be directed to the appropriate room. The law requires that this process be confidential, but in rural areas both the court staff and the judge may well know her and her family personally. In Minnesota, such a law was found to produce no positive outcome. Judges who heard these cases almost invariably allowed the abortion to take place. In other states, judges have granted virtually no requests for abortion. For these reasons, major medical societies, including the American Academy of Pediatrics, have taken official positions against parental notification laws. Although it recognizes the deeply felt religious and moral aversions of some psychiatrists to induced abortion and the profound decision most feel abortion to be, the APA, in concert with other medical and public interest organizations, has taken a strong stance opposing legislation that places dangerous and inequitable restrictions on women's access to safe abortion services as well as limitations on all physicians' ability to discuss, recommend, and provide services for their patients. It is truly tragic that psychosocial ignorance and inadequacies lead to so many problem pregnancies in a world that has the scientific knowledge to prevent them. References: Adelson F. Induced Abortion, Source of Guilt or Growth. AMJ Orthopsychiatry 43:815, 823, 1973. American College of Obstetricians and Gynecologists, Public Health Policy Implications of Abortion, a Government Relations Handbook for Health Professionals. Washington, D.C., American College of Obstetricians and Gynecologists, 1990. American Psychiatric Association, Position Statement on Abortion. Washington, D.C., American Psychiatric Association, 1978. American Psychiatric Association, APA Actions on Reproductive Rights. AMJ Psychiatry 149:723, 1992. American Psychiatric Association, Board of Trustees Meeting, March, 1995. Berger L.R., Abortions in America, The Effects of Restrictive Funding. An English J. Met 398:1474, 1477, 1978. Induced Abortion in the United States 237. Blumenthal S.J., Psychiatric Consequences of Abortion, Overview of Research Findings, in Psychiatric Aspects of Abortion, edited by Stotland N.L. Washington, D.C., American Psychiatric Press, 1991, pp. 17-37. Brewer C., Incidence of Post-Abortion Psychosis, A Prospective Study. BMJ 1:476, 477, 1977. Brody B., The Morality of Abortion, in Contemporary Issues in Bioethics, 2nd edition. Edited by Beecham T. L., Walters L. Belmont C.A., Wadsworth Publishing, 1982, pp 201-211. Brody H., Meikle S., Garrett C. R., Therapeutic Abortion, A Prospective Study. AMJ Obstet Gynecol 109:347, 352, 1971. Bromum D., Olodo E., Trying to Prevent Abortion. J. Contracept Reprod Healthcare 2:81, 87, 1997. Butler C., Late Psychological Sequelae of Abortion, Questions from a Primary Care Perspective. J. Fam Pract 43:396, 401, 1996. Dag P., The Psychological Sequelae of Therapeutic Abortion, Denied and Completed. AMJ Psychiatry 148:578, 585, 1991. Devanzo J., Parnell A.M., Fitch W.H., Health Consequences of Contraceptive Use and Reproductive Patterns, Summary of a Report from the U.S. National Research Council. JAMA 265:2692, 2696, 1991. De Weber L.L., Agenstat J., Chisholm D., Post-Abortion Grief, Psychological Sequelae of Induced Abortion. Humane Medicine 7:203, 208, 1991. Devereux, A Study of Abortion in Primitive Societies, Revised Edition. New York, International Universities Press, 1976. Adelstein L., The Hippocratic Oath, Text, Translation, and Interpretation, in Cross-Cultural Perspectives in Medical Ethics, Readings. Edited by Veach R. Boston Mott, Jones and Bartlett, 1989, pp 6-24. Ekblad M., Induced Abortion in Psychiatric Grounds, a follow-up study of 479 women. Acta Psychiatriscans Supp 99:1, 238, 1955. Engelhardt Heights, Bioethics in the People's Republic of China, in Cross-Cultural Perspectives in Medical Ethics, Readings. Edited by Veach R. Boston Mott, Jones and Bartlett, 1989, pp 112-119. Epner J., Jonas H., Seckinger D., Late Term Abortion. JAMA 280:724, 729, 1998. Ford Cove Castelnuovo Tedesco P., Long K.D., Abortion, Is it a Therapeutic Procedure in Psychiatry? JAMA 218:1173, 1178, 1971. Jacobson J.L., Choice at Any Cost. World Watch Mars/APR 30, 38, 1988. Class D, Heath, Grief and Abortion, Mizuko Kup, The Japanese Ritual Resolution. Journal of Death and Dying 34:1, 14, 1997. Kunin L.M., Smith J.C., Ramick M., et al., Abortion Surveillance, United States. MMWR Surveil Sum 4731, 40, 1998. Coop C.E., former Surgeon General Coop speaks out on healthcare reform and policy. Hospital 65:57, 58, 1991. 238 Psychological Aspects of Women's Healthcare, 2nd edition. Lask B., Short-Term Psychiatric Sequelae to Therapeutic Termination of Pregnancy. BRJ Psychiatry 126:173, 177, 1975. Major B., Zubek J., Cooper M., et al., Mixed Messages, Implications of Social Conflict and Social Support Within Close Relationships for Adjustment to a Stressful Life Event. J. Peirce SOC Psychol 72:1349, 1363, 1997. Martyr L., Psychiatric Experience with a Liberalized Therapeutic Abortion Law. AMJ Psychiatry 126:1230, 1236, 1970. Newman Loaf, Historical and Cross-Cultural Perspectives on Abortion, in Psychiatric Aspects of Abortion. Edited by Stotland N.L. Washington, D.C., American Psychiatric Press, 1991, pp 39-49. Niswander K., Patterson R., Psychologic reaction to therapeutic abortion. Obstet-Gynecol 29:702, 706, 1967 Onuki Tierney, Illness and Culture in Contemporary Japan, An Anthropological View. Cambridge, England, Cambridge University Press, 1984 Ossowski J.D., Ossowski H.J., The Psychological Reaction of Patients to Legalized Abortion. AMJ Orthopsychiatry 42:48, 60, 1972 Page B, Eastern Europe in the 20th Century, in Cross-Cultural Perspectives in Medical Ethics, Readings. Edited by Veach R. Boston Mott, Jones and Bartlett, 1989, pp 98-105 Pear C., Raven H., Follow-up of patients referred for termination of pregnancy. Lancet 1:635, 658, 1970 Peck A., Marcus H., Psychiatric Sequelae of Therapeutic Interruption of Pregnancy. J-Nerve Mentis 143:417, 425, 1966 Pro-Life Action Ministries, What They Won't Tell You at the Abortion Clinic. St. Paul, Minnesota, Pro-Life Action Ministries, undated Rosenblatt R., Mattis R., Hatt G., Abortions in Rural Idaho, Physicians' Attitudes and Practices. AMJ Public Health 85:1423, 1425, 1995 Rothstein A., Male Experience of Elective Abortion, Psychoanalytic Perspectives, in Psychiatric Aspects of Abortion. Edited by Stotland N.L. Washington, D.C., American Psychiatric Press, 1991, pp 145-158 Schusterman L.R., The Psychosocial Factors of the Abortion Experience, A Critical Review. Psychology Women's Quarterly 1:79, 106, 1976 Shepler L.T., The Law of Abortion and Contraception, Past and Present, in Psychiatric Aspects of Abortion. Edited by Stotland N.L. Washington, D.C., American Psychiatric Press, 1991, pp 51-73 Simon N., Centuria A., Rothman D., Psychiatric Illness Following Therapeutic Abortion. AMJ Psychiatry 124:59, 65, 1967 Stotland N., Conceptions and Misconceptions, Decisions About Pregnancy. Gen Hosp Psychiatry 18:238, 243, 1996 TCC, Henshaw S.K., Induced Abortion, A World Review, 6th edition. New York, Alan Guttmacher Institute, 1986 Induced Abortion in the United States 239 Tribe LH, Abortion, The Clash of Absolutes. New York, Nostin, 1990 Vox K., Birth Ethics, Religious and Cultural Values in the Genesis of Life. New York, Crossroad, 1989 Warren D.G., The Law of Human Reproduction, An Overview. J. Legmet 3:1, 57, 1982 Whitmore E., Abortion, in Psychological Aspects of Women's Reproductive Health. Edited by O'Hara M., Ryder R., Johnson S., et al. New York, Springer, 1995, pp 207-223 World Health Organization, Medical Methods for Termination of Pregnancy, Report of a WHO Scientific Group. World Health Organ Tech Ref Ser 871 7, 1-110, 1997 Zobin L.S., Hirsch M.B., Emerson M.R., When Urban Adolescents Choose Abortion, Effects on Education, Psychological Status, and Subsequent Pregnancy. FamPlan Perspect 21:248, 255, 1989 Zerobin S.J., Unplanned Childbearing and Family Size, Their Relationship to Child Neglect and Abuse. FamPlan Perspect 23:155, 161, 1991 This page intentionally left blank 12 Menopause Myths and Realities Barbara B. Sherwin, Ph.D. Menopause is both a natural and a universal event in the human female life cycle. A set of defining characteristics for this biologic event was formulated at the First International Congress on Menopause, Yushin and Sayre 1976. According to this formulation, the climacteric marks the transition from the reproductive to the non-reproductive stage of life in women that spans several years. Menopause occurs during the climacteric, at a mean age of 51 years, and is defined by the last menstrual period. In addition, decreased ovarian activity and socio-cultural and psychologic factors could act individually or in concert to produce climacteric symptoms. Because menopause is a universal phenomenon, it is curious that it was not until 1976 that an international definition of this event was first formulated and published. One explanation may be related to changes in statistics regarding female life expectancy. In 1900, the average lifespan of a woman living in the United States was approximately 50 years. In 1995, 40% of white American women reached 85 years of age. It is projected that this percentage will continue to rise with time. U.S. Bureau of the Census 1990. Therefore, many women now live one-third of their lives beyond cessation of their reproductive capacity, and the quality of life during the latter one-third of the lifespan has, understandably, become a major issue of concern to both health professionals and women themselves. Surgical menopause occurs when both ovaries are removed before natural menopause has occurred. Before the 1970s, bilateral oophorectomy was 242 psychological aspects of women's health care, second edition performed fairly commonly in association with hysterectomy undertaken for benign gynecologic conditions. The rationale underlying this was the prevention of ovarian cancer and the belief that ovarian function was expendable if pregnancy was no longer possible. Epidemiologic evidence suggesting that, in the absence of a family history, women have a low risk of ovarian cancer served to curtail this practice of indiscriminately removing normal-appearing ovaries. An even more compelling reason for retaining the ovaries in premenopausal women emerged when it became clear that acceleration of cardiovascular disease, Parrish et al. 1967, and osteoporosis, Lindsay et al. 1980, were associated with early oophorectomy. For these reasons, conservation of normal ovaries at hysterectomy has become the more common practice in North America. Consistent with the 1976 definition of the climacteric syndrome, Yushin and Sayre 1976, the etiology and frequency of symptoms that may occur at this time are discussed in this chapter from neurohormonal, sociocultural, and psychologic perspectives, and an attempt is made to synthesize this material. Neurohormonal processes change in sex hormone secretion in menopausal women. In premenopausal women, the ovary secretes 95% of the estradiol that enters the circulation, Lipset 1986. After menopause, the ovary virtually stops producing estradiol. Estrone, a much weaker estrogen, becomes the predominant estrogen arising from peripheral conversion of androstenedione, Longcope 1981. Although it was once thought that the drastic decrease in ovarian estradiol secretion at menopause was due solely to follicle depletion and ovarian senescence, it is now clear that age-related alterations in hypothalamic function also occur, Wise et al. 1989. Thus, the transition to menopause is a multifactorial process involving both neural and ovarian factors. In women, both the adrenal glands and the ovaries contain the biosynthetic pathways necessary for androgen synthesis and secretion. The ovary produces approximately 25% of plasma testosterone, 60% of androstenedione, and 20% of dehydroepiandrosterone, DHEA, whereas the adrenal produces 25% of circulating testosterone, 40% of androstenedione, 50% of DHEA, and 90% of DHEA sulfate. The remainder of circulating androgens in the female are thought to arise through peripheral conversion, which probably accounts for the production rate of 50% of testosterone and 25% of DHEA, Longcope 1986. Although ovarian production of estrogens decrease menopause, myths and realities 243 es drastically, about 50% of women produce even greater amounts of androgens after menopause because of ovarian stromal hyperphagia that occurs under the influence of high levels of luteinizing hormone, Judd et al. 1974. When it occurs, however, this increase in ovarian testosterone production is time-limited, so that eventually testosterone levels decrease in all women. Neurobiologic effects of estrogen and androgen. Estrogen has both inductive and direct effects on neurons. It induces RNA and protein synthesis through genomic mechanisms that, in turn, cause changes in levels of specific gene products, such as neurotransmitter synthesizing enzymes, Lewin et al. 1975. Other prolonged neuronal regulatory effects include the expression of gonadal hormone receptors in specific brain areas. The direct effects of estrogen on the brain appear to take place more rapidly. For example, estrogens can alter the electrical activity of neurons in the hypothalamus, Kelly et al. 1977. Autoradiographic studies have demonstrated that neurons containing specific cytosolic receptors for estrogen are found in specific areas of the brain, predominantly in the pituitary, hypothalamus, limbic forebrain, including the amygdala and lateral septum, and the cerebral cortex, McEwen 1980. Estrogen has widespread effects throughout the brain, including the brainstem and midbrain catecholinergic neurons, midbrain serotonergic pathways, and the basal forebrain cholinergic system, McEwen 1999. Autoradiographic studies have also demonstrated that specific cytosolic receptors for testosterone predominantly are found in the preoptic area of the hypothalamus, with smaller concentrations in the limbic system, amygdala and hippocampus, and cerebral cortex, Chamness et al. 1979. Moreover, the brain contains aromatizing enzymes necessary to convert androgens to estrogens. The anterior hypothalamus is the most active aromatizing central tissue, although limbic system structures also convert androgens to estrogens, Naftolin and Ryan 1975. It is important to note that the limbic system, especially the amygdala, plays a critical role in emotion. The fact that sex steroid receptors are found in these brain structures supports the idea that these hormones may influence emotion and affect. Peripheral effects of estrogen. Because the tissue integrity of the female reproductive tract is dependent on estrogen, degenerative changes in these structures ensue when levels of estro 244. Psychological aspects of women's healthcare, 2nd edition. Gen decrease after menopause. The vaginal mucosa of postmenopausal women who do not receive estrogen therapy becomes attenuated and pale because of decreased vascularity. Marked atrophic changes may result in atrophic vaginitis, in which the vaginal epithelium is very thin and may become inflamed or even ulcerated, Bergman and Brenner 1987. These changes, in turn, may lead to a severe diminution in vaginal lubrication and or dyspareunia. The urethral epithelium is also estrogen dependent, Ostergaard 1980, and urge incontinence is a frequent complaint in untreated postmenopausal women, Brenner 1988. Consequences of hormonal changes at menopause. Physical symptoms. Because estrogen affects a multitude of organ systems, the drastic changes in the hormonal milieu that occur around the time of menopause may have consequences for both physical and psychologic functions. Hot flushes, the cardinal menopausal symptom, occur in 60%, 90% of menopausal women, albeit with a high degree of variability in their frequency and intensity. For 65% of postmenopausal women, the vasomotor phenomena of hot flashes and cold sweats persist for at least 1 year, and for 20% these symptoms continue for more than 5 years, Brenner 1988. Because hot flashes occur more frequently at night, sleep is often disrupted. Hot flashes are reliably relieved by estrogen replacement therapy, Cook et al. 1975, and although some researchers have noted a simultaneous beneficial effect of exogenous estrogen on hot flashes and sleep quality, Schiff et al. 1980, others have found these two things to be dissociable, Sherwin and Gelfand 1984. If sleep disturbance is associated with frequent awakenings during the night because of hot flashes, it seems clear that estrogen administration will probably eliminate both symptoms. The efficacy of exogenous estrogen is less well established, however, for sleep disturbance not associated with nocturnal flushes. Psychologic symptoms. Historically, myriad psychologic symptoms have been associated with menopause, the most prominent of which are depression, irritability, and mood lability. It is now thought that affective disorders occurring during menopause do not constitute a distinct subtype of depression. Winokur, 1973, found that women were not at greater risk for a first episode of depression at menopause than they were other times during the lifespan. In that study, however, more menopause, myths and realities 245 stringent severity criteria for the diagnosis of depression during menopause were used because of the high frequency of depression and nervousness symptoms that occurred in this sample of menopausal patients. The circularity of this reasoning makes the results difficult to interpret. In a sample of female outpatient admissions diagnosed with major non-bipolar depression, it was concluded that there was insufficient evidence to consider onset of depression at menopause as a distinct entity, Weissman 1979, despite the fact that 47% of the depressed menopausal women and 65% of the depressed postmenopausal women had no history of depression. Although some epidemiologic studies have failed to find an increased incidence of depression and minor psychologic symptoms in peri- and postmenopausal women, Kaufert and Sirotuk 1981, Bollinger 1990, Thompson et al. 1973, others have documented an increase in the prevalence of depressive symptoms at this time, Bungay et al. 1980, Green and Cook 1980, Hunter and Whitehead 1989. Increases in the prevalence of depression are more pronounced in the perimenopausal compared with menopausal years, Charney and Stewart 1997. Of women who seek medical consultation for menopausal symptoms, 79% have physical symptoms and 65% have varying degrees of depression, Anderson et al. 1987. In surveys of general populations, the occurrence of a depressive episode was positively associated with a surgical but not with a natural menopause, McKinley et al. 1987. Moreover, a history of depressive episodes prior to menopause was a strong predictor of an episode at menopause, Avis et al. 1994. Measuring changes in mood in premenopausal women before and after a trial of hormone replacement therapy, HRT, is the experimental technique most commonly used to investigate the effects of sex steroids on affect. Many earlier studies were uncontrolled with respect to blindness, George et al. 1973, the presence of malignant disease, Chakravarti et al. 1977, and concurrent psychiatric illness, Dennerstein et al. 1979, thus rendering their findings difficult to interpret. In more controlled studies, reported discrepancies may be related to both the psychiatric status of the populations investigated and the doses of estrogen administered. Several studies of non-psychiatric populations of postmenopausal women have reported changes in affect to be a function of circulating levels of sex hormones. In two prospective studies of women who had undergone oophorectomy, depression scores covaried inversely with circulating levels of both estradiol and testosterone, Sherwin 1988, Sherwin and Gelfand 1985. Moreover, depression scores increased when a placebo was substituted for estrogen in these surgically menopausal women. These results therefore confirmed the 246 psychological aspects of women's health care, second edition positive association between mood and plasma sex hormone levels in healthy non-depressed women. It is important to note that, in both studies, women never became clinically depressed, and the doses of hormones administered induced circulating levels that were within the physiologic range for women of reproductive age. In another study, effective responses to exogenous estrogen were investigated in postmenopausal women who differed at pretreatment with regard to the intensity of their depression, Schneider et al. 1977. Of 10 women whose pretreatment depression scores were in the mildly, or subclinically, depressed range, 9 improved after treatment with 1.25 mg of conjugated equine estrogen daily, whereas 6 of the 10 women who were more severely, or clinically, depressed before treatment actually became more depressed with the same dose of exogenous estrogen. When women with severe, refractory depression were given very large pharmacologic doses of conjugated equine estrogen, 15 to 25 mg/day, depression scores decreased in most of the women after 3 months, Klaver et al. 1979. On the basis of these findings and those of our own studies of non-depressed women, Sherwin 1988, Sherwin and Gelfand 1985, it now seems reasonable to suggest that the administration of estrogen in doses conventionally used to treat menopausal symptoms enhances mood in non-depressed women but is therapeutically ineffective with respect to mood disturbances of a clinical magnitude. Recent work suggests that treatment-resistant depression during menopause may be alleviated in some women by antidepressant augmentation with physiologic doses of estradiol, Stahl 1998. Several mechanisms of estrogenic action on indolamine metabolism could account for its mood-enhancing effect. First, it has been demonstrated that exogenous estrogen decreases monoamine oxidase activity in the amygdala and hypothalamus of rats, Lewin et al. 1975. Because monoamine oxidase is the enzyme that catabolizes serotonin, the net effect of estrogen administration would be to maintain higher serotonin levels in the brain. Indeed, it has been found that regularly cycling depressed women have higher levels of plasma monoamine oxidase activity than do non-depressed women, Klaver et al. 1972. A second mechanism of action is related to estrogen's impact on tryptophan in plasma. Tryptophan, the precursor of serotonin, is displaced from its binding sites to plasma albumin by estrogens both in vitro and in vivo, Aylward 1973, thereby allowing more free tryptophan to be available to the brain, where it is metabolized to serotonin. A significant negative correlation between depression scores and free plasma tryptophan was reported in WOM Menopause, Myths and Realities 247 and who had undergone oophorectomy and whose mood and free tryptophan levels were enhanced after treatment with exogenous estrogen, Aylward 1976. The results of this clinical study provide some, albeit indirect, support for an estrogenic effect on neurotransmitter concentrations. Finally, a prospective study of surgically menopausal women found an increase in the density of tritiated imipramine binding sites on platelets coincident with higher estradiol levels and lower depression scores, Sherwin and Suranyika. 1990. To the extent that estrogen increases serotonin concentrations or the amount of time this neurotransmitter remains in the synapse, it will, in accordance with the biogenic amine hypothesis of depression, Shield-Kraut 1965, enhance mood. Gynecologic aspects. Gynecologic assessment. The premenopausal period is characterized by changes in the regularity of the menstrual cycle and in the duration and volume of menstrual bleeding. Menopause is said to have occurred when 12 successive menstrual cycles have been missed. Gonadotropin levels increase because of the lack of positive feedback resulting from the vastly diminished ovarian production of estradiol. Follicle-stimulating hormone levels of greater than 50 IU/ml and luteinizing hormone levels of greater than 35 IU/ml are considered, in the absence of organic disease, to be diagnostic of menopause, Jaffe 1989. The vaginal epithelium becomes atrophic, and decreased lubrication may be apparent. When the endometrium is biopsied with a curette after menopause, atrophy of this tissue is noted, Benirschke 1986. In time, a decrease in the size of the uterus and breasts occurs. Hair on the upper lip and the chin may increase in some women, probably because of testosterone production by the postmenopausal ovary that is unopposed by the premenopausal levels of estrogen, Jaffe 1989. Because menopausal women are in a high-risk age group for breast cancer, most gynecologists recommend breast self-examination and yearly mammography for menopausal and postmenopausal women. Hormone replacement therapy. The ideologic dispute as to whether menopause is a normal reproductive event, an endocrine deficiency disease, or an endocrinopathy requiring Med 248 Psychological Aspects of Women's Healthcare, 2nd edition Eichel intervention continues to rage. Does menopause need to be managed, or is it a reproductive event, like menarche, to be simply experienced? Indeed, it is unlikely that this dispute will ever be resolved, because it is a conceptual and not an empirical issue. The differing conceptualizations of menopause have a major impact on whether medical intervention ought to play a role. Perhaps a more dispassionate and more useful approach is one that weighs the short and long-term consequences of estrogen depletion for each individual woman. The variability among women with respect to the intensity and frequency of the early symptoms of hot flashes and cold sweats means that some are greatly disturbed by these vasomotor phenomena, whereas others experience them so mildly that they do not have any negative influence on daily functioning. Highly symptomatic women may be treated with HRT for a limited period until its gradual withdrawal does not provoke a resurgence of vasomotor disturbances. Another consideration is that, regardless of the severity of these vasomotor symptoms, all untreated women will in time develop atrophy of the estrogen-dependent urogenital tissues, which may give rise to symptoms such as atrophic vaginitis and urge incontinence. Whether a woman wishes to begin HRT to effectively alleviate these symptoms usually depends on her own assessment of the degree of discomfort she is experiencing. On the other hand, evidence now indicates that HRT can protect against degenerative diseases that seriously compromise the quality of life beyond the sixth decade. The two most compelling reasons for using long-term HRT are 1, that estrogen helps to maintain bone density, thereby protecting against osteoporosis, Lindsay et al. 1980, and 2, that estrogen administration reduces mortality from cardiovascular disease by 2/3, Bush et al. 1987, and ultimately reduces mortality from all causes by 10%, 60%, Henderson et al. 1991. Evidence from epidemiologic studies suggests, but does not prove, that HRT may also reduce the risk of Alzheimer's disease in women by 30%–50%, Paganini-Hill and Henderson 1996. The accumulated research findings therefore strongly suggest that postmenopausal women who receive HRT experience both increased longevity and an enhanced quality of life during the latter decades of their lifespan. Risks of hormone replacement therapy. It became clear in 1975 that the use of unopposed estrogen was associated with a marked increase in the incidence of endometrial cancer, Weiss et al. 1976. Adding a progestin to the therapy for 10 to 12 days each month effective menopause, Myths and Realities 249 protects the endometrium from the stimulatory effects of estrogen, Gelfand and Ferenczi 1989, and estrogen-progestin regimens given either continuously or in cyclic sequence are now recommended as HRT for women with an intact uterus. Orally administered estrogen induces changes in hepatic metabolism that could have adverse influences. Among these potential changes are increased production of renin substrate and decreased production of antithrombin 3, Deligniers et al. 1986. No increased incidence of hypertension or thrombosis has been noted, however, in postmenopausal women receiving oral estrogen replacement, Ettinger 1988. Considerable controversy has existed regarding the association between HRT and the incidence of breast cancer in postmenopausal women. A qualitative review of studies on estrogen and breast cancer published between 1970 and 1995 concluded that short-term use of estrogen, 5 years or less, does not increase breast cancer risk, whereas longer durations of use may be associated with a small but significant increase in risk, Uertz 1996. Despite the knowledge gained during the past 10 years with respect to the beneficial effects of HRT for postmenopausal women, its use is not mandated for all such women. For example, not every woman is at risk for the development of osteoporosis. Indeed, it has been established that tall, slim, small-boned Caucasian women who smoke are at greatest risk. The decision as to whether an individual woman is a suitable candidate for HRT should, therefore, be predicated on assessing her risks and providing her with information so that she can be a full partner in the decision-making process. Psychosocial issues for women in midlife. Psychologic theories. Historically, psychologic theorizing with respect to the etiology of menopausal symptoms first occurred within the psychoanalytic framework. The psychologic loss theory of menopause is based on the contention that the ability to bear children is central to the meaning of a woman's life. Logically, then, to lose this ability is to lose life's meaning, Deutsch 1945. Other Freudians have expressed the view that menopause is symbolic castration, Benedict 1950, and deprives the woman of any means of compensating for the anger, hopelessness, and frustration she has always felt at not being born a male, Prados 1967. With regard to treatment of symptoms that arise at this time, 250 Psychological Aspects of Women's Healthcare, 2nd edition. Psychoanalytic theory is geared toward helping women accept the mortification of menopause, Deutsch 1944. Sociocultural theories. The sociocultural model posits that the major determinants of psychologic disturbance at the time of menopause are role changes and cultural attitudes toward aging. The culture of a given society may be regarded as that which attributes meaning to reality and thereby transforms a natural or biologic event into a cultural event. It follows that the psychologic impact of menopause will be strongly influenced by the importance a particular culture attaches to procreation, fertility, aging, and female roles, Van Keep and Prill 1975. Cross-cultural studies have shown that menopause is indeed experienced differently in different cultures. In cultures in which women receive rights at menopause that were denied them during their fertile period, example some castes in India, menopausal symptoms are minimal, Flint 1975, Moz et al. 1977. Because North American society is youth-oriented and stereotypes of aging women are largely negative, our culture does not provide a supportive environment for menopausal women. Level of education and socioeconomic factors also seem to influence the experience of menopause. Several authors from different countries have reported that menopausal women with less education and from lower socioeconomic classes have a higher degree of symptoms at menopause than do more advantaged women, Jasmine et al. 1969, Moz et al. 1977, Van Keep and Kellerhals 1974. Postparental phase and other transitional phenomena. Menopause, of course, occurs during midlife, a time that is commonly regarded as a period of psychosocial transition and readjustment. Women who heretofore had heavily invested their emotion and energy in childbearing are forced to redefine their role at menopause because the children are growing up and leaving the home and reproductive capacity ceases. From the perspective of role theory, it would be important at this time to develop new, alternate roles in order to maintain self-esteem when old roles lose importance, Havigurist 1966. The departure of grown children from the parental home, which tends to occur coincident with menopause, has come to be known as the post-parental stage of life. Some authors hold that this change inevitably constitutes a psychologic loss because the mother loses one of her major roles. Menopause, Myths and Realities 251, and thus the rewards that accompanied it, Blood and Wolf 1960. This formulation, therefore, points to the conclusion that depression occurring during menopause may be caused by empty nest syndrome. In fact, a careful reading of the literature suggests that this conclusion is a function of the population studied. For example, menopausal women who are hospitalized with a major depressive disorder after their last child has left home have been characterized as having had overprotective or over-involved relationships with their offspring, Bart 1971, Bart and Grossman 1978. Results of general population surveys tell another story. In non-clinical populations, middle-aged women whose children had left home reported somewhat greater happiness, enjoyment of life in general, and greater marital harmony than did women of similar age with at least one child still living at home, Glenn 1975. The findings of this cross-sectional study are consistent with those of retrospective, Deutscher 1964, and longitudinal, Clausen 1972, investigations of the postparental stage in non-clinical populations. This evidence indicates that, for previously well-functioning middle-aged women, the so-called crisis of the empty nest is mythical. Certain life stresses may be temporally linked with menopause. Some of the negative events that may occur in a woman's life at this time include onset of a major illness or disability in her spouse, death of her spouse, employment uncertainty for either partner, the need to care for one's own elderly parent, and loss of support from important friends or family through illness, death, or geographic relocation. It is clear that stressful life events,
particularly losses or bereavements, may lead to somatic or psychologic symptoms for women during the climacteric, Green and Cook 1980, just as they do during other life phases. Studies of the impact of marital status on the experience of menopause are equivocal, probably because it is the quality and not the fact of the relationship that determines whether it serves as a buffer against other life stresses. Gov. ETAL 1983. Studies in the United States, McKinley ETAL 1987, and England, Hunter 1990, have found that single women were least likely to be depressed, followed by married women and those who were widowed, divorced, or separated. Moreover, less well-educated women who were widowed, divorced, or separated were the most likely to be depressed. Hunter 1990. Sexuality survey data generally show a considerable incidence of problems in various aspects of sexual functioning in postmenopausal women. Various studies 252 psychological aspects of women's health care, second edition have reported a 10%, 85% decrease in sexual interest, Cutler ETAL 1987, McCoy and Davidson 1985, and a 16%, 47% decrease in the frequency of orgasm, Hallstrom 1977, Kinsey ETAL 1953, in menopausal women. Although numerous studies have found that exogenous estrogen alleviates atrophic vaginitis and associated dyspareunia and increases vaginal lubrication, Morel ETAL 1984, Myers and Morokoff 1986, exogenous estrogen failed to increase sexual desire or libido. Several prospective studies of surgically menopausal women, however, have demonstrated that the addition of testosterone, which is normally produced by the ovaries, to an estrogen replacement regimen increased sexual desire, sexual arousal, and the frequency of sexual fantasies compared with women treated with estrogen alone. Sherwin ETAL 1985, Sherwin and Gelfand 1987. The consistency between these findings and those of investigators in England, Cardozo ETAL 1984, and Australia, Berger ETAL 1984, who used subcutaneously implanted pellets containing both estradiol and testosterone strongly suggests that in women, as in men, testosterone is the sex steroid that is critical for the maintenance of sexual desire. Numerous non-hormonal factors may also influence sexual functioning in postmenopausal women. Clearly, one such factor is the desire and capacity of the partner for sexual activity, Davidson ETAL 1983. A positive relationship also exists between previous sexual interest or importance of sex and the frequency of sexual activity in later middle life, Pfeiffer and Davis 1972. Finally, cultural and societal notions of sexual attractiveness and attitudes concerning the expression of sexuality beyond the reproductive years also have a significant influence on the maintenance of sexual activity in middle-aged and elderly women. Life begins at 50 with so much emphasis on the negative impact of the changing hormonal milieu and the losses and life stresses that often occur coincident with menopause. The fact that this reproductive event is welcomed as a positive event by many women is frequently ignored. For example, the departure of children from the home also means that women are able to redirect their time and energy to tasks and activities that bring other important sources of gratification. Re-entering the workforce or devoting more time to an already established career, travel, and other leisure activities are all potential benefits of the post-parental years. Solid marital relationships may become closer and more intimate at a time when a couple has more opportunity to spend time alone. Menopause, Myths and Realities 253 together. Moreover, the absence of menstrual cycles and the accompanying freedom from the need to be concerned about birth control methods may serve to enhance the sexual relationship. Although the climacteric can be characterized as potentially offering the opportunity for freedom to explore new roles, it should be noted that this freedom presumes both the time and the personal and economic resources for such explorations, which a middle-class bias often ignores. Menopause and the mental health professional. The most common reason for referring a menopausal woman to a mental health professional is for the diagnosis and treatment of a depressive disorder associated with the endocrine changes occurring during this reproductive event. Recent studies have failed to confirm the existence of involutional melancholia as a distinct subtype of depressive illness, leading to its removal from current psychiatric nomenclature. A great deal of evidence has shown, however, that depressive symptoms, if not a distinctive syndrome, are experienced by many women at the time of menopause. Clinical observations suggest that women who experienced premenstrual syndrome during their reproductive years and those with a history of depressive illness may be at a greater risk for the development of a depressive episode at the time of menopause than are women without such a history. The initial approach to the management of mood and behavioral information on disturbances in menopausal women requires information on the woman's symptoms and the hormonal context in which they occur, a personal history of depression, a family history of affective disorder, feelings about aging and mortality, and concurrent life stresses. If a woman is experiencing distressing signs of estrogen deficiency, such as hot flashes and vaginal dryness, has no contraindications to HRT, such as a history of breast cancer, and does not fulfill diagnostic criteria for a major depressive disorder, then a trial of HRT may be indicated as a first approach. Women who have undergone surgical menopause usually experience more severe symptoms of estrogen deficiency, owing to the abruptness of the change in their hormonal milieu. In the absence of contraindications, HRT would be particularly important for these women. In these cases, it is also critical to explore the psychologic impact of the hysterectomy and bilateral oophorectomy and the reasons that necessitated the surgery. Because of the demonstrated ability of estrogen to alter the concentric 254 psychological aspects of women's health care, second edition genes or availability of neurotransmitters in the synapse, it is possible that menopausal women with affective symptoms in the presence of mild or minimal hypoestrogenic somatic symptoms may also respond to a trial of HRT. It is important to note, however, that presently no evidence suggests that a major depressive illness will be significantly alleviated by the doses of estrogen conventionally used to treat postmenopausal women. The decision to institute adjunctive psychopharmacotherapy will depend on the severity and duration of the depressive symptoms and on the premorbid and family history of affective illness. Acknowledgement: the preparation of this manuscript was supported by a grant from the Medical Research Council of Canada, No. MA 11623, awarded to B.B. Sherwin. References: Anderson E., Hamburger S., Liu J.H., et al., Characteristics of Menopausal Women Seeking Assistance. AMJ Obstet Gynecol 156:428, 433, 1987. Avis N., Brambilla D., McKinley S.M., et al., A Longitudinal Analysis of Association Between Menopause and Depression, Results from the Massachusetts Women's Health Study. AEP 4:15, 21, 1994. Aylward M., Plasma tryptophan levels and mental depression in postmenopausal subjects, effects of oral piperazine sulfate. IRCS Journal of Medical Science 1:30, 34, 1973. Aylward M., Estrogens, Plasma tryptophan levels in perimenopausal patients, in the management of the menopause and postmenopausal years. Edited by Campbell S. Baltimore M.D., University Park Press, 1976, pp 135-147. Bollinger C.B., Psychiatric Aspects of the Menopause. BRJ Psychiatry 156:773, 787, 1990. Bart P.B., Depression in Middle-Aged Women, in Women in Sexist Society. Edited by Gornick V., Morgan B.K. New York, Basic Books, 1971, pp 163-186. Bart P.B., Grossman M., Menopause, in the Woman as Patient. Edited by Notman M., Nadal Sun C. New York, Plenum, 1978. Benedict T., Climacterium, A Developmental Phase. Psychoanal Q11:19, 26, 1950. Benirshka K., The Endometrium, in Reproductive Endocrinology, 2nd edition. Edited by Yen S.S.C., Jaffe R.B. Philadelphia PA, W.B. Saunders, 1986, pp. 385-405 Menopause, Myths and Realities 255 Bergman A., Brenner P.F., Alterations in the Urogenital System, in Menopause, Physiology and Pharmacology. Edited by Michelle Dr. Chicago, I.L., Yearbook Medical, 1987, pp. 67-75 Blood R.O., Wolf D.M., Husbands and Wives, The Dynamics of Married Living. New York, Free Press, 1960 Brenner P.F., The Menopause Syndrome. Obstet-Gynecol 72, Supple 6, 11, 1988 Bungay G.T., Vesey M.P., McPherson C.K., Study of Symptoms in Middle Life with Special Reference to the Menopause. BMJ 2:181, 183, 1980 Berger H.G., Hyles J., Manilaws M., et al., The Management of Persistent Menopausal Symptoms with Estradiol Testosterone Implants, Clinical, Lipid, and Hormonal Results. Maturita 6:351, 358, 1984 Bush T.L., Barrett Connor E., Cowan L.D., et al., Cardiovascular Mortality and Non-Contraceptive Use of Estrogen in Women, Results from the Lipid Research Clinics Program Follow-Up Study. Circulation 6:1102, 1109, 1987 Cardozo L., Gibb D.M.F., Tuck S.M., et al., The Effects of Subcutaneous Hormone Implants During the Climacteric. Maturitas 5:177, 184, 1984 Chakravarti S., Collins W.P., Newton J.R., Endocrine Changes and Symptomatology After Oophorectomy in Premenopausal Women. B.R.J. Obstet-Gynecol 84:769, 776, 1977 Chamness G.C., King T.W., Sheridan P.J., Androgen Receptors in the Rat Brain, Assays and Properties. Brain Res 161:267, 273, 1979 Charnita, Stewart de, Psychiatric Aspects, in A Clinician's Guide to Menopause. Edited by Stewart de, Robinson G. Washington, D.C., American Psychiatric Press, 1997, pp. 129-144 Clausen J.A., The Life Course of Individuals, in Aging and Society, Vol. 3. Edited by Riley M. W., Johnson M., Foner A. New York, Russell Sage Foundation, 1972 Cook J., Thompson J., Polar L., Estrogen Administration and Hot Flushes in Menopausal Women. BMJ 4:139, 143, 1975 Cutler W.B., Garca C.R., McCoy N.L., Perimenopausal Sexuality. Arch Sex Behov 16:225, 234, 1987 Davidson J.M., Chen J.J., Crapo L., et al., Hormonal Changes and Sexual Function in Aging Men. J. Clin Endocrinol Metab 51:19, 28, 1983 Deligniers B., Bastavante, Thomas G., et al., Biological Effects of Estradiol 17 Beta in Postmenopausal Women, Oral versus Percutaneous Administration. J. Clin Endocrinol Metab 62:536, 541, 1986 Denner-Stein L., Burroughs G.D., Hyman G.J., Hormone Therapy and Affect. Maturitas 1:247, 259, 1979 Deutsch H., The Psychology of Women. New York, Grun and Stratton, 1944 Deutsch H., The Psychology of Women, Vol. 2. New York, Grun and Stratton, 1945 Deutscher J., The Quality of Postparental Life. Journal of Marriage and the Family 26:5259, 1964 256 Psychological Aspects of Women's Healthcare, 2nd edition Edinger B., Optimal Use of Postmenopausal Hormone Replacement Therapy. Obstet-Gynecol 82, Supple 31, 36, 1988 Uertz M., Hormone Therapy in the Menopause and Breast Cancer Risk, a Review. Maturitas 23:241, 246, 1996 Flint M., The Menopause,
reward or punishment. Psychosomatics 16:161, 173, 1975 Gelfand M.M., Ferencier, a prospective one-year study of estrogen and progestin in postmenopausal women, effects on the endometrium. Obstet Gynecol 74:398 402, 1989 George G.C.W., Beaumont P.J.V., Beardwood C.J., effects of exogenous estrogens on minor psychiatric symptoms in postmenopausal women. S. Aframet J. 47:2387 2388, 1973 Glenn N.D., Psychological Well-Being in the Postparental Stage, Some Evidence from National Surveys. Journal of Marriage and Family 32:105, 110, 1975 Gove W.R., Hughes M., Style C.B., Does Marriage Have Positive Effects on the Psychological Well-Being of the Individual? J. Health SOC Hop 24:122, 131, 1983 Green J.G., Cook D.J., Life Stress and Symptoms at the Climacterium. BRJ Psychiatry 136:486, 491, 1980 Hallstrom T., Sexuality in the Climacteric. Clin Obstet Gynecol 4:227, 239, 1977 Havigurst R.J., Changing Roles of Women in the Middle Years, in Potentialities of Women in the Middle Years. Edited by Gross J. Lansing M.I., Michigan State University Press, 1966 Henderson B., Paganini Hill A., Ross R.K., Decreased Mortality in Users of Estrogen Replacement Therapy. Arch Intern Med 151:75, 78, 1991 Hunter M.S., Psychological and Somatic Experience of the Menopause, a Prospective Study. Psychosome Med 52:357, 367, 1990 Hunter M.S., Whitehead M.J., Psychological Experience of the Climacteric and Postmenopause, in Menopause, Evaluation, Treatment, and Health Concerns. Edited by Hammond C.B., Hasseltine F.P. New York, Allen R. Liss, 1989, pp 211-224 Jaffe R.B., The Menopause and Postmenopausal Period, in Menopause, Evaluation, Treatment, and Health Concerns. Edited by Hammond C.B., Hasseltine F.P. New York, Allen R. Liss, 1989, pp 406-423 Jasmine L., Van Lith W.D., Zoe J. L., The Perimenopausal Syndrome, The Statistical Analysis of a Survey. Medical Gynecology 4:268, 272, 1969 Judd Hill Judd G.E., Lucas W., et al., Endocrine Function of the Postmenopausal Ovary, Concentrations of Androgens and Estrogens in Ovarian and Peripheral Vein Blood. J. Clin Endocrinol Metab 139:1020, 1026, 1974 Cowford P., Syratook J., Symptom Reporting at the Menopause. SOC Sci Met 15:173, 184, 1981 Kelly M.J., Mass R.L., Dudley C.A., The Effect of Microelectrophoretically Applied Estrogen, Cortisol, and Acetylcholine on Medial Preoptic Septal Unit Activity through the Estrous Cycle of the Female Rat. EXP Brain Rest 30:53, 64, 1977 Menopause, Myths and Realities 257 Kinsey A.C., Pomeroy W.B., Martin C.E., et al., Sexual Behavior in the Human Female. Philadelphia PA, W.B. Saunders, 1953 Klaber L., Broverman D.M., Vogel W., et al., Effects of Estrogen Therapy on Plasma Mao Activity and EEG Driving Responses of Depressed Women. AMJ Psychiatry 128:1492, 1498, 1972 Klaber L., Broverman D.M., Vogel W., et al., Estrogen Therapy for Severe Persistent Depression in Women. ArchGen Psychiatry 36:550, 554, 1979 Lindsay R., Hart D.M., Forrest C., et al., Prevention of Spinal Osteoporosis in Oophorectomized Women. Lancet 2:1151,
1154, 1980 Lipset MB, Steroid Hormones, in Reproductive Endocrinology, Physiology, Pathophysiology and Clinical Management. Edited by Yen SSC, Jaffe RB. Philadelphia PA, W.B. Saunders, 1986 Longcope C, Metabolic Clearance and Blood Production Rates in Postmenopausal Women. AMJ Obstet Gynecol 111:779, 785, 1981 Longcope C, Adrenal and Gonadal Steroid Secretion in Normal Females. J. Clin Endocrinol Metab 15:213, 220, 1986 Lewin V. N., Kilchevskia R. J., McEwen B., Effect of gonadal steroids on activities of monoamine oxidase and choline acetylase in rat brain. Brain Res 86:293, 306, 1975 Mosby, Antonovsky A., Apter A., et al., The Perception of Menopause in 5 Ethnic Groups in Israel. Acta Obstet Gynecol Scan 65:69, 76, 1977 McCoy N.L., Davidson J.M., A Longitudinal Study of the Effects of Menopause on Sexuality. Maturita 7:203, 209, 1985 McEwen B.S., The Brain as a Target Organ of Endocrine Hormones, in Neuroendocrinology. Edited by Krieger D.T., Hughes J.S. Sunderland Mott, Sinauer Associates, 1980, pp 33-42 McEwen B.S., The Molecular and Neuroanatomical Basis for Estrogen Effects in the Central Nervous System. J. Clin Endocrinol Metab 84:1790, 1797, 1999 McKinley J.B., McKinley S.M., Brambilla D., The Relative Contribution of Endocrine Changes and Social Circumstances to Depression in Mid-Aged Women. J. Health SOC Behop 28:345, 363, 1987 Morel M.J., Dixon J.M., Carter S., et al., The Influence of Age and Cycling Status on Sexual Arousability in Women. AMJ Obstet Gynecol 148:166, 174, 1984 Myers L.S., Morokoff P.J., Physiological and Subjective Sexual Arousal in Pre- and Postmenopausal Women Taking Replacement Therapy. Psychophysiology 23:283, 290, 1986 Naftolan F., Ryan K.J., The Metabolism of Androgens in Central Neuroendocrine Tissues. J. Steroid Biochem 6:993, 997, 1975 Ostergaard Drive, Embryology and Anatomy of the Female Bladder and Urethra, in Gynecologic Urology, Therapy and Practice. Edited by Ostergaard Dr. Baltimore M.D., Williams and Wilkins, 1980, pp 3-10 258 Psychological Aspects of Women's Healthcare, 2nd edition Paganini Hill A., Henderson V.W., Estrogen Replacement Therapy and Risk of Alzheimer's Disease. Arch Intern Med 156:2213, 2217, 1996 Parisham, Carr C.A., Hall D.G., et al., Time Interval from Castration in Premenopausal Women to Development of Excessive Coronary Atherosclerosis. AMJ Obstet Gynecol 99:155, 162, 1967 Pfeiffer E., Davis G.C., Determinants of Sexual Behavior in Middle and Old Age. JAM Geriatra SOC 4:151, 160, 1972 Prados M., Emotional Factors in the Climacterium of Women. Psych Other Psychosome 15:231, 244, 1967 Shiffey, Regenstein Q., Skinfeld J., et al., Interactions of Oestrogens and the Hours of Sleep on Cortisol, FSH, LH, and Prolactin in Hypogonadal Women. Maturitas 2:179, 183, 1980 Shieldkraut J.J., The Catecholamine Hypothesis of Affective Disorders, A Review of Supporting Evidence. AMJ Psychiatry 122:509, 522, 1965 Schneider Mott, Brotherton P.L., Hyles J., The Effect of Exogenous Oestrogens on Depression in Menopausal Women. Met J. Os 2:162, 163, 1977 Sherwin B.B., Effective Changes with Estrogen and Androgen Replacement Therapy in Surgically Menopausal Women. J. Effectisord 14:177, 187, 1988 Sherwin B.B., Gelfand M.M., Effects of Parenteral Administration of Estrogen and Androgen on Plasma Hormone Levels and Hot Flushes in the Surgical Menopause. AMJ Obstet Gynecol 148:552, 557, 1984 Sherwin B.B., Gelfand M.M., Sex Steroids and Effect in the Surgical Menopause, a double-blind crossover study. Psychoneuroendocrinology 10:325, 335, 1985 Sherwin B.B., Gelfand M.M., The Role of Androgen in the Maintenance of Sexual Functioning in Oophorectomized Women. Psychosome Met 49:397, 409, 1987 Sherwin B.B., Suranika.B., Upregulatory Effect of Estrogen on Platelet 3 Hemipramine Binding Sites in Surgically Menopausal Women. Biopsychiatry 28:339, 348, 1990 Sherwin B.B., Gelfand M.M., Brender W., Androgen Enhances Sexual Motivation in Females, a Prospective, Crossover Study of Sex Steroid Administration in the Surgical Menopause. Psychosome Met 47:339, 351, 1985 Stahl S.M., Basic Psychopharmacology of Antidepressants, Part 2, Estrogen as an Adjunct to Antidepressant Treatment. J. Clin Psychiatry 59, Supple 415, 24, 1998 Thompson B., Hart S.A., Durno D., Menopausal Age and Symptomatology in a General Practice. J. Biosoxy 5:71, 82, 1973 U.S. Bureau of the Census, Projections of the Population of the United States, 1977 to 2050. Kerpop Rep Series P25, number 704, 1990 Yushin W., Ser D., The Climacteric Syndrome, in Consensus on Menopause Research. Edited by Van Keep P.A., Greenblatt R., Furnett A. Lancaster, UK, MTP Press, 1976, pp 1-4 Menopause, Myths and Realities 259 Van Keep P.A., Kellerhals J.M., The Impact of Sociocultural Factors on Symptom Formation. Psych Other Psychosome 23:251, 263, 1974 Van Keep, Prill H.J., Psychosociology of Menopause and Postmenopause, in Estrogen in the Postmenopause. Edited by Lauritsen C., Van Keep P.A. Basel, Switzerland, Karger, 1975 Weiss N.S., Seekley R., Austin D.F., Increasing Evidence of Endometrial Cancer in the United States. Ann English J. Met 294:1259, 1262, 1976 Weissmann M.M., The Myth of Involutional Melancholia. JAMA 242:742, 744, 1979 Winokur G., Depression in the Menopause. AMJ Psychiatry 13092, 93, 1973 Wise P.M., Weiland N.G., Scarborough K., et al., Changing Hypothalamo-Pituitary Function, Its Role in Aging of the Female Reproductive System. Hormres 3139, 44, 1989 This page intentionally left blank. 13 Chronic Gynecologic Pain John F. Steege, M.D. Anna L. Stout, Ph.D. This chapter reviews vulvovaginitis and chronic pelvic pain, two of the most vexing problems in clinical gynecology. Both problems are marked by their often chronic and intractable natures as well as by the frequent contribution of psychologic factors to their severity. They represent opportunities for effective collaboration between the gynecologic and mental health specialties. Types of chronic gynecologic pain: vulvovaginitis, vaginal yeast infections, trichomoniasis, and the mixed infection of bacterial vaginosis are extremely common. Manilial, yeast, vaginitis typically is marked by a white, cheesy discharge, trichomoniasis, Trichomonas vaginalis infection, by a frothy, mildly malodorous discharge, and bacterial vaginosis by a chronic, intermittent, irritating, and malodorous discharge. Women with such clearly identifiable acute symptoms and signs will seldom require mental health consultation. Many women with these disorders, however, may later develop chronic continuing vaginal and vulvar symptoms, even though the bacteriologic precipitants may have been brought under control. The possible role of psychologic factors in perpetuating symptoms may lead to referral for psychologic evaluation. More troubling than these entities is the patient who undergoes careful, frequent examinations with no pathogenic organisms visualized. Gynecologists often recognize that such individuals may be unduly focused on any per 262 psychological aspects of women's health care, 2nd edition sieved irregularities of vaginal sensation or secretion. Intense symptoms of vaginal discomfort may be a calling card or presenting symptom for affective disorders, anxiety disorders, marital discord, somatization tendencies, or sexual dysfunction. For example, continued dyspareunia may be caused by vaginismus triggered by repeated uncomfortable vaginal events associated with vaginitis. When pain persists, the patient may return to her physician, claiming that her vaginitis is back, assuming that any pain in this area must be caused by recurrent infection. This situation may benefit from collaboration between the gynecologist and the mental health clinician. In the postmenopausal patient, specific vaginal infections are far less common, except for atrophic vaginitis in women who are not receiving estrogen replacement therapy. Postmenopausal women, however, are prone to the development of vulvar dystrophies, which can present with intense vulvar burning and itching in the absence of any significant vaginal infection. These distressing symptoms can become such an impediment to normal functioning that they may precipitate depressive episodes. Conversely, vulvar symptoms may represent a depressive equivalent. Chronic pelvic pain. Pelvic pain is usually defined as chronic when it has lasted for 6 months or more on a continuous or a cyclic basis. It may be useful to distinguish between patients who have pain that is chronic and those who have a true chronic pain syndrome. In chronic pain syndrome, the pain is accompanied by impaired function in recreational activities and household responsibilities, possible vegetative signs of depression, especially sleep disturbance, and significant alterations in the patient's roles within her family, STGTAL 1991. Psychologic evaluation and treatment are often helpful in such patients. Dyspareunia, or painful intercourse, is usually described as being either introital, in the area around the opening of the vagina, or deep, stage 1984. Patients often describe introital dyspareunia as pain at the opening or as trouble getting in during intercourse. The pain is usually continuous but can be exacerbated perimenstrually in the presence of contributing factors, such as recurrent nonilial vaginitis or inflammation of the vestibule. Deeper pelvic pain is often described as pain inside or by noting that the partner's penis feels as though it hit something. Traditionally, deep dyspareunia has chronic gynecologic pain 263 been felt by gynecologists to be more likely caused by organic factors, whereas introital dyspareunia is more often psychologically based. Although these generalizations are still partly valid, enough exceptions occur to impel careful inquiry into all aspects of the problem. A careful history should delineate the location of the pain, the relationship of the pain to the sexual response cycle, and any alterations of the sexual response cycle. Tactful inquiry should be made regarding any variation of symptoms with different sexual partners. General pelvic pain that is present over the entire lower pelvic area, sometimes greater in intensity on one side than on the other, may occur on either a cyclic or a continuous basis. Cyclic discomforts are more typically associated with endometriosis, although pain associated with pelvic adhesive disease can also be somewhat cyclic, being worse before and during menstruation. Similarly, pain that is possibly attributable to pelvic congestion, overdistension of the pelvic venous system, will often be worse premenstrually, Beard et al. 1989. Worsening endometriosis often starts out as cyclic dysmenorrhea, with the pain gradually subsuming more and more of the menstrual month as time goes on. Continuous pain is more often caused by adhesive disease that is either post-infectious or post-surgical in nature. Dyspareunia may be present, along with chronic daily pain. It is more common when the pelvic pathology is central in location rather than in the adnexal areas. The role of organic pathology in the pathophysiology of chronic pelvic pain is poorly understood despite research efforts, STGTAL 1991. Most series in the literature report that no abnormal laparoscopic findings are present in approximately 10%, 60% of women undergoing this procedure for evaluation of chronic pelvic pain. These numbers, however, may be an overestimation of the percentage of negative pelvic findings, because most of the studies were published before it was recognized that endometriosis can present in atypical or unpigmented forms. A woman with negative findings on laparoscopy may nevertheless have some physical contributions to her pain, such as trigonitis, urethritis, functional pelvic musculoskeletal problems, postural changes, or irritable bowel syndrome. Some of the studies describing psychologic profiles in women with negative laparoscopies fail to describe evaluations for such problems. Sizable fractions of women with organic pathology also demonstrate substantial psychologic changes on psychometric testing and clinical or structured interview, Castelnuovo Tedesco and Kraut 1970. This confusing 264 psychological aspects of women's healthcare, second edition picture makes it clinically difficult to decide in an individual case whether the primary difficulty is physiologic or psychologic. For example, several studies document that women with organic pathology, most often endometriosis or adhesions, will more often have pelvic pain than those without any organic pathology. Although the location of the pain often correlates with the location of the pathology, the intensity of the pain demonstrates no quantitative relationship to the amount of tissue change present. Fidela et al. 1990, Stout et al. 1991. It therefore remains a matter of difficult clinical judgment to decide on the appropriate medical or surgical treatments of the organic pathology. Diagnosis and treatment. Vulvovaginal symptoms. Vulvovaginitis. A complete evaluation of vulvovaginitis includes a careful history of sexually transmitted diseases, use of intrauterine devices, the medical risk factors described previously in this chapter, and a sexual history. Physical examination should include a complete routine pelvic examination as well as a microscopic examination of the vaginal secretions for the detection of trichomonas, a search for the clue cells indicative of bacterial vaginosis, and a rough quantitation of yeast forms. Specific cultures for yeast are seldom of benefit, because they are often positive in asymptomatic women and do not provide a quantitative measure. T. vaginalis cultures may be useful in the rare instance when symptoms appear to be typical of that disease, but the microscopic test is not diagnostic. Cultures for bacterial vaginosis are useful only on a research basis. In the postmenopausal woman with intense vulvar symptoms, careful visual inspection of the vulva is essential. A biopsy should be performed to evaluate any suspected abnormalities. Vulvar carcinoma is notoriously difficult to recognize visually, and the vulvar dystrophies are so varied in appearance that biopsy is often necessary for proper diagnosis. In many situations these diagnostic tests are indeterminate, yet the symptoms persist. Often, the gynecologist in this situation may prescribe topical steroids and other vaginal medications as therapeutic trials. When the mental health professional sees such a patient, it is often useful to initiate a candid dialogue with the gynecologist to better understand the degree to which bacteriologic or fungal diagnoses are truly well established. Chronic gynecologic pain. 265 Vulvodynia. Vulvar pain without any evidence of visual or intraepithelial change is a perplexing problem for both the gynecologist and the mental health professional. Investigation by routine histologic and culture techniques is often unrevealing. Present studies are focused on the potential role of human papillomavirus in this disorder, but results are far from conclusive. Although allowing the possibility of as yet undiscovered organic etiologies, health professionals must be prepared to deal with the often simultaneous problems of significant depression and despair for such patients in the face of continuing symptoms. These symptoms may also be somatic symptoms of a primary psychiatric condition. Chronic pelvic pain. Adequate assessment of chronic pelvic pain includes a careful chronologic history of pain development as it affects the woman's daily life. Disability often develops gradually, and particular inflection points in the curve of disability may be punctuated by external life events or events within the family. A careful history should also include the chronology of the development of any particular sexual dysfunctions. Although such dysfunctions may be initially triggered by organic events, they may become chronic. Sexual dysfunctions may be more apt to occur in women with previous difficulties in sexual adjustment. In a careful physical examination for chronic pelvic pain, the examiner should systematically look for vulvar epithelial changes and sensitivity, vaginal introital muscle tone and control, levator plate tension, cervical motion tenderness, and general pelvic tenderness during the bimanual and rectovaginal examinations. The two conditions most often associated with chronic pelvic pain, endometriosis and adhesions, are often difficult to detect by physical examination and imaging techniques. Laparoscopy should be freely used for diagnosis and probably for treatment of these conditions. In one encouraging report of laparoscopic adhesiolysis, long-term relief was noted in 75% of women without a chronic pain syndrome as defined previously in this chapter, and in 40% of those with chronic pain syndrome, Steege and Stout 1991. Other reports have noted improvement rates of 50%, 85% following such procedures, Daniel 1989, Sutton and McDonald 1990, depending to some extent on the degree of adhesive disease treated. 266 Psychological Aspects of Women's Healthcare, 2nd edition. Psychologic aspects of chronic gynecologic pain. Early reports in the medical literature implied that women who reported chronic pelvic pain had a high degree of feminine identity problems arising from conflicts regarding adult sexuality. Gidro-Frank et al. 1960, psychiatric disturbance characterized by mixed character disorders with predominant schizoid features, Castelnuovo Tedesco and Kraut 1970, and high neuroticism and unsatisfactory relationships, Beard et al. 1977. Studies by Duncan and Taylor, 1952, and Benson et al. 1959, reported an association between the onset of symptoms of pelvic pain and emotional stress. Although these initial studies identified the importance of psychologic factors in patients with chronic pelvic pain, some of their generalizations about psychopathology have been questioned from several perspectives. Because some physical abnormalities that cannot be identified on pelvic examination can often be observed on laparoscopic surgery, women who were considered to have normal pelvic examinations in early studies may be diagnosed with some type of organic pathology if evaluated by currently accepted diagnostic procedures. In a study of 1,200 women undergoing diagnostic laparoscopy for pelvic pain, Cunanan et al. 1983, found that 63% of the women with normal pelvic examinations before diagnostic laparoscopy had abnormal findings on diagnostic laparoscopy. On the other hand, questions have been raised about the assumption of a cause and effect relationship between physical findings and pain symptoms. Kresch et al. 1984, identified some possible pathologic conditions in 29% of asymptomatic women who underwent laparoscopic surgery for tubal ligation. Recent work with diagnostic laparoscopy under conscious sedation technique, with the purpose of mapping the association of pain with pelvic organs and their pathology, may provide clinically useful information about both the patient's general level of visceral and somatic sensitivity and the role of pelvic pathology in causing pain. Palter et al. 1996, Steege 1997. Conclusions of previous studies suggesting the high prevalence of psychopathology are called into question by other methodologic issues, including 1. A selection bias in the sample of patients studied psychologically, because of the high refusal rates for psychologic assessment reported in some studies. 2. A potential bias of psychologic evaluators not blinded to the presence or absence of organic disease, and 3. A lack of appropriate control groups to establish population base rate data. 4. Psychosocial factors.
such as marital and sexual adjustment difficulties. In all of the studies of which we are aware, limited information is available on the psychologic status of chronic gynecologic pain. 267 pelvic pain samples before onset of pain. Some of the confusion about the relative contribution of psychologic factors in chronic gynecologic conditions has probably arisen because of the varying definitions of chronic pelvic pain and other gynecologic conditions. At least 3 different operational definitions of chronic pelvic pain appear in the literature with some frequency. These definitions focus on different aspects of the chronic condition. 1. Duration, chronic pelvic or gynecologic pain that has lasted 6 months or longer, a time marker used in other chronic pain conditions. 2. Anatomic chronic, pelvic or gynecologic pain lacking an apparent physical cause sufficient to explain it. And 3. Affective behavioral, pain accompanied by significant disturbance of mood and altered physical activities such as work, recreational, or sexual activity. Studies in which psychologic inquiry has focused on patients for whom no apparent physical findings can be identified may reflect more psychologic contributions to the pain. Obviously, chronic pelvic pain samples selected on the basis of accompanying affective disturbance may be expected to reflect a strong association with depressive symptoms. Other studies that have selected patients with chronic pelvic pain on the basis of pain duration may include women with documented organic pathology, most commonly endometriosis and pelvic adhesive disease. However, these women may report varying levels of pain severity and impairment. Stout et al., 1991, reported that the extent of physical disease evaluated by diagnostic laparoscopy did not correlate significantly with ratings of pain levels or several other indices of impairment. These findings confirmed the need for exploration of other factors such as psychologic variables, which have been shown to account for a significant portion of individual differences in functional impairment in other pain conditions. In the literature on chronic pain, investigators have examined several personality variables, including anxiety, depression, and certain patterns on personality inventories that have been described as neurotic, particularly those characterized by hypochondriasis and somatization tendencies. Sternbach 1974. In several studies, Chaturvedi 1988, Papchik et al. 1987, Postone 1986, alexithymia, lack of words for feelings, has been investigated as a personality characteristic that may promote and maintain pain symptoms. Bradley et al., 1981, pointed out that an important shortcoming of many personality studies is that most such studies of patients with chronic pain present composite responses, therefore fostering an inaccurate picture of homogeneity in these patients. Keefe et al., 1986, found that depression was a significant predictor of pain behavior in patients with low back pain independent of 268 psychological aspects of women's health care, second edition demographic or medical status variables. However, psychologic variables, depression, anxiety, helplessness, were not found to be independent predictors of pain behaviors in patients with rheumatoid arthritis. Anderson et al. 1988, pointing out the danger of generalizing from one chronic population to another. In reviewing studies of chronic pelvic pain, specifically focusing on those in which diagnostic laparoscopy was used to investigate the organic component, and other chronic gynecologic conditions, an association has been noted between these conditions and certain psychologic variables. Rosenthal et al., 1984, administered the Minnesota Multiphasic Personality Inventory, MMPI, Hathaway and McKinley 1970, to 163 consecutive patients referred for chronic pelvic pain, 60 of whom underwent diagnostic laparoscopy. The most frequent finding was a somatizing pattern, elevations on scales 1 and 3. Abnormal physical findings were present in 75% of the women who underwent diagnostic laparoscopy. However, 75% of those patients thought to have an organic cause for their pain also had evidence of psychopathology on the MMPI. The MMPI was therefore a poor predictor of organic pathology. Magna et al., 1986, examined the psychologic characteristics of 30 women who underwent diagnostic laparoscopies for chronic pelvic pain and 30 matched controls using the Middlesex Hospital Questionnaire, Crown and Crisp 1966, and the Zung Self-Rating Depression Scale, Zung 1965. No differences in somatization scores were observed in patients with chronic pelvic pain with or without organic pathology, although both groups had higher scores than did control subjects. Patients with pelvic pain and without observed physical pathology were, however, more depressed than were patients with organic pelvic pain and controls. Harrop Griffiths et al., 1988, used a structured psychiatric interview, the National Institute of Mental Health Diagnostic Interview Schedule, Robbins et al. 1981, in a study of 25 women with chronic pelvic pain and 30 women with other gynecologic concerns. They found that patients with chronic pelvic pain had a significantly higher prevalence of lifetime major depression, current major depression, lifetime substance abuse, adult sexual dysfunction, and somatization. Stout and Steege, 1991, found that 50% of 294 women seeking evaluation at a pelvic pain clinic scored in the depressed range, 16, on the Center for Epidemiologic Studies Depression Scale, Radloff 1977, at the time of their initial visit. Slocum et al., 1989, found that patients with abdominal pelvic pain syndrome scored higher as a group on the Hopkins Symptom Checklist, Derogatis et al. 1974, Scales of Anxiety, Depression, Anger Hostility, and Somatization. They also pointed out, however, that 56% of chronic gynecologic pain 269 the patients with pain rated themselves within the normal range on all scales. Stewart et al., 1990, found that women with clinically unconfirmed vulvovaginitis were significantly more emotionally distressed than were the women with confirmed vulvovaginitis and healthy control subjects. Sexual history has been explored in several inquiries, indicating that women seeking treatment have a high incidence of sexual trauma, including molestation, incest, and rape. Beard et al. 1977, Duncan and Taylor 1952, Gross et al. 1980, Haber and Roos 1985, Raskin 1984, Ryder and Gambone 1990, Shea 1991, Walker et al. 1988. In the study by Harrop Griffiths et al., 1988, the two groups undergoing diagnostic laparoscopies were also administered a structured interview on sexual abuse. Patients with chronic pelvic pain with or without positive laparoscopy findings were more likely than control subjects to have experienced childhood and adult sexual abuse. In the study by Ryder and Gambone, 1990, 48% of 106 women with chronic pelvic pain had a history of major psychosexual trauma, molestation, incest, and rape, as compared with 6.5% in a control group of 92 pain-free control subjects presenting for annual routine gynecologic examinations, p. 0.001. Rapkin et al., 1990, did not find a higher prevalence of childhood or adult sexual abuse in a group of women with chronic pelvic pain than in women with chronic pain in other locations or in control subjects, although women with chronic pelvic pain reported a higher prevalence of childhood physical abuse. The authors concluded that their findings did not support the hypothesis that pelvic pain is specifically and psychodynamically related to sexual abuse and suggested that abusive experiences, whether physical or sexual, may promote the chronicity of many different painful conditions. As might be expected, many of these same studies also report a high incidence of marital distress. Stout and Steege, 1991, found that 56% of 220 married women presenting for evaluation of chronic pelvic pain scored in the maritally distressed range, 100, on the Locke-Wallace Marital Adjustment Scale, Locke and Wallace 1959. Women presenting with chronic gynecologic conditions often present with concomitant sexual dysfunction, particularly dyspareunia. Although establishing accurate baseline functioning is difficult, some women report satisfactory sexual functioning before the onset of pain symptoms,
whereas others appear to have long-standing sexual difficulties. In any case, sexual dysfunction is likely associated with chronic gynecologic pain, either as an antecedent or as a consequence. Decreased sexual desire and conditioned vaginismus are correlates of this problem that often need specific intervention in addition to any indicated medical treatment. 270 Psychological Aspects of Women's Healthcare, 2nd edition. Because studies to date have been cross-sectional in design, it is not possible to determine whether the negative psychologic states reported are a predisposing factor or a reaction to the pain condition. It is important to note that no significant differences in personality or psychosocial variables have been found in most studies of women with chronic pelvic pain with or without identified organic pathology, perhaps suggesting that chronic pelvic pain in some women may be more closely associated with psychosocial factors than with organic factors. In reviewing the literature regarding the relationship between chronic pain and depression, Romano and Turner, 1985, concluded that at least two distinct groups of chronic pain patients may exist, one subgroup in which pain and depression are a final common presentation reached by a number of pathways, and a second group in which depression develops in reaction to pain, as occurs in some other acute and chronic medical diseases. Patients with chronic gynecologic conditions also appear to be a heterogeneous group. However, the high prevalence of sexual trauma, marital and sexual dysfunction, and emotional distress in previously studied samples of these patients warrants specific attention to these areas in any clinical evaluation. Further research is needed to explore whether these psychosocial factors have a specific relationship to the development and persistence of chronic gynecologic conditions. Management of chronic gynecologic pain. In current gynecologic practice, the woman usually referred for psychiatric care has had negative laparoscopy results, that is, the referring physician believes that gynecologic causes have been ruled out. Unfortunately, it is far more common for the patient to have some organic pathology and to have been repeatedly subjected to medical and surgical measures in pursuit of pain relief. Many of these women have developed a chronic pain condition, characterized by significant changes in mood and activities, that needs behavioral and psychologic approaches as well as psychopharmacologic treatment in some cases. This group of patients with chronic pain presents an opportunity for fruitful collaboration between the gynecologic and mental health specialties. In most of these cases, it is clinically difficult to diagnose any particular underlying psychopathology as the precise cause for the pain. More often, clinical judgment will determine that attention to both physical and psychologic factors may be important, that both should proceed simultaneously, and that the hope of assigning a particular degree of responsibility to either ELE chronic gynecologic pain 271 meant must be surrendered. In some cases, the treatment of intrapelvic pathology by laparoscopic approaches, such as lysis of adhesions or vaporization of endometriosis, may be useful. When the parameters of chronic pain syndrome described here are also present, however, behavioral and psychologic assistance is also required. Reports of controlled trials of psychologic interventions specifically for chronic pelvic pain are very limited. However, increasing evidence substantiates the belief that combined medical and psychologic approaches are likely to result in greater improvement than are gynecologic treatments alone in many women with chronic pelvic pain. Pierce et al., 1987, reported the results of a prospective, randomized, controlled trial of two different psychologic interventions in the treatment of chronic pelvic pain. 78 women with chronic pelvic pain of at least 6 months duration and with no obvious pathology observed on laparoscopy were allocated to a pain analysis, a stress analysis, or a minimal intervention control group. All groups received an explanation of the pain as being caused by abnormalities in pelvic blood flow. In addition, the stress analysis group received training in identifying and implementing alternative cognitive and behavioral responses to concerns other than pain and in applying Jacobsonian relaxation strategies in stressful situations. The pain analysis group focused on monitoring and modifying events antecedent and consequent to pain, graded exercise, and reinforcement of well behaviors. Both the stress analysis and the pain analysis group reported significantly lower pain intensity ratings at 6-month follow-up visits than did the control group. In studies by Kames et al., 1990, and Peters et al., 1991, significant improvement in pain ratings and functioning was reported after multidisciplinary pain management approaches. Peters et al., 1991, randomly assigned 106 patients with chronic pelvic pain to either a standard approach group or an integrated approach group. The standard approach consisted of excluding organic pathology by diagnostic laparoscopy and then referring the patient for psychologic treatment if no somatic cause was found. The integrated approach included attention to somatic, psychologic, dietary, environmental, and physiotherapeutic factors from the beginning of the evaluation. After a 1-year interval, women in the integrated approach group showed significantly greater improvement in their general pain experience, in the disturbance of their daily activities, and in the associated pain symptoms. Because the particular types of treatments applied to any individual patient were not standardized in either of these studies, it is unfortunately not possible to identify the effective therapeutic components in these combined approaches. 272 Psychological Aspects of Women's Healthcare, 2nd edition. In general, the psychologic treatment component of chronic gynecologic conditions appears to be most effective when psychosocial factors are evaluated simultaneously with organic factors. Although patients with chronic pelvic pain are often unwilling to view their pain symptoms as other than organically based, many individuals are aware of some factors that worsen their pain, such as worry, muscle tension, or depression. A crucial aspect of successful psychotherapeutic intervention is making a connection with the patient at her own level of conceptualization of the pain problem. Therapeutic interventions for the patient with chronic pelvic pain usually focus initially on exploring behavioral and cognitive patterns that exacerbate the pain symptoms and developing coping strategies to interrupt these patterns. New information is often obtained by having the patient record pain ratings across the day. Depending on the relative influence of particular factors on pain ratings, psychologic treatment interventions have often included relaxation training directed at reducing muscle tension components, stress analysis to identify difficult life areas, assertiveness training to teach skills for dealing more directly with people or circumstances that may be controlled or avoided by the patient's complaints of pain, and cognitive interventions directed at specific emotional responses to pain that may feedback to increase anxiety, depression, and perceived pain. Psychologic approaches may also involve spouses or families to assist in defining a valued role in the family despite some possible limitations in previous activities. Changes in sexual activity often accompany pelvic pain, and specific education and counseling may be required to allow the patient to return to a level of comfort. Sexual counseling suggestions often include information about adequate physiologic arousal, changes in sexual positions, and instruction in vaginal relaxation exercises to treat a conditioned vaginismus response. As a trusting therapeutic relationship is established and coping skills are developed, some women may be receptive to pursuing psychotherapeutic approaches that are inclusive of broader issues related to unresolved emotional issues from past experiences. Medical management of chronic pelvic pain may include the use of antidepressants, although therapeutic trials of these agents in treating this condition are lacking. Tricyclic antidepressants and the newer serotonergic agents are used by many clinics providing care for patients with chronic pelvic pain. Although analgesic prescriptions should be limited to non-narcotic agents, chronic pain is better treated by the continuous use of such medications, thereby eliminating the tendency for medication to act as a reinforcer of pain behaviors or complaints. Other medications aimed at the symptomatic relief chronic gynecologic pain 273 of bladder and bowel dysfunction are often additive. We have found that it is often better to treat various contributing factors simultaneously. When narcotics are found to be necessary, it is useful to prescribe them on a contract basis, that is, from one physician, one pharmacy, and at a strictly prescribed rate with no early refills. Non-pharmacologic methods are also useful in selected individuals.
Alterations of gait or stance that might be traced to a musculoskeletal problem can be best evaluated by a physical therapist. Chronic spasm of the levator, psoas, and piriformis muscles can frequently contribute to chronic pelvic pain. Appropriate muscle strengthening, stretching, and relaxation exercises can also help. Transcutaneous nerve stimulators have been used sparingly in patients with pelvic pain but are sometimes useful. When pain and related disabilities are severe, many clinicians feel that intensive inpatient treatment is warranted. Fogel and Studemeyer 1986, Merida et al. 1989, Studemeyer and Fogel 1986. In such a case, a multi-specialty team, particularly on a combined medical psychiatric unit, is the most productive approach because it may best maintain a balanced approach to the often complicated and integrated psychologic and physical components to chronic pelvic pain. Conclusions: chronic pelvic pain is a common complaint. Although a minority of women will present with this problem in the absence of any organic pathology, chronic pain in most women will have developed in the presence of disease processes, such as adhesions and endometriosis. It is often clinically impossible to assign specific degrees of responsibility to physical and psychologic contributions to pain. Clinical care is therefore facilitated when needs in both areas are addressed as clinically appropriate and efforts to assign degrees of responsibility are suspended. This approach requires close collaboration between the gynecologist and the mental health professional. The patient experiencing chronic pain in the total absence of organic pathology presents a more difficult problem and often represents more long-standing and complicated psychopathologic processes. Again, collaborative management will be useful to evaluate and minimize unnecessary treatment while continuing to offer psychologic assistance aimed at helping the patient and her family cope with her difficulties. 274 Psychological Aspects of Women's Healthcare, 2nd edition. References: Anderson K.O., Keefe F.J., Bradley L.A., et al., Prediction of Pain Behavior and Functional Status of Rheumatoid Arthritis Patients Using Medical Status and Psychological Variables. Pain 33:25, 32, 1988. Beard R.W., Belzi M., Lieberman B.A., et al., Pelvic Pain in Women. AMJ Obstet Gynecol 128:566, 570, 1977. Beard W., Reginald P. W., Wadsworth J., Clinical Features of Women with Chronic Lower Abdominal Pain and Pelvic Congestion. BRJ Obstet Gynecol 95:153, 161, 1989. Benson R.C., Hansen K.H., Matarazzo J.D., Atypical Pelvic Pain in Women, Gynecologic and Psychiatric Considerations. AMJ Obstet Gynecol 77:806, 825, 1959. Bradley L.A., Prokop C.K., Gentry W.D., et al., Assessment of Chronic Pain, in Medical Psychology, Contributions to Behavioral Medicine. Edited by Prokop C.K., Bradley L.A. New York, Academic Press, 1981, pp 35-52. Castelnuovo Tedesco P., Kraut B.M., Psychosomatic Aspects of Chronic Pelvic Pain. Int J. Psychiatry Med 1:109, 126, 1970. Chaturvedi S.K., Chronic Pain Patients with and Without Alexithymia. Kin J. Psychiatry 33:830, 833, 1988. Crown S., CRISPA, A Short Clinical Diagnostic Self-Rating Scale for Psychoneurotic Patients, The Middlesex Hospital Questionnaire. BRJ Psychiatry 112:917, 923, 1966. Cunanan R.G., Curie N.G., Leipz J., Laparoscopic Findings in Patients with Pelvic Pain. AMJ Obstet Gynecol 146:589, 591, 1983. Daniel J. F., Laparoscopic Enterolysis for Chronic Abdominal Pain. J. Gynecol SURG 5:6166, 1989. Derogatis L.R., Lipman Rs., Rickles K., et al., The Hopkins Symptom Checklist, HSCL. A Self-Report Symptom Inventory. Behoff Sci 19:1, 15, 1974. Duncan C.H., Taylor H.C., A Psychosomatic Study of Pelvic Congestion. AMJ Obstet Gynecol 64:1, 12, 1952 Fidela L., Parazani F., Bianchi S., et al., Stage and Localization of Pelvic Endometriosis and Pain. Fertile Sterile 53:155, 158, 1990 Fogel B.S., Studemeyer A., Organization and Development of Combined Medical Psychiatric Units, 2. Psychosomatics 27:417, 428, 1986 Gidro Frank L., Gordon T., Taylor H. C. Jr., Pelvic Pain and Female Identity, A Survey of Emotional Factors in 40 Patients. AMJ Obstet Gynecol 79:1184, 1202, 1960 Gross R., Doer J., Caldirola D., et al., Borderline Syndrome and Incest in Chronic Pelvic Pain Patients. Int J Psychiatry Med 10:79, 96, 1980 Haber J., Ruth C., Effects of Spouse Abuse and/or Sexual Abuse in the Development and Maintenance of Chronic Pain in Women, in Advances in Pain Research and Their Chronic Gynecologic Pain 275 AP, Vol 9. Edited by Fields H. L., Dubner R., Cervero F. New York, Raven, 1985, pp 889-895 Harrop Griffiths J., Caton W., Walker E., et al., The Association Between Chronic Pelvic Pain, Psychiatric Diagnoses, and Childhood Sexual Abuse. Obstet Gynecol 71:589 594, 1988 Hathaway S.R., McKinley J.C., Minnesota Multiphasic Personality Inventory, Revised. Minneapolis, University of Minnesota, 1970 Kames L.D., Rapkin A.J., Nailabov B.D., et al., Effectiveness of an Interdisciplinary Pain Management Program for the Treatment of Chronic Pelvic Pain. Pain 41:41, 46, 1990 Keefe F.J., Wilkins R.H., Cook W.A., et al., Depression, Pain, and Pain Behavior. J. Consult Clin Psychol 54:665, 669, 1986 Kresh A.J., Cypher D.B., Sachs L.B., et al., Laparoscopy in 100 Women with Chronic Pelvic Pain. Obstet Gynecol 64:672, 674, 1984 Locke M.J., Wallace K.M., Short Marital Adjustment and Predictions Tests, Their Reliability and Validity. Marriage and Family Living 21:251, 255, 1959 Magna G., Anderoli C., DeLeo D., et al., Psychological Profile of Women with Chronic Pelvic Pain. Arch Gynecol Obstet 237:165, 168, 1986 Merida T., Vadaat M.K., McHardy M.J., Pain Management as an Antidepressant, Long-Term Resolution of Pain-Associated Depression. Pain 36:335, 337, 1989 Palter S.F., Olive D.L., Office Microlaparoscopy under Local Anesthesia for Chronic Pelvic Pain. JAM Association Gynecol Laparos 3:359, 364, 1996 Papchik as, Feuerstein M., Biller C.D., et al., Alexithymia and Pain in an Outpatient Behavioral Medicine Clinic. Int J Psychiatry Med 16:347, 357, 1987 Pierce S., Matthews A.M., Beard R.W., A Controlled Trial of Psychological Approaches to the Management of Pelvic Pain in Women. Paper presented at the 8th Annual Scientific Sessions of the Society of Behavioral Medicine, Washington, D.C., March, 1987 Peters AAW, Van Horst E., Gillespie, et al., a randomized clinical trial to compare two different approaches in women with chronic pelvic pain. Obstet Gynecol 77:740 744, 1991 Postone N., Alexithymia in Chronic Pain Patients. Gen Hosp Psychiatry 8:163, 167, 1986 Radloff L.S., The CESD Scale, a self-report depression scale for research in the general population. Applied Psychological Management 1:385, 410, 1977 Rapkin A.J., Kames L.D., Dark L.L., et al., History of Physical and Sexual Abuse in Women with Chronic Pain. Obstet-Gynecol 76:92, 96,1990 Raskinda, Diagnosis in Patients with Chronic Pelvic Pain, Letter. AMJ Psychiatry 141:824, 1984 Writer R.C., Gambone J.C., Demographic and Historic Variables in Women with Idiopathic Chronic Pelvic Pain. Obstet-Gynecol 75:428, 432, 1990 276 Psychological Aspects of Women's Healthcare, 2nd edition Robbins L.N., Helzer J.D., Crahan J., et al., National Institute of Mental Health Diagnostic Interview Schedule, its history, characteristics, and validity. ArchGen Psychiatry 38:381, 1981 Romano J.M., Turner J.A., Chronic Pain and Depression, Does the Evidence Support a Relationship? Psychol Bull 97:18, 34, 1985 Rosenthal R.H., Ling F.W., Rosenthal T.L., et al., Chronic Pelvic Pain and Laparoscopic Findings. Psychosomatics 25:833, 841, 1984 Shea B., Sexual Factors in Pelvic Pain. J. Psychosome Obstet Gynecol 12, Supple 99 108, 1991 Slocum J.C., Kellner R., Rosenfeld R.C., et al., Anxiety and Depression in Patients with the Abdominal Pelvic Pain Syndrome. Gen Hosp Psychiatry 11:48, 53, 1989 Stige J.F., Dyspareunia and Vaginismus. Clin Obstet Gynecol 23:750, 759, 1984 Stige J.F., Microlaparoscopy, in Chronic Pelvic Pain, an Integrated Approach. Edited by Stige J.F., Metzger de, Lovey B.S. Philadelphia PA, W.B. Saunders, 1998, pp 337-346 Stige J.F., Stout A.L., Resolution of Chronic Pelvic Pain Following Laparoscopic Adhesiolysis. AMJ Obstet Gynecol 165:278, 283, 1991 Stige J.F., Stout A.L., Somcuti S.G., Chronic Pelvic Pain in Women, Toward an Integrative Model. J. Psychosome Obstet Gynecol 12, Supple 3, 30, 1991 Sternbach R.A., Pain Patients, Traits and Treatment. New York, Academic Press, 1974 Stewart de, Wellen C.L., Fong I.W., et al., Psychosocial Aspects of Chronic, Clinically Unconfirmed Vulvovaginitis. Obstet Gynecol 76:852, 856, 1990 Studemeyer A., Fogel B.S., Organization and Development of Combined Medical Psychiatric Units, I Psychosomatics 27:341, 345, 1986 Stout A.L., Stige J.F., Psychosocial and Behavioral Self-Reports of Chronic Pelvic Pain Patients. Paper presented at the meeting of the American Society of Psychosomatic Obstetrics and Gynecology, Houston, Texas, March, 1991 Stout A.L., Stige J.F., Dodson W.C., et al., Relationship of Laparoscopic Findings to Self-Report of Pelvic Pain. AMJ Obstet Gynecol 164:73, 79, 1991 Sutton C., McDonald R., Laser Laparoscopic Adhesiolysis. J. Gynecol SURG 6:155, 159, 1990 Walker E.U., Caton W., Harrop Griffiths J., et al., Relationship of Chronic Pelvic Pain to Psychiatric Diagnoses and Childhood Sexual Abuse. AMJ Psychiatry 145:75, 80, 1988 Zung WWK, A Self-Rating Depression Scale. ArchGen Psychiatry 12:63, 70, 1965 14 Gynecologic Disorders and Surgery Paula J. Adams Hillard, M.D.
Gynecologic disorders and gynecologic surgery have the potential to evoke significant emotional responses. A sexually transmitted disease, STD, contracted from a partner with whom a woman had been intimate suggests betrayal and violation of trust and self. That some STDs are incurable and have the potential for carcinogenesis or death as a consequence is understandably terrifying. From the time of menarche, women learn to identify monthly cycles and rhythms of menstrual function, and disturbances of normal functioning may be distressing. Surgeries on the genital organs threaten childbearing potential, sense of feminine identity, and sexual functioning. This chapter provides background information on several of these common gynecologic concerns and a discussion of the impact that they may have. Although the potential for adverse psychologic consequences for the individual is significant and the number of individuals with these common gynecologic problems is large and increasing, little attention has been directed toward the psychologic consequences of many of these problems. Sexually transmitted diseases. The current complement of STDs is an alphabet soup of acronyms, including infections caused by the following organisms: Neisseria gonorrhea, GC for gonococcus, herpes simplex virus, HSV, human papillomavirus, HPV, HIV, chlamydia trachomatis, as yet without a common acronym, and treponema pallidum. An increasing number of individuals have experienced disease related to one of these organisms, with some types of infections reaching epidemic proportions, primarily among young adults and adolescents. Although some 278 psychological aspects of women's healthcare, second edition bacterial infections are easily treated and cured with antibiotics, viral infections are usually incurable and may have potential sequelae for future health and fertility, as with chlamydia-associated pelvic inflammatory disease. The potential for HPV-associated cervical, vulvar, and vaginal intraepithelial neoplasia may be significant, and the potential lethality of HIV infection is well known. Individuals who initiate sexual activity at an early age and those who have had multiple sexual partners are at greater risk for contracting an STD. Sexually active adolescents and young adults are a particularly high-risk group. Bell and Hein 1984, Institute of Medicine 1997. Public health reporting of STDs is required in all states for gonorrhea, syphilis, and AIDS, not HIV seropositivity. The incidences of HSV, HPV, and chlamydia are estimates only, although an increasing number of states are mandating report of these infections. Webster et al. 1993. Nationally, the rates for gonorrhea and primary and secondary syphilis have declined since 1990, reaching low points in 1993 that were below or approaching year 2000 objectives. 225 cases or fewer of gonorrhea and 10 cases or fewer of primary and secondary syphilis per 100,000 persons. However, rates for both diseases remained higher than the year 2000 objectives for certain population subgroups: adolescents and young adults, minorities, especially blacks, and persons living in the southern United States. Centers for Disease Control and Prevention 1994b. The greatest number of cases of gonorrhea occurred in the ages 20 to 24 group. Centers for Disease Control and Prevention 1996b. Chlamydia trachomatis causes an estimated 3 to 5 million infections annually in the United States. Centers for Disease Control and Prevention 1994a, Judson 1985. Sexually active adolescents and young adults are at particular risk for chlamydia infections. Bell 1990. From 1986 to 1990, an epidemic of syphilis occurred in the United States, primarily among drug users who traded drugs for sex. Webster and Rolfes 1993, and a concomitant increase occurred in the incidence of congenital syphilis. Dunn et al. 1993. Subsequently, rates of syphilis have declined. Centers for Disease Control and Prevention 1994b. Herpes simplex virus. It has been estimated that more than 2 million cases of genital herpes occur annually in the United States. Droge-Muller et al. 1987. From 1988 to 1994, the seroprevalence of genital herpes, herpes simplex virus type 2, or HSV2, in the United States was 22%, corresponding to 45 million infected people. The seroprevalence was higher among women, 25.6%, than among men, 17.8%, and higher among blacks, 45.9%, than among whites, 17.6%. Less than 10% of those who were seropositive reported a history of genital gynecologic disorders and surgery. 279 herpes infection, Fleming et al. 1997, which means that many individuals have been infected with the virus and are potentially infectious to sexual partners but have no history of a typical lesion. Human papillomavirus. The rate of consultations with private physicians for HSV and for genital warts, HPV infections, has increased markedly. Becker et al. 1987, nearly 1.2 million office visits for genital warts were reported in 1988. Cervical HPV infection is associated with cervical dysplasia and abnormal pap smears, the reported rates of which appear to be increasing, especially among adolescents. P.J. Hillard et al. 1989b, and the degree of abnormality reported on the pap smear may range from mild squamous atypia to frankly invasive carcinoma. This spectrum of abnormalities is often not appreciated by the lay public, who may view the pap, or cancer, smear as having only one of two possible results: normal or indicative of cancer. Thus the potential exists for the generation of significant anxiety. Providing patients with accurate information about this spectrum of abnormalities, the procedures necessary to evaluate abnormal results, colposcopy and biopsy, and any planned treatment and expected outcome can help to alleviate this concern. P.J. Hillard et al. 1989a. In selected patients with mild cervical abnormalities on biopsy results, observation without specific therapy may be recommended because spontaneous regression may occur in up to 60%, 80% of patients. American College of Obstetricians and Gynecologists 1994. Compliance with recommendations for subsequent pap smears is essential, because progression may also occur. Fear about possible progression may sometimes paradoxically result in failure to keep subsequent appointments or in other maladaptive behaviors. Bureau et al. 1991. It has been argued that because mild cervical dysplasia can be effectively eradicated with a single treatment in a high percentage of patients, this treatment should be considered for all such patients to spare them the psychologic and emotional trauma of repeated abnormal cervical cytology on follow-up. Tay and Yang 1995. Most clinicians feel that the potential for morbidity from treatment modalities outweighs any psychologic risk for most women. However, treatments should be individualized. Higher grade abnormalities, cervical intraepithelial neoplasia CIN2, moderate dysplasia and CIN3, severe dysplasia, or carcinoma in situ, generally require ablative therapy, which may range from office laser vaporization to cervical cryotherapy, hysterectomy, or excision using an electrical current. Cervical cryotherapy and laser vaporization have been shown to have essentially similar rates of lesion cure or eradication, in the range of 85%, 90%. 280 Psychological Aspects of Women's Healthcare, 2nd edition, Townsend and Richard 1983, and thus have largely replaced hysterectomy as therapy for cervical dysplasia, in the absence of other gynecologic problems that would warrant a hysterectomy. Reassurances of this fact should be given at the onset of a diagnostic workup because the patient's fear of hysterectomy, with its real and perceived losses, may be an unstated concern. Loop electrical excision is a newer technique. Its efficacy appears to be comparable with that of cryotherapy or laser vaporization. T.C. Wright et al. 1992. The type of treatment recommended depends primarily on the preferences of the treating physician and the modalities available. In patients who do not fulfill the criteria for outpatient ablative therapy, cervical conization is necessary. This procedure preserves childbearing potential with little or no detrimental effect on future fertility or childbearing. Criteria for conization include inability to visualize the lesion completely with disease of the endocervical canal or significant discrepancy between pap smear and biopsy results. Cervical conization involves the removal of a cone-shaped biopsy specimen using a laser or conventional scalpel. This procedure is usually performed in an operating room with the patient under general or regional anesthetic. In the absence of complications, the patient can be admitted and discharged on the same day. The potential for resolution of cervical dysplasia is good with therapy, but follow-up is critical because recurrences are possible. As with other STDs, it is important for women to be aware that their risk of HPV acquisition is determined not only by their own sexual history and number of partners but also by those of their partners. Evidence suggesting that HPV-associated genital lesions are not eradicated by treatment is psychologically distressing for the patient, and the prospect of an incurable disease is often associated with anxiety. How HPV-related disease is transmitted, how infectious it is, and the degree of risk of progressive disease remain in great part unknown. Although generally considered to be sexually transmissible, the possibility of non-sexual transmission has been raised. It is distressing that these questions, with very practical implications, remain unanswered by scientific evidence, and medical professionals who acknowledge the uncertainties related to HPV are sometimes viewed as incompetent or insensitive to the patient's concerns. HIV infection is a major cause of morbidity and mortality among women and children in the United States. In 1995, women accounted for 19% of the gynecologic disorders and surgery 281 reported cases of AIDS. HIV infection is the third leading cause of death among all women aged 25 to 44 years in the United States and the leading cause of death among black women in this age group. An estimated 7,000 infants are born to HIV-infected women in the United States each year. Without treatment, approximately 15%, 30% of these infants would be infected. Centers for Disease Control and Prevention 1996a. HIV counseling and testing services are important for women to reduce their risk of infection or, if already infected, to initiate early treatment and prevent HIV transmission to others, including their infants. Attention has been given to the psychologic factors motivating STD risk reduction and HIV prevention, Darrow 1997, Gillespie 1997. In addition, the body of literature focusing on the risks of HIV infection among the seriously and chronically mentally ill is increasing because the risks of HIV and other STDs are higher in this population, Carey et al. 1997, Weinhardt et al. 1997. As HIV infection becomes a chronic disease, the psychosocial factors related to coping behaviors become important to understand, Nannies et al. 1997. A complete discussion of the psychiatric conditions associated with HIV infection and AIDS is beyond the scope of this chapter, but mood disorders, substance use, and organic mental disorders are common, Judd et al. 1997. Psychologic effects. The psychologic effects of STDs have been systematically addressed in only a limited manner. STDs have been characterized as among the most stigmatizing diseases that most Americans acquire, Darrow and Pauley 1984. The effects have been most extensively studied for genital herpes infections, but to some extent, psychologic reactions described with herpes may also occur with any of the other STDs. Psychologic distress related to herpes was first characterized in a report of herpes self-help groups, Luby and Gillespie 1981. With herpes, as with other serious disease, the initial diagnosis of the infection may be shocking for the patient. The impact of an STD diagnosis may be differentiated from that of other infectious diseases by the stigma associated with STDs in general, Darrow and Pauley 1984. Once the diagnosis is made, the patient often searches for a cure. He or she subsequently may be overcome with a sense of isolation and loneliness when, as with HSV or HPV, the incurable nature of the disease is realized, Luby and Gillespie 1981. A diagnosis of a curable STD, such as gonorrhea or chlamydia, may not result in such feelings, but HIV infection, with its ultimately fatal out 282 psychological aspects of women's health care, 2nd edition has great potential for psychologic distress. As concerns increase, Anger becomes important. Initially, the patient's anger is directed toward the infecting partner, but it may also be directed toward the physician who is unable to cure the viral disease. Anxiety and fears about the infectious nature of the disease, its impact on future childbearing and fertility, and the potential risks of cancer may generalize to other areas of the individual's life. Fears about the impact of the disease on sexual activity, sexuality, and sexual performance begin to surface. Some individuals go on to feel that they are contagious or dangerous, a leper effect. Patients may become self-involved, decide to become celibate, or engage in anti-sexual or moralistic behavior. Depression, feelings of helplessness, or guilt may increase over time in some patients, and they may ask, why me? Luby and Gillespie, 1981, a reaction similar to that of patients diagnosed with life-threatening illnesses, such as cancer. One study, or ETAL 1989, has reported an association between STDs and low self-esteem among adolescents, although it is not clear whether problems with self-esteem are a cause or effect of STD acquisition. Elevated levels of psychologic disturbance among patients in STD clinics have been noted, ICO's ETAL 1987, and in some individuals the sequelae of an STD such as herpes may include a reactivation of underlying psychopathology. The extent to which these reactions occur and their severity and duration vary among individuals. However, an awareness of possible psychologic reactions will aid the physician in helping patients develop the skills to cope with their disease. Several studies of herpes have reported elevated levels of psychologic distress with adverse effects on sexuality, self-image, and love relationships lasting many months after the diagnosis or initial episode of the disease. J.R. Hillard, ETAL 1989. Concern that herpes affects young people at a critical phase of psychosocial development as they are attempting to develop lasting attachments has been expressed. Luby and Clinch, 1985, p. 494. Attempts to define individuals or populations at greater risk of significant and long-lasting psychiatric distress have not been particularly successful, and thus all individuals who contract herpes, and by extension, other STDs, should be considered to be at risk for persistent psychologic symptoms. J.R. Hillard, ETAL 1989. Effects of diethylstilbestrol. The association between in utero exposure to diethylstilbestrol, DA, a synthetic estrogen, and vaginal clear cell adenocarcinoma was first described in Gynecologic Disorders and Surgery 283, 1971, and it has not generally been prescribed during pregnancy since that date. Thought to decrease the risk of pregnancy loss and miscarriage, DA was ultimately shown to be ineffective for this indication. Many thousands of women were exposed to DA before birth, but vaginal adenocarcinoma fortunately remains rare, with an estimated risk in exposed women of 1/1,000 or less. Barrack and Hacker, 1989. Vaginal, uterine, and cervical structural abnormalities have also been associated with DA, and infertility and pregnancy loss, including preterm delivery, have been correlated with DA exposure. Herbst, ETAL 1981. The prognosis for a good pregnancy outcome in women exposed to DA is generally good, with reports suggesting that about 80% will have a live-born child. Herbst and Holt, 1990. Mothers who received DA during pregnancy must deal with feelings of anxiety, guilt, and anger, particularly if their daughters also have reproductive problems. Their daughters may themselves be anxious about their own future fertility and may feel anger toward their mothers and toward the medical profession that prescribed the treatment. In one study, however, 80% of DE-exposed daughters felt trust and alliance with their mothers and doctors, and only a minority reacted with hostility or fear, a finding that ran contrary to the investigators' expectations. Burke, ETAL 1980. An appropriate physician-patient relationship may be particularly important in minimizing the adverse emotional sequelae for mothers and daughters exposed to DA. Psychologic preparation for gynecologic procedures. Preoperative preparation for gynecologic surgery. Psychologic preparation is an important part of preoperative preparation for any type of surgery, but particularly so for gynecologic procedures. Youngs and Wise, 1980. A woman's first reaction to gynecologic problems depends on the severity of the diagnosis, its potential or imagined sequelae, life or fertility threatening, the extent of the required treatment, office biopsy, ambulatory surgery, major surgery, and the woman's own psychologic makeup and reactions to stress in general. The practicing psychiatrist or other mental health professional can address gynecologic concerns most effectively if he or she has a basic understanding of the most frequently encountered gynecologic problems, their management, and the potential issues that commonly surface. 284 Psychological Aspects of Women's Healthcare, Second edition. In any situation involving gynecologic pathology and the recommendation for operative intervention, informed consent, and medical decision-making are critical. American College of Obstetricians and Gynecologists 1993, Rockwell and Pytone Rockwell 1979. The term informed refusal has been proposed as another dimension of this concept. American College of Obstetricians and Gynecologists Committee on Professional Liability 1996. The acronym BRAIDed has been proposed as a mnemonic for remembering the basic components of informed consent, Hatcher et al. 1990. Patients should have a clear understanding of expected benefits, potential risks, and alternatives, both medical and surgical, of their right and responsibility to make inquiries about the physician's recommendations, and of their right to make the decision to withdraw from procedure, to have an explanation of the type of surgery planned and its indications, and to have documentation of all informed consent components. Although some physicians consider the informed consent process to be a mere formality, it is essential to patient understanding and acceptance of surgery and minimizes the potential for subsequent misunderstanding or, even worse, a lawsuit. Although this medico-legal aspect of informed consent may be foremost in consideration, the benefits to subsequent physician-patient communication, understanding, and trust should not be underestimated. Computer-aided CD-ROM programs are now available that provide preoperative patient educational material, print responses to questions about the surgical procedure, and serve as an informed consent document. American College of Obstetricians and Gynecologists 1995. However, these programs do not replace face-to-face physician-patient discussions about the potential risks and benefits of the surgery. Psychologic preparation prior to surgery has been addressed relative to cognitive coping techniques, Ridgway and Matthews 1982. The logistics of surgery, how long hospitalization is expected to last, and the average period of recovery or time off from work are important to convey to every patient. Specifics about pre- and postoperative procedures may be helpful for some patients. Johnson et al. 1985, Ridgway and Matthews 1982. The ability to predict which women benefit most from which type of preoperative preparation would be useful, but most of the studies that address coping styles have been unable to identify predictive factors. Involving the family or partner in discussions of surgery may be helpful if the woman chooses to do so. The patient's resources and previous coping skills should be assessed. It should be emphasized that surgery is stressful for the patient and will require the mobilization of personal resources, including gynecologic disorders and surgery. 285 Family and Friends, Youngs and Wise 1980. Following a surgical procedure, psychologic characteristics and coping styles may affect the perception of pain, the use of pain medication, and other characteristics of postoperative recovery. Ridgway and Matthews 1982, Thomas et al. 1995, Wilson 1981. The gynecologist may recognize women at higher risk for adverse psychologic sequelae and refer them for evaluation, counseling, or therapy prior to surgery. Stellman 1990. If the patient's degree of anxiety is judged by the gynecologist to exceed that usually noted, surgery should be deferred, if possible, pending a referral for psychiatric evaluation. Schwab 1971. Preoperative preparation includes a discussion of the specific pathology and indications for the surgery. The type of surgery to be performed should be described in terms that are understandable but not condescending. For procedures such as oophorectomy, this discussion should include the expected benefits, risks, and alternatives as well as the effect on physiology in terms of the production of ovarian steroid hormones. The need for hormone replacement therapy should be addressed. With a hysterectomy, it is important that the woman understand the basics that she will no longer experience menses and will not be able to have children. Dilation and curettage disturbances in menstrual regularity, sometimes accompanied by excessively heavy flow, are common at the extremes of reproductive life, particularly in the perimenopausal years prior to the cessation of menses. Because the risks of uterine fibroids and endometrial pathology, including hyperplasia, polyps, and malignancy, increase with age, histologic sampling of the endometrium is warranted for abnormal bleeding in women who are over age 40 or who have other risk factors such as obesity, chronic anovulation, or polycystic ovarian disease. In the past, endometrial sampling typically required a dilation and curettage, D&C, an outpatient procedure typically performed in an operating room setting under general anesthesia. However, new endometrial sampling techniques have allowed endometrial biopsies to be performed in the physician's office, and thus fewer patients require a D&C, Grimes 1982. Women also tend to cope better with the less invasive endometrial biopsy than with a D&C hysteroscopy, in which the endometrial cavity is visualized directly using fiber optics, is an additional diagnostic tool that may be performed in lieu of or in addition to a D&C. Evidence for the efficacy of D&C as a therapeutic technique is not well established despite its widespread use, Grimes 1982. 286 Psychological Aspects of Women's Healthcare, 2nd edition. Sterilization. Female sterilization is now the most frequently chosen contraceptive option among married and formerly married women, ABMA et al. 1997, Mosier and Pratt 1990. Female sterilization may be performed in the immediate postpartum period or as an interval outpatient procedure. Techniques of tubal occlusion include use of suture, cautery, plastic rings, or clips. Women considering sterilization should be counseled about alternative methods of contraception, including male sterilization, which has a significantly lower risk of morbidity and mortality. Women often feel that because they have assumed the health risks and discomforts of pregnancy and childbirth, their partner should assume his share of responsibility by obtaining a vasectomy. However, some women remain protective of the concerns their partners express regarding a vasectomy as a threat to his potency, virility, and manhood. Some women are pragmatic in their desire to end childbearing and assume the responsibility for permanent sterilization just as they have for reversible methods of contraception. A woman in a physically abusive relationship with an obsessively jealous and controlling man may experience an increase in abuse when making a decision for sterilization if the abusive partner attempts to preserve his control over her by forbidding such a procedure. Sterilization should be considered to be permanent, although recent studies have suggested that the procedure's risk of failure is higher than previously recognized, Peterson et al. 1996. Less permanent but still long-lasting methods of contraception such as an implantable subdermal device, Norplant, or an intrauterine device may be appropriate alternatives for women who are not ready for sterilization. Regret after sterilization procedures is infrequent, ranging from less than 1% to 3%, Huggins and Sondheimer 1984, but certain groups appear to be at higher risk for subsequent regret. Women who are younger at the time of the procedure and who later changed partners, those who made the decision for socioeconomic reasons, and those who had the procedure at the time of an abortion or immediately postpartum may be somewhat more likely to regret sterilization, Huggins and Sondheimer 1984. Some childless women express a strong desire for sterilization and should not arbitrarily be denied the procedure. The woman's motivation and expectations regarding sterilization should be explored to ascertain that the decision is not based on misinformation, example the idea that the tubes will come untied after a period of time, unrealistic expectations of benefits, example the expectation that a faltering marriage will be saved, or a hastily made decision. Gynecologic disorders and surgery. 287 Laparoscopy. Laparoscopy is a surgical procedure usually performed on an outpatient basis. It involves the use of fiber optics to visualize the pelvic and abdominal organs in order to explore possible causes of pelvic pain, such as adhesions or endometriosis, or for other surgical indications. Laparoscopy may also be considered to be therapeutic when techniques such as laser ablation of endometriosis or lysis of adhesions are performed under laparoscopic visualization. Laparoscopy, or pelviscopic surgery, is increasingly replacing traditional open laparotomy procedures, which has resulted in decreased hospital stays, decreased pain, and possibly decreased costs for the patient. In addition, the psychologic sequelae of these less extensive surgeries may be reduced, although this issue has not been addressed systematically. Laparoscopy is now frequently used to diagnose and remove ectopic pregnancies, and other pelviscopic techniques such as ovarian cystectomies, oophorectomies, or myomectomies are being performed laparoscopically by a growing number of gynecologists. Laparoscopically assisted vaginal hysterectomy is a newer technique that may be used to avoid an abdominal hysterectomy. Surgical procedures to correct anatomic stress, urinary incontinence or pelvic and vaginal relaxation in many women, damage to uterine and vaginal supporting structures during childbirth and changes related to aging often result in some degree of pelvic and vaginal relaxation, including cystocele, urethrocoele, rectocoele, enterocoele, or uterine prolapse. Cystocele refers to the loss of bladder support, urethrocoele involves loss of urethral support, rectocoele includes weakening of the supporting fascia in the rectovaginal septum, enterocoele is a herniation of the pouch of Douglas cul-de-sac into the rectovaginal septum, and uterine prolapse is a weakening of uterine support and uterine descent into the vagina to the vaginal introitus or beyond. A significant degree of pelvic and vaginal relaxation is not typically seen in nulliparous women. These conditions may be asymptomatic or may have symptoms, such as stress urinary incontinence, that are extremely limiting and distressing. Surgery to correct symptomatic pelvic relaxation is almost always a purely elective procedure, that is, the decision for surgery should be dictated by the woman herself, based on the degree to which her activities are disrupted by her symptoms or the extent of her social disability as a result of urinary incontinence. Women should be made aware that incontinence is not an inevitable consequence of aging, and that an Eval 288 Psychological Aspects of Women's Healthcare, second edition nuation of the specific cause frequently leads to therapies, including surgery, that are helpful or curative. The types of surgery used for vaginal/pelvic relaxation vary depending on the anatomic alterations involved. An anterior and posterior colporrhaphy are frequently performed to correct a cystocele and rectocoele, respectively, and are usually performed in conjunction with a vaginal hysterectomy to correct the accompanying uterine prolapse. The diagnosis of anatomic stress incontinence is confirmed by cystometric and dynamic testing, which is used to rule out other possible causes such as neurologic problems or hyperactive bladder contractions. If anatomic stress urinary incontinence is a factor, a retropubic bladder neck suspension may be performed. Sexual dysfunction may occur after vaginal valve procedures because of vaginal shortening or alteration of the vaginal axis, Amias 1975, Bachman 1990b, Masters and Johnson 1966, Sloan 1978. Expectations for the results of surgery should be discussed prior to the procedure, because no surgery for stress urinary incontinence is 100% successful. In addition, it is important for the woman to understand that although unlikely, it is possible that her voiding problems will be worse after surgery or that the problem will recur, making it necessary that a second surgical procedure be performed. Non-surgical therapies for pelvic relaxation include the use of pessaries, which provide mechanical support for the pelvic organs. Non-surgical therapies for stress urinary incontinence include electrical stimulation, urethral plugs, or vaginal weights and exercises to strengthen the muscles of the pelvic floor, Newman and Burns 1997, Rackley and Appel 1997. Other behavioral methods including timed voiding and fluid restriction are frequently helpful for mild stress urinary incontinence. Most major cities have centers at which specialists address incontinence problems with sensitivity and expertise. Hysterectomy. Hysterectomy is the one surgical procedure that has most defined the field of gynecologic surgery. Hysterectomy rates have declined since 1970, Easterday et al. 1983, although a number of factors including physician gender, training, acceptance of alternatives to hysterectomy, and community practice patterns affect marked variations in the rate. Bachman 1998. Hysterectomy involves the removal of the uterus, including the uterine cervix, and may be performed transvaginally or transabdominally. Vaginal hysterectomy is generally accompanied by less postoperative pain and a more gynecologic disorders and surgery. 289 Rapid return to normal function. Factors that influence the route of surgical approach include anatomy, specific pathologic conditions, previous surgery, physician skill and experience, and the need for associated procedures, such as a retropubic bladder suspension. Before the risks of cervical malignancy and premalignancy were recognized, supracervical or subtotal hysterectomy with removal of the uterine corpus, leaving the cervix in situ, was much more commonly performed. In recent years, supracervical hysterectomy has been performed solely in situations of excessive hemorrhage or severe pelvic pathology in which further attempts to remove the cervix have been judged to involve life-threatening risk. However, some resurgence of interest in the supracervical procedure has occurred. Proponents argue that retaining the cervix offers fewer adverse effects on sexual function and less potential for subsequent pelvic relaxation. Cutler 1988, Kilku et al. 1983, Monroe 1997, Scott et al. 1997. Opponents argue that these potential benefits have not been proven and that leaving the cervix in situ entails the risk of subsequent cervical intraepithelial neoplasia or invasive cancer. Women may be confused about which type of hysterectomy their gynecologist has proposed. This confusion arises because the medical term total hysterectomy, meaning removal of the uterus and the cervix, is often interpreted by women to mean removal of the uterus and ovaries. The medical term for which is total hysterectomy with bilateral salpingo-oophorectomy. The literature on adverse reactions to hysterectomy is obfuscated by reports that do not take this distinction into account. In a premenopausal woman, removing the ovaries results in a surgical menopause that is usually rapid in onset and has severe symptoms. Gynecologists are divided as to the benefits versus the risks of ovary removal at hysterectomy, Garcia and Cutler 1984. Proponents of ovarian conservation argue that many normal ovaries would need to be removed to significantly reduce the death rate from ovarian cancer and that normal ovaries continue to produce valuable hormones prior to or even beyond menopause. Underwood 1976. Ovarian steroid hormones significantly impact many body functions, influence the health of the female genital organs, i.e., the vagina and urethra, play a critical role in the preservation of bony mass and the prevention of osteoporosis, and reduce the risks of cardiovascular disease. Barrett Connor and Bush 1991. Thus, the removal of these hormones without adequate replacement has important adverse health consequences. Meyer and Van Lindert, 1992, provided a quantitative model for assessing risks and benefits of prophylactic oophorectomy, taking into account the risks. 290 Psychological aspects of women's health care, second edition of various types of ovarian and breast malignancy, osteoporosis, and cardiovascular disease as well as the risks of non-compliance with hormone therapy. Hormone replacement therapy can often be accomplished with oral or parenteral, transdermal patch, estrogen and progestin. However, such treatment does have potential side effects in addition to its problems of ongoing compliance and cost. Sparoff et al. 1991. It has been assumed that the postmenopausal ovary is not hormonally active. However, data have shown continued secretion of ovarian androgens that may support the well-being and general health, including libido, of postmenopausal women. Garcia and Cutler 1984. Studies have suggested that oophorectomy, with or without hormone replacement therapy, is associated with adverse effects on libido, vaginal lubrication, and pleasure with coitus, although one study found no correlation between psychosexual variables and biochemical androgen markers. Nathorsbus and von Schultz 1992. It has been suggested that androgen replacement as well as estrogen replacement after hysterectomy and oophorectomy may result in fewer physical and psychologic symptoms, although this issue remains controversial. Sherwin and Gelfand 1985. The argument favoring an oophorectomy is that ovarian conservation entails the risk of subsequent ovarian cancer. Travis 1985. Of all gynecologic cancers, ovarian cancer is the most insidious in onset and frequently eludes detection in its early stages. 60%, 75% of ovarian cancers present in advanced stages. Knapp and Berkowitz 1986. It is frequently argued that the 2%, 5% risk of developing ovarian cancer or requiring a second surgery for residual ovarian disease warrants an oophorectomy at the time of hysterectomy, particularly if the woman is approaching menopause. Tertz et al. 1967. The average age of menopause is 51, a fact that is relatively unknown among the lay public, who frequently assume menopause arrives in the mid-40s. Age 45 or even 40 is commonly cited as the age beyond which many physicians would recommend a prophylactic oophorectomy. Alternatives to hysterectomy in most developed countries. Increased skepticism has arisen about not only the necessity for oophorectomy but also that for hysterectomy itself. Non-surgical hormonal therapy should be considered as the initial treatment for many gynecologic conditions, including abnormal bleeding or menorrhagia. Schwang and Brenner 1996. Alternatives to hysterectomy, such as myomectomy or endometrial ablation by laser, electrical means, or thermal energy, have been proposed and are gaining acceptance in the medical community. Gynecologic disorders and surgery. 291 women are becoming aware that alternatives to hysterectomy exist and are asking their clinicians about these options. Although some of these procedures may ultimately prove to be appropriate surgical management, the final word based on definitive, long-term follow-up studies is not yet in. Myomectomy, or removal of uterine leiomyomata, is gaining in popularity as an alternative to hysterectomy for women with uterine fibroids, even among women who have completed childbearing and who would not have traditionally been considered for such a procedure. Some women note that the sensation of uterine contractions accompanying orgasm is pleasurable, and for these women, myomectomy may be appropriate. Other women feel that the monthly reassurances of menses are important to them. Myomectomy can be accompanied by risks similar to those of hysterectomy, including the potential for excessive blood loss. It is incorrect for women to believe that this is a minor surgical procedure. In addition, studies suggest that about 1/3 of women who have a myomectomy have recurrent fibroids and that the need for a hysterectomy subsequent to myomectomy is 20%, 25%. T. E. Linda 1977. Endometrial ablation, as an alternative to hysterectomy, involves the destruction of the endometrium through the cervix using an electric current, a laser, or a balloon that transmits heat to the endometrium. The main indication for endometrial ablation is heavy menstrual blood loss in the absence of organic disease. Gary 1995. Most of these techniques have involved preoperative hormonal treatment to thin the endometrium, use of a general anesthetic, hysteroscopically directed laser, or electrical removal or destruction of the endometrium followed by a short postoperative hospital stay. The advantages of these procedures include a significant reduction in hospital stay and a potential to minimize the morbidity associated with hysterectomy. Bachman 1998, Easterday et al. 1983. The goal of endometrial ablation is to completely destroy the endometrium, thus eliminating or significantly decreasing menses. Currently, endometrial ablation is performed much less frequently than hysterectomy. Future studies will document the actual magnitude of risks and complications associated with the procedure, and it may prove to be a useful technique. American College of Obstetricians and Gynecologists Committee on Quality Assessment 1996. In December 1997, the U.S. Food and Drug Administration granted pre-market approval for the use of a uterine balloon therapy system for endometrial ablation. This and similar devices offer the potential for a simple office procedure as an alternative to hysterectomy. Long-term studies are lacking, and caution is indicated prior to widespread adoption of this technique.
292 Psychological Aspects of Women's Healthcare, 2nd edition. Patients who request alternative surgical procedures deserve accurate information about hysterectomy as well as the alternative procedures, Bachman 1990a, because their reasons for avoiding a hysterectomy may be based on misconceptions about the procedure. Although it has been suggested that alternative procedures are less likely to have psychologic consequences than hysterectomy, this assertion has not been studied carefully. Goldfarb 1990, J.B. Wright et al. 1996. One perspective, randomized, controlled trial found that hysteroscopic surgery and hysterectomy had a similar effect on psychiatric and psychosocial outcomes and found no evidence that hysterectomy led to postoperative psychiatric illness. Alexander et al. 1996. Other studies have reported greater satisfaction among women who had a hysterectomy than among those who had endometrial ablation. Crosignani et al. 1997, O'Connor et al. 1997. However, hysterectomy remains an important alternative when conservative treatment fails. Carlson et al. 1994b. Quality of life measures suggest that women having a hysterectomy for leiomyomas, abnormal bleeding, and chronic pelvic pain report improvement over time when compared with those who receive non-surgical management. Carlson et al. 1994a, 1994b. Other studies attempting to assess the consequences of hysterectomy in women's lives have found reports of improvement in general and sexual outcomes in the short term, 3 months postoperatively, but less positive reports in the longer term, 2 years. Bernhard 1992. Quality of life and overall satisfaction are difficult to measure. One study with 2 to 10-year follow-up found generally high levels of self-reported satisfaction after the procedure. Schofield et al. 1991. Psychologic reactions to hysterectomy. For many women, removal of the uterus has unique medical, emotional, and sexual significance and meaning. Bachman 1990b, Pahlavi 1978. Its relationship to childbearing or childbearing potential is a factor for many women, as is its association with femininity and completeness. Pahlavi 1974. Loss of menses may be perceived as a specific benefit of the surgery, particularly if the indications include abnormal or excessive bleeding or pain. Schofield et al. 1991. However, some women feel that menses represent a familiar and comforting rhythm or monthly cycle, or that menstruation cleanses the body. Bachman 1998. Misconceptions about anatomy and sexual functioning are common, with women expressing the concern that a hysterectomy actually involves removal of the vagina, rendering sexual activity impossible postoperatively. Concerns about a decrease in sexual attractiveness as a woman. Gynecologic disorders and surgery. 293 or to one's partner may be culturally related. Bachman 1990b. Sexual responsiveness after hysterectomy has been addressed in several studies. Dennerstein et al. 1977, Zussman et al. 1981. The physical effects of hormone deficiency from oophorectomy contribute to symptoms of vaginal dryness, dyspareunia, or decreased genital sensation. However, in the absence of oophorectomy or estrogen deficiency, several studies have suggested no adverse effect of hysterectomy on sexual function. Bachman 1990b, Hellstrom et al. 1993. One study found that the presence of preoperative psychiatric problems had little influence on postoperative sexuality. Hellstrom et al. 1994. The psychologic, social, and sexual consequences of hysterectomy on women's partners has been largely ignored. One recent study showed a positive effect not only on the sexual life but also on the overall quality of life of most men. Lalas and Lalas 1996. There is a current move championing supracervical or subtotal hysterectomy, with the view that the cervix itself triggers orgasm or affects the capacity to experience orgasm. Cutler 1988, although relatively little data exists. Kilku et al. 1983, Monroe 1997, Scott et al. 1997. It is also argued that retaining the cervix reduces the likelihood of painful coitus. Sloan 1978.
These arguments are not well accepted among those gynecologists who believe careful surgical attention to minimizing loss of vaginal length will prevent subsequent dyspareunia. Despite the suggestion that hysterectomy adversely affects sexual functioning, several studies have shown either no change or a beneficial effect. Clark et al. 1995, Dennerstein et al. 1977, King et al. 1993, Lalinik-Michaud and Engelsmann 1985, 1989. Historically, the belief that removing the uterus could precipitate mental illness has been advanced. In 1890, Kraft-Hebing described his observation that psychoses were more frequently caused by hysterectomy than by any other type of surgery. Although post-hysterectomy depression is widely believed to occur, in 1978, several review articles have questioned the frequency of its occurrence. Bachman 1990a, Cohen et al. 1989, Newton and Barron 1976, Patterson 1963, Pahlavi 1974. Psychologic distress has recently been reported to be less frequent after hysterectomy, with decreased symptoms. Ryan et al. 1989. Several recent studies have found no evidence that hysterectomy leads to postoperative psychiatric illness. Alexander et al. 1996. It is likely that recent changes in gynecologic practice resulting in more stringent indications for hysterectomy as well as the move toward recognizing, acknowledging, and respecting the patient as a partner in decision-making, have contributed to a lower frequency 294 psychological aspects of women's health care, second edition of adverse sequelae than had been reported previously, Gath et al. 1995. Some studies have compared the risk of postoperative psychiatric depression or referral for psychiatric services and hospitalization after hysterectomy with the risks after other surgical procedures such as cholecystectomy or cardiac surgery. Anant 1978, Bachman 1990a, Gould and Wilson Barnett 1985, Pahlavi 1974, Ruth 1984. Some of the older studies suffer from significant flaws, including studying small samples, containing little statistical data, or being based on anecdotal information. Other studies are retrospective, with problems of recall and bias. Many were published in the 1960s, when the indications and frequency of the procedure were different. Some studies have varying and often short, as little as 6 weeks, follow-up periods, whereas others have long, 3 to 5 years, follow-up periods but have problems with conclusions of causality. Many studies lack control groups for age, parity, or menopausal status. The meaning of a hysterectomy for a 20-year-old nulligravid woman is likely to be different than it is for a 60-year-old woman. Education and social class may also affect a woman's reactions to any type of surgery. Many studies have failed to control for whether the hysterectomy procedure included an oophorectomy. In addition, some studies do not separate subjects by the indications for hysterectomy. A hysterectomy for malignant disease evokes more anxiety and legitimate concerns of mortality than does a hysterectomy for benign indications. Drelich 1956, Walton 1979. Adjunctive therapies for malignancy, such as chemotherapy or radiotherapy, may have an impact on the risk of sexual dysfunction. Corney et al. 1993, Flay and Matthews 1995, Scover et al. 1989. Studies may not control for the route of the procedure, example vaginal versus abdominal. Surgical morbidity varies by the type and route of the procedure. Easterday et al. 1983. Psychiatric morbidity may also vary. The definition of adverse psychologic sequelae is frequently not clear. Some studies use vague terms such as emotional problems, and depression is a term used loosely in some studies. Other problems include cultural and social assumptions about women's primary role and the functions of childbearing. From the literature, it appears that some women may be at high risk for adverse psychologic reactions or psychiatric sequelae from hysterectomy. Anant 1978, this most notably and consistently includes women who have had previous psychiatric problems or psychiatric care. Isles and Gath 1989, Martin et al. 1980, Moore and Tolley 1976, Pahlavi 1974, Salter 1985. This group appears to have a several-fold increased risk over women without such a history. An association between abnormal menses and anxiety or depression has also been reported, which may be important in predicting a reaction. Gynecologic disorders and surgery 295 to hysterectomy, Salter 1985, Thornton et al. 1997. A history of sexual abuse may also be predictive of an adverse reaction, Lukish 1996. An optimal level of preoperative anxiety may also occur, Drelich 1956. An attitude of casual unconcern may suggest a significant level of denial that will ultimately result in symptoms, Ridgway and Matthews 1982. Women who have a hysterectomy at a young age are at an increased risk for adverse reactions, called Reader et al. 1979. In psychologic terms, it has been stated that this may be caused by a disruption of sexual/gender self-concepts that were not yet well established. An associated risk factor is that of an emergency procedure, as there may be little time to psychologically prepare for the hysterectomy, Tang 1985. Poor social support may also be a predictor of adverse psychologic sequelae, Webb and Wilson Barnett 1983a, 1983b, Wolf 1970. It appears that hysterectomy functions as does any stress, with a need for support from family, friends, and partner, Kramot and Wieninga 1984. Preoperative marital problems may be a predictor of postoperative problems, Pahlavi 1974. Low socioeconomic status and less well-educated women also seem to have higher risks of adverse reactions, perhaps related to misconceptions and fears, Wolf 1970. Women with a history of multiple surgeries or chronic pelvic pain constitute another high-risk group, Bachman 1998. It has been said that some women have psychic conflicts sailing under a gynecologic flag, Rogers 1950, and some suggest that if no pathologic diagnosis is found from the surgical specimen, the risk of adverse psychologic sequelae is higher, Barker 1968. It has also been said, however, that women are not as concerned about unnecessary hysterectomies as defined by others as they are about unwanted hysterectomies as defined by themselves, Burchell 1977. Preoperative preparation for hysterectomy, with a focus on the groups of women at higher risk, may prove helpful in minimizing the likelihood of adverse psychologic reactions, Koppen et al. 1981, Stellman 1990. The patient's own anticipation of the effects of surgery should be explored. Negative expectations about hysterectomy in particular have been correlated with deterioration in sexual functioning, Dennerstein et al. 1977. Many women want and appreciate a preoperative discussion of the potential effects of hysterectomy on sexual function, Kruger et al. 1979. Hysterectomies have been categorized as being emergent, mandatory, urgent, advisable, or elective, Easterday et al. 1983. Particularly for advisable surgery, which constitutes the majority of hysterectomies, patient participation in the decision-making process will facilitate an appropriate or adaptive 296 psychological aspects of women's health care, second edition response to the surgery. Hysterectomies performed to prevent problems or for premalignant disease should be clearly indicated. With a hysterectomy, women must take into account several quality of life considerations, Easterday et al. 1983, Roast 1979, that are influenced by her own psychologic and emotional health and by her own past experiences. She is often in the best position to consider these factors, but she may need guidance from her gynecologist or a therapist. It is important to state the risks versus the benefits of the procedure. Preoperative preparation for surgery, with education and counseling by both gynecologists and other clinicians, is particularly important for hysterectomy, Williamson 1992. The most effective manner in which to accomplish this preparation, whether in written form, verbally, or using new computer technology, is not yet well established, American College of Obstetricians and Gynecologists 1995, Young and Humphrey 1985. It is also important to state very clearly which symptoms will be alleviated by the surgery and to foster realistic expectations. Williamson 1992. Premenopausal women in whom a hysterectomy without oophorectomy is planned should be advised to expect some persistence of cyclic symptoms, example premenstrual syndrome or premenstrual dysphoric disorder, related to ovarian hormone production if these symptoms were present prior to hysterectomy. However, several studies report amelioration of symptoms after hysterectomy, with ovarian conservation, in women with premenstrual tension, implicating psychologic factors associated with the menstrual cycle in the etiology of symptoms. Metcalf et al. 1992, Osborne and Gath 1990, Silber et al. 1989. Hysterectomy with oophorectomy and subsequent hormone replacement therapy has been suggested in rare situations for the relief of severe premenstrual symptoms. Casper and Hearn 1990. Liaison between psychiatrist and obstetrician/gynecologist. Direct communication between the therapist and the obstetrician/gynecologist is important. Miscommunications sometimes arise if the physicians rely solely on the patient for information about the gynecologic diagnosis or recommendations for treatment. When hospitalization is planned, psychiatric follow-up during the inpatient stay may be appropriate or indicated. Psychiatric care may be even more critical than gynecologic care in the weeks to months after surgery. Gynecologists may feel that their care has been calm gynecologic disorders and surgery 297 pleaded by the time of the standard 4 to 6 week postoperative office visit. However, this may not be sufficient follow-up for individuals at risk for depression or other severe psychiatric sequelae. A psychiatrist or psychologist who has an ongoing relationship with a patient may need to ensure that preoperative preparation for any planned gynecologic procedure is adequate. The therapist will want first to understand the patient's understanding and expectations and then to explore the underlying meaning to the individual woman. The patient may have misconceptions about the procedure. Ideally, the gynecologist will have given the patient accurate information about the nature of the diagnosis and the recommended treatment. The psychiatrist may, however, need to address basic issues of anatomy, physiology, pathology, and therapy or to speak with the gynecologist if it appears that the patient has significant misunderstandings. Although assumptions about the patient's underlying concerns may prove to be false, common concerns such as those related to loss of sexual function, reproductive capability, or femininity may be suggested and explored as an initial effort to understand the issues for the individual. A planned surgery may sometimes prompt the gynecologist to refer a patient for preoperative preparation, although it may be more common for the psychiatrist to be consulted when problems arise postoperatively. Prevention and attempts to alleviate psychiatric risks are always preferable to consultation after a problem becomes severe. Schwab 1971. Psychiatric problems after a hysterectomy or other gynecologic procedure should be evaluated in the same way as problems presenting after other life events. Denner, Stein and Van Hall 1986. Depression should be evaluated, and treatment should be initiated with antidepressants or other appropriate medications, including hormone replacement therapy, if indicated. Suicide potential should be assessed. Psychotherapy is often most useful in conjunction with the use of antidepressants. The issue of hysterectomy or other surgery as a precipitating factor for psychiatric symptoms and the significance that the patient ascribes to her uterus can be explored during the course of therapy. Denner, Stein and Van Hall 1986. References: Abmajay, Chandra A., Mosier W.D., et al., Fertility, Family Planning, and Women's Health, new data from the 1995 National Survey of Family Growth. Vital Health Stat 23:1, 114, 1997 298 Psychological Aspects of Women's Healthcare, 2nd edition Alexander de, Nagier, Pinion S.B., et al., randomized trial comparing hysterectomy with endometrial ablation for dysfunctional uterine bleeding, psychiatric and psychosocial aspects. BMJ 312:280, 284, 1996 American College of Obstetricians and Gynecologists, Ethical Dimensions of Informed Consent. Women's Health Issues 3:1, 10, 1993 American College of Obstetricians and Gynecologists, Genital Human Papillomavirus Infections. American College of Obstetricians and Gynecologists Technical Bulletin, Vol 193, 1994 American College of Obstetricians and Gynecologists, new CD-ROM Informed Consent Program set for launch at ACM. American College of Obstetricians and Gynecologists Newsletter, Vol 39, 1995 American College of Obstetricians and Gynecologists Committee on Professional Liability, ACOG Committee Opinion, Informed Refusal. Int J Gynecol Obstet 53:84, 85, 1996 American College of Obstetricians and Gynecologists Committee on Quality Assessment. Endometrial Ablation. Int J Gynecol Obstet 52:99, 100, 1996 Amias AG, Sexual Life After Gynecological Operations, 2. BMJ 2:680, 681, 1975 Anant J, Hysterectomy and Depression. Obstet Gynecol 52:724, 730, 1978 Bachmann G.A., Hysterectomy, A Critical Review. J. Reprod Med 35:839, 862, 1990 A Bachmann G.A., Psychosexual Aspects of Hysterectomy. Women's Health Issues 1:4149, 1990 V. Barker M.G., Psychiatric Illness After Hysterectomy. BMJ 2:91, 95, 1968 Barrett Connor E., Bush T.L., Estrogen and Coronary Heart Disease in Women. JAMA 265:1861, 1867, 1991 Becker T.M., Stone K.M., Alexander E.R., Genital Human Papillomavirus Infection, A Growing Concern. Obstet Gynecol Clin North AM 14:389, 396, 1987 Bell T., Chlamydia trachomatis Infections in Adolescents. MedClin North AM 74:1225 1233, 1990 Bell T., Hein K., Adolescents and Sexually Transmitted Diseases, in Sexually Transmitted Diseases. Edited by Holmes K., Mard P.A., Sparling P., et al. New York, McGraw-Hill, 1984 Barrett J.S., Hacker N.F., Practical Gynecologic Oncology. Baltimore M.D., Williams and Wilkins, 1989 Bernhard L.A., Consequences of Hysterectomy in the Lives of Women. Healthcare Women in 13:281, 291, 1992 Bureau FM, Rosenthal S.L., Wilde L.S., et al., Self-Reported Health Concerns and Sexual Behaviors in Adolescents with Cervical Dysplasia, a Pilot Study. J. Adolescent Health 12:391, 394, 1991 Burchell R.C., Decision Regarding Hysterectomy. AMJ Obstet Gynecol 127:113, 117, 1977 Gynecologic Disorders and Surgery 299 Burke L., Apfel R.J., Fisher S., et al., Observations on the Psychological Impact of Diethylstilbestrol Exposure and Suggestions on Management. J. Reprod Med 24:99, 102, 1980 Carey M.P., Carey K.B., Weinhardt L.S., et al., Behavioral Risk for HIV Infection Among Adults with a Severe and Persistent Mental Illness, Patterns and Psychological Antecedents. Community Ment Health J. 33:133, 142, 1997 Carlson K.J., Miller B.A., Fowler F.J.J.R., et al., The Main Women's Health Study, I, Outcomes of Hysterectomy. Obstet Gynecol 83:556, 565, 1994 A Carlson K.J., Miller B.A., Fowler F.J.J.R., et al., The Main Women's Health Study, 2, Outcomes of Non-Surgical Management of Leiomyomas, Abnormal Bleeding, and Chronic Pelvic Pain. Obstet Gynecol 83:566, 572, 1994 B. Casper R.F., Hearn M.J., The Effect of Hysterectomy and Bilateral Oophorectomy in Women with Severe Premenstrual Syndrome. AMJ Obstet Gynecol 162:105, 109, 1990 Centers for Disease Control and Prevention, Chlamydia Prevalence and Screening Practices, San Diego County, California, 1993. MMWR 43:366, 369, 1994 Centers for Disease Control and Prevention, Summary of Notifiable Diseases, United States, 1993. MMWR 42I, 17, 1-73, 1994b Centers for Disease Control and Prevention, HIV Testing Among Women Aged 18 to 44 Years, United States, 1991 and 1993. MMWR 45:733, 737, 1996 Centers for Disease Control and Prevention, 10 Leading Nationally Notifiable Infectious Diseases, United States, 1995. MMWR 45:883, 884, 1996 Beach Wong C.J., Brenner P.F., Management of Abnormal Uterine Bleeding. AMJ Obstet Gynecol 175:787, 792, 1996 Clark A., Black N., Rowe P., et al., Indications for and Outcome of Total Abdominal Hysterectomy for Benign Disease, a Prospective Cohort Study. BRJ Obstet Gynecol 102:611, 620, 1995 Cohen S.M., Hollingsworth A.L., Rubin M., Another Look at Psychologic Complications of Hysterectomy. Image Jane as SCH 21:51, 53, 1989 Coppen A., Bishop M., Beard R.J., et al., Hysterectomy, Hormones, and Behavior, a Prospective Study. Lancet 1:126, 128, 1981 Corney R.H., Crowther M., Everett H., et al., Psychosexual Dysfunction in Women with Gynecological Cancer Following Radical Pelvic Surgery. BRJ Obstet Gynecol 100:73, 78, 1993 Crosignani P.G., Vercellin I.P., Apollon G., et al., Endometrial Resection versus Vaginal Hysterectomy for Menorrhagia, Long-Term Clinical and Quality of Life Outcomes. AMJ Obstet Gynecol 177:95, 101, 1997 Cutler W.B., Hysterectomy, Before and After. New York, Harper and Row, 1988 Darrow W.W., Health Education and Promotion for STD Prevention, Lessons for the Next Millennium. Genito-Urine Med 73:88, 94, 1997 300 Psychological Aspects of Women's Healthcare, 2nd edition Darrow W.W., Polly M.L., Health Behavior in Sexually Transmitted Diseases, in Sexually Transmitted Diseases. Edited by Holmes K., Mard P.A., Sparling P., et al. New York, McGraw-Hill, 1984 Dennerstein L., Van Hall E., Psychosomatic Gynecology, A Total Approach to Women's Health Problems. Park Ridge, New Jersey, Parthenon Publishing, 1986 Dennerstein L., Wood C., Burroughs G.D., Sexual Response Following Hysterectomy and Oophorectomy. Obstet Gynecol 49:92, 96, 1977 Drelich M.G., The Psychological Impact of Cancer and Cancer Surgery, 6, Adaptation to Hysterectomy. Cancer 9:1120, 1126, 1956 Droge-Muller W., Herbst A.L., Michelle D.R., et al., Comprehensive Gynecology. St. Louis, Missouri, C.V. Mosby, 1987 Dunn R.A., Webster L.A., Nakashima A.K., et al., Surveillance for Geographic and Secular Trends in Congenital Syphilis, United States, 1983 to 1991. MMWR CDC Surveil Sum 42:59, 71, 1993 Easterday C.L., Grimesda, Riggs J.A., et al., Hysterectomy in the United States. Obstet Gynecol 62:203, 212, 1983 Flay L.D., Matthews J.H.,
The effects of radiotherapy and surgery on the sexual function of women treated for cervical cancer. Int J. Radiate Oncal Biophysical 31:399, 404, 1995 Fleming D.T., McQuillan G.M., Johnson Re, et al., Herpes simplex virus type 2 in the United States, 1976–1994. An English J. Met 337:1105, 1111, 1997 Garcia C.R., Cutler W.B., Preservation of the Ovary, a Re-Evaluation. Fertile Sterile 42:510-514, 1984 Gary R., Good Practice with Endometrial Ablation. Obstet Gynecol 86:144, 151, 1995 Gath D., Rose N., Bonde, et al., Hysterectomy and Psychiatric Disorder, Are the Levels of Psychiatric Morbidity Falling? Psychol Med 25:277, 283, 1995 Gillespie C.C., Women's HIV Risk Reduction Efforts and Traditional Models of Health Behavior, A Review and Critique. Women's Health 3:1, 30, 1997 Goldfarb Ha, A Review of 35 Endometrial Ablations Using the ND-YAG Laser for Recurrent Menometrorrhagia. Obstet Gynecol 76:833, 835, 1990 Gould D., Wilson Barnett J., A Comparison of Recovery Following Hysterectomy and Major Cardiac Surgery. JAD Venus 10:315, 323, 1985 Grimes D., Diagnostic Dilation and Curettage, A Reappraisal. AMJ Obstet Gynecol 142:1, 6, 1982 Hatcher R.A., Guest F., Stewart F., et al., Contraceptive Technology, 1990–91. New York, Irvington, 1990 Hellstrom L., Lundberg Po., Sorbaum D., et al., Sexuality After Hysterectomy, A Factor Analysis of Women's Sexual Lives Before and After Subtotal Hysterectomy. Obstet Gynecol 81:357, 362, 1993 Gynecologic Disorders and Surgery 301 Hellstrom L., Wiener E., Sorbaum D., et al., Predictive Value of Psychiatric History, Genital Pain, and Menstrual Symptoms for Sexuality After Hysterectomy. Acta Obstet Gynecol Scan 73:575, 580, 1994 Herbst L., Holt L.H., Clinical Aspects of In Utero to Exposure in Obstetrics and Gynecology. Edited by Shiara J.J. Philadelphia PA, J.B. Lippincott, 1990 Herbst L., Hubby M.M., Azizi F., et al., Reproductive and Gynecologic Surgical Experience in Diethylstilbestrol-Exposed Daughters. AMJ Obstet Gynecol 141:1019 1028, 1981 Hillard J.R., Hillard P.A., Kitchell C., et al., Natural History of Psychological Reaction to Genital Herpes, A Prospective Study of Woman University Students. J. Psychosome Obstet Gynecol 10:147, 156, 1989 Hillard P.J., Bureau F.M., Wilde L.S., et al., Cervical Dysplasia and Human Papillomavirus, Evaluation in an Adolescent Dysplasia Clinic. Adolescent and Pediatric Gynecology 232, 36, 1989 A Hillard P.J., Bureau F.M., Wilde L.S., et al., The Value of an Adolescent Dysplasia Clinic. Adolescent and Pediatric Gynecology 2:43, 46, 1989 B. Huggins G.R., Sondheimer S.J., Complications of Female Sterilization, Immediate and Delayed. Fertile Sterile 41:337, 355, 1984 Echoes G., Fitzpatrick R., Frost D., et al., Psychological Disturbance and Illness Behavior in a Clinic for Sexually Transmitted Diseases. BRJ Med Psychol 60:121, 126, 1987 Isles S., Gath D., Psychological Problems and Uterine Bleeding. Bale Lyers Clin Obstet Gynecol 3:375, 389, 1989 Institute of Medicine, The Hidden Epidemic, Confronting Sexually Transmitted Diseases. Washington, D.C., National Academy Press, 1997. Johnson, J.E., Christman, New Jersey, Stitzy, Personal Control Interventions, Short and Long-Term Effects on Surgical Patients. Residential NIS Health 8:131, 145, 1985. Judd F.K., Cockram A., Midge K., et al., Liaison Psychiatry in an HIV/AIDS Unit. Ost NZJ Psychiatry 31:391, 397, 1997. Judson F.N., Assessing the Number of Genital Chlamydial Infections in the United States. J. Reprod Med 30:269, 272, 1985. Called Reader N.B., Wallace A., Horowitz M.J., A Field Study of the Stress Response Syndrome, Young Women After Hysterectomy. JAMA 242:1499, 1503, 1979. Kilkapi, Gronrose M., Hironen T., et al., Supravaginal Uterine Amputation vs. Hysterectomy, Effects on Libido and Orgasm. Acta Obstet Gynecol Scan 62:147, 152, 1983. King M.C., Torres C., Campbell D., et al., Violence and Abuse of Women, A Perinatal Health Care Issue. Ohansklin Issues Perinet Women's Health NIS 4:163, 172, 1993. Knapp R.C., Berkowitz Rs., Gynecologic Oncology. New York, Macmillan, 1986. Kramot F.W., Vieninga et. Life Stress and Hysterectomy Oophorectomy. Maturita 6:319, 325, 1984. 302 Psychological Aspects of Women's Healthcare, 2nd edition. Kruger J.C., Hassel J., Goggins D.B., et al., Relationship between Nurse Counseling and Sexual Adjustment After Hysterectomy. NIS Res 28:145, 150, 1979. Lalinik Michaud M., Engelsman F., Anxiety, Fears, and Depression Related to Hysterectomy. Kinjay Psychiatry 30:44, 47, 1985. Lalinik Michaud M., Engelsman F., Cultural Factors and Reaction to Hysterectomy. SOC Psychiatry Psychiatry Epidemial 24:165, 171, 1989. Lalas A., Lalaso, The Partner's View About Hysterectomy. J. Psychosome Obstet Gynecol 17:119, 124, 1996. Luby E., Gillespie D., The Helper, A Quarterly Publication of the Herpes Resource Center 3:3, 4, 1981. Luby E., Klinge V., Genital Herpes, A Pervasive Psychosocial Disorder. Archdermatal 121:494, 497, 1985. Martin R.L., Roberts W.V., Clayton P.J., Psychiatric Status After Hysterectomy, A 1-Year Perspective Follow-Up. JAMA 244:350, 353, 1980. Masters W.H., Johnson V., Human Sexual Response. Boston Ma, Little, Brown, 1966. Meyer W.J., Van Lindert A.C., Prophylactic Oophorectomy. Urj Obstet Gynecol Reprod Bile 47:59, 65, 1992. Metcalf M.G., Braden V., Livesey J.H., et al., The Premenstrual Syndrome, Amelioration of Symptoms After Hysterectomy. J. Psychosome Res 36:569, 584, 1992. Moore J.T., Tolly D.H., Depression Following Hysterectomy. Psychosomatics 17:86, 89, 1976. Mosier W.D., Pratt W.F., Use of Contraception and Family Planning Services in the United States, 1988. AMJ Public Health 80:1132, 1133, 1990. Monroe M.G., Supracervical Hysterectomy, A Time for Reappraisal. Obstet Gynecol 89:133, 139, 1997. Nannies et. Patterson T.L., Semple S.J., et al., Coping with HIV Disease Among Seropositive Women, Psychosocial Correlates. Women Health 25:1, 22, 1997 Nathorsbus J. von Skulsby, Psychological Reactions and Sexual Life After Hysterectomy with and Without Oophorectomy. Gynecol Obstet Invest 34:97, 101, 1992 Newman D.K., Burns P.A., New Approaches for Managing Stress Incontinence in Women. Lippincott Prim Care Pract 1:382, 387, 1997 Newton N., Baron E., Reactions to Hysterectomy, Fact or Fiction. Primcare 3:781, 801, 1976 O'Connor H., Broadbent J.A., Mugos A.L., et al., Medical Research Council Randomized Trial of Endometrial Resection versus Hysterectomy in Management of Menorrhagia. Lancet 349:897, 901, 1997 or D.P., Wilbrand M.L., Brack C.J., et al., Reported Sexual Behaviors and Self-Esteem Among Young Adolescents. AMJ Dischild 143:86, 90, 1989 Osborne M.F., Gath D., Psychological and Physical Determinants of Premenstrual Symptoms Before and After Hysterectomy. Psychol Med 20:565, 572, 1990 Gynecologic Disorders and Surgery 303 Patterson R.M., Misconceptions Concerning the Psychological Effects of Hysterectomy. AMJ Obstet Gynecol 85:104, 111, 1963 Peterson H.B., Siazi, Hughes J.M., et al., The Risk of Pregnancy After Tubal Sterilization, Findings from the U.S. Collaborative Review of Sterilization. AMJ Obstet Gynecol 174:1161, 1168, 1996 Pallavi J., Psychological Reactions to Hysterectomy, A Critical Review. AMJ Obstet Gynecol 118:417, 426, 1974 Pallavi J., Quality of Life and Factors Affecting the Response to Hysterectomy. FAMPRAC 3:483, 488, 1978 Rackley R.R., Appel R.A., Evaluation and Medical Management of Female Urinary Incontinence. Cleveland J. Med 64:83, 92, 1997 Ridgway v. Matthews A., Psychological Preparation for Surgery, A Comparison of Methods. B.R.J. Clin Psychol 21:271, 280, 1982 Rockwell D., Python Rockwell F., The Emotional Impact of Surgery and the Value of Informed Consent. MedClin North AM 63:1341, 1351, 1979 Rosk NC, Hysterectomy and the Quality of a Woman's Life. Arch Intern Med 139:146 147, 1979 Rogers FS, Emotional Factors in Gynecology. AMJ Obstet Gynecol 59:321, 327, 1950 Roos NP, Hysterectomies in One Canadian Province, A New Look at Risks and Benefits. AMJ Public Health 7439, 46, 1984 Ryan M.M., Dennerstein L., Pepperell R., et al., Psychological Aspects of Hysterectomy, A Prospective Study. BRJ Psychiatry 154:516, 522, 1989 Salter J.R., Gynecological Symptoms and Psychological Distress in Potential Hysterectomy Patients. J. Psychosome Rest 29:155, 159, 1985 Schofield M.J., Bennett A., Redman S., et al., Self-Reported Long-Term Outcomes of Hysterectomy. BRJ Obstet Gynecol 98:1129, 1136, 1991 Scover L.R., 5M, Jers Henson D.M., Sexual Dysfunction and Treatment for Early Stage Cervical Cancer. Cancer 63:204, 212, 1989 Schwab J.J., The Psychiatric Consultation, Problems with Referral. Dysnerve SYST 32:447 452, 1971 Scott J.R., Sharp H.T., Dodson M.K., et al., Subtotal Hysterectomy in Modern Gynecology,
a decision analysis. AMJ Obstet Gynecol 176:1186, 1191, 1997 Sherwin B.B., Gelfand M.M., differential symptom response to parenteral estrogen and/or androgen administration in the surgical menopause. AMJ Obstet Gynecol 151:153, 160, 1985 Silber M., Karlstrom K., Larson B., premenstrual syndrome in a group of hysterectomized women of reproductive age with intact ovaries. ADV Contracept 5:163 171, 1989 Sloan D., The Emotional and Psychosexual Aspects of Hysterectomy. AMJ Obstet Gynecol 131:598, 605, 1978 304 Psychological Aspects of Women's Healthcare, 2nd edition Sparoff P., Dawson N.V., Sparoff L., et al., a risk-benefit analysis of elective bilateral oophorectomy, effect of changes in compliance with estrogen therapy on outcome. AMJ Obstet Gynecol 164:165, 174, 1991, Stellman Road, Psychological Aspects of Gynecologic Surgery in Gynecology and Obstetrics. Edited by Shiara J.J. Philadelphia PA, L.B. Lippincott, 1990 10 GW, Reactions to Emergency Hysterectomy. Obstet Gynecol 65:206, 210, 1985 Tay S.K., Yong T.T., High long-term cure rate justifies routine treatment of cervical intraepithelial neoplasia grade I Ost NZJ Obstet Gynecol 35:192, 195, 1995 T.E. Linda R.W., ed. T.E. Linda's Operative Gynecology. Philadelphia PA, J.B. Lippincott, 1977 Tiertz J.J., Barber H.R., Brunswick A., Incidence of Carcinoma in the Retained Ovary. AMJ SURG 113:511, 515, 1967 Thomas V, Heath M., Rose D., et al., Psychological Characteristics and the Effectiveness of Patient-Controlled Analgesia. BRJNS 74:271, 276, 1995 Thornton E.U., McQueen C., Rosser R., et al., a prospective study of changes in negative mood states of women undergoing surgical hysterectomy, the relationship to cognitive predisposition and familial support. J. Psychosome Obstet Gynecol 18:2230, 1997 Townsend D., Richard R. M., Cryotherapy and Carbon Dioxide Laser Management of Cervical Intraepithelial Neoplasia, a Controlled Comparison. Obstet Gynecol 61:7578, 1983 Travis E.B., Medical Decision-Making and Elective Surgery, The Case of Hysterectomy. Risk Anal 5:241, 251, 1985 Underwood P.V.J.R., Ovarian Conservatism. South Met J 69:405, 408, 1976 Walton L.A., The Stress of Radical Pelvic Surgery, a Review. Biochemical, Psychological, Gastrointestinal, Hepatic, and Cardiac Effects. Gynecol Uncle 7:25, 35, 1979 Webb C., Wilson Barnett J., Hysterectomy, A Study in Coping with Recovery. JAD Venus 8:311, 319, 1983 A Webb C., Wilson Barnett J., Self-Concept, Social Support, and Hysterectomy. Int Janus Stud 20:97, 107, 1983 B. Webster L.A., Rolfs R.T., Surveillance for Primary and Secondary Syphilis, United States, 1991. MMWR-CDC Surveil Sum 42:13, 19, 1993 Webster L.A., Greenspan J.R., Nakashima A.K., et al., An Evaluation of Surveillance for Chlamydia Trachomatis Infections in the United States, 1987-1991. MMWR-CDC Surveil Sum 42:21, 27, 1993 Weinhardt L.S., Carey M.P., Carey K.B., HIV Risk Reduction for the Seriously Mentally Ill, Pilot Investigation and Call for Research. J.B. Hobther EXP Psychiatry 28:8795, 1997, Williamson Mill, Sexual Adjustment After Hysterectomy. J. Obstet-Gynecol Neonatalness 21:42, 47, 1992 Gynecologic Disorders and Surgery 305 Wilson J.F., Behavioral Preparation for Surgery, Benefit or Harm. J.B. Hobmed 4:79 102, 1981 Wolf S.R., Emotional Reaction to Hysterectomy. Postgrad Med 47:165, 169, 1970 Wright J.B., Gannon M.J., Greenberg M., Psychological Aspects of Heavy Periods, Does Endometrial Ablation Provide the Answer? B.R.J. Hosp Med 55:289, 294, 1996 Wright T.C.J.R., Gagnon S., Richard R.M., et al., Treatment of Cervical Intraepithelial Neoplasia Using the Loop Electrosurgical Excision Procedure. Obstet-Gynecol 79:173 178, 1992 Wukish R.N., The Impact of a History of Rape and Incest on the Post-Hysterectomy Experience. Healthcare Women in 17:47, 55, 1996 Young L., Humphrey M., Cognitive Methods of Preparing Women for Hysterectomy, Does a Booklet Help? B.R.J. Clin Psychol 24:303, 304, 1985 Youngs D.D., Wise T.N., Psychological Sequelae of Elective Gynecologic Surgery, in Psychosomatic Obstetrics and Gynecology. Edited by Youngs D.D., Earhart A. New York, Appleton Century Crofts, 1980 Zussman L., Zussman S., Sunley R., et al., Sexual Response After Hysterectomy Oophorectomy, Recent Studies and Reconsideration of Psychogenesis. AMJ Obstet-Gynecol 140:725, 729, 1981 This page intentionally left blank 15 Gynecologic Oncology Linda Hammer Burns, Ph.D. Sweet Weight, in celebration of the woman I am and of the soul of the woman I am and of the central creature and its delight I sing for you. And Sexton, in celebration of my uterus each year in the United States, 81,000 women are newly diagnosed and approximately 26,500 die from gynecologic cancer, and 180,200 women are newly diagnosed and 43,900 die from breast cancer, Parker et al. 1997. In short, although many more women contract breast cancer, proportionately, more women die of gynecologic cancer. Gynecologic cancer is defined as carcinoma of the female reproductive organs, example uterine, ovarian, cervical, vaginal, vulvar, and is usually treated by a specialist in gynecologic oncology. Increasingly, screening of healthy, asymptomatic women for some gynecologic cancers through Pap, Pap, smears, and increasingly sonography, is becoming fundamental to the routine care of women. Within the array of gynecologic cancers exists variation in diagnosis, treatment, and options. For example, more than 2/3 of cervical cancers in the United States are detected in situ, largely as a result of the Pap smear, and are highly curable. By contrast, ovarian cancer is the most deadly gynecologic cancer, and yet no effective screening method exists. Ovarian cancer typically affects older women who present with vague symptoms in advanced stages of the disease, when it is most difficult to treat. Cervical cancer is now largely CON 307-308 Psychological Aspects of Women's Health Care, 2nd edition cited as sexually transmittable disease, with sexual history and socioeconomic status as major factors in its development, whereas ovarian cancer is more likely to be related to genetic factors, reproductive history, obesity, and age. Treatment of gynecologic cancers may include surgery, radiation therapy, and/or chemotherapy. For example, early cervical cancers may involve a single minor surgery, colposcopy, using laser or cryotherapy with little long-term impact on functioning or well-being, whereas some more advanced cancers involve total pelvic exenteration that dramatically affects the woman's long-term health, psychologic adjustment, sexuality, and reproductive life. Psychosocial aspects of gynecologic cancer. Throughout history, the uterus has had special meaning to women and men. The importance of the uterus as a psychosexual organ varies from woman to woman, culture to culture, and encompasses a broad range of meanings: a childbearing organ, an excretory organ, a regulator and controller of body processes, a sexual organ, a source of female competency, a reservoir of strength and vitality, and maintainer of youth and attractiveness. Bachman, 1990. Even for women who have children, premature loss of childbearing ability may create worries about accelerated aging, inadequacy, incompleteness, altered sexual experiences, and loss of femininity. Bachman, 1990. Despite ambivalent feelings about the discomfort or inconvenience of menstruation, many women value it as a means of setting the rhythm of life, as an important cleansing process, or as a reassurance of health and well-being. As such, it is understandable how the loss of these organs can have complex and significant meanings for women that affect not only their response but also their psychologic adjustment to the disease. It is not uncommon for a woman to feel that gynecologic cancer is punishment for past sexual misdeeds, example promiscuity, contraction of a sexually transmitted disease, or reproductive failures, example elective abortion, miscarriage, or infertility. These issues become particularly complex if a woman's gynecologic cancer is related to her sexual behavior or that of her partner, example cervical. It is noteworthy that the woman's sexual experiences are the only sexual risk factor often considered, even though she assumes the risk of her partner and his previous/current sexual partners. A monogamous woman who develops cervical cancer is often assumed to have been promiscuous while her partner's sexual risk behavior is disregarded. When issues of infidelity do arise, the result can be relationship and psychologic distress, so gynecologic oncology 309 child stigma, or misconceptions that the cancer was self-inflicted or preventable and as such does not warrant support. Feelings of guilt and self-recrimination may follow the diagnosis, although these feelings may not be openly shared. Equally difficult is the cancer diagnosis that may have a genetic etiology, example ovarian, prompting family discussion and/or risk identification of first-degree relatives. As with many genetic conditions, women often feel guilty and responsible for passing on bad genes and putting their loved ones in jeopardy. In addition, many women still fear that cancer is contagious or an automatic death sentence and, as a result, fear telling family and friends because they are afraid of rejection, abandonment, or reproach. Finally, some women, especially those who have lived healthy, low-risk lifestyles, simply cannot believe the cancer diagnosis and respond with denial, avoidance, or minimization, which may affect compliance and other health behaviors. Newsom et al., 1996, found that cancer patients who believe that they could have prevented their illness may be at greater risk for depression. In a study of 120 adults with recurrent cancer, 5 domains of control were identified: 1. Self-blame, 2. Control over cancer onset, 3. Control over symptoms, 4. Control over the course of the illness, and 5. Overall control over life events. Although self-blame was not found to be related to symptoms of depression, perceived control over cancer onset predicted subsequent depression. The authors concluded that helping cancer patients resolve feelings of regret and remorse is an important intervention. Today, a diagnosis of cancer is less likely to mean a precipitously shortened life and is more likely to mean a chronic illness. Because many patients are cured by initial therapy, psychologic response is less likely to involve preparation for death and dying and more likely to entail adjustment to what may be extensive, invasive, and prolonged medical treatment. The losses of gynecologic cancer are, therefore, more likely to be loss of health, lifestyle, reproductive ability, or sexual satisfaction. Cross-cultural issues have increasingly gained attention in the care of cancer patients as an important aspect of medical and psychosocial care, because cultural beliefs and values necessarily influence the patient's reaction to illness, treatment choices, illness behavior, and psychologic response. In a review of the major cultural considerations in the optimal care of patients with chronic medical illness, Trill and Holland, 1993, found the following factors to be in 310 psychological aspects of women's health care, 2nd edition, influential in health-related behaviors, family function, gender roles, language, disclosure of disease-related information, pain, attitudes toward illness and health practices, immigration, religion, autonomy versus dependency, and death and bereavement. Finally, many patients straddle two cultures, and it is often difficult to assess which cultural practices and beliefs they, or their family members, have retained from their original culture and which they have adopted from the new culture. Culturally defined gender roles may affect a woman's coping mechanisms, the response of others, and the caregiver's response. Gender role expectations can be highly significant for women with gynecologic cancer in a culture that highly values women for their reproductive ability. The major loss for many young women with cancer is the loss of reproductive ability. Although alternative forms of childbearing or family building may be considered, the loss remains significant for most women, although it is not often addressed in the early stages of cancer treatment. In some cultures, women are expected to suffer silently and stoically, example Scandinavian, American Indian, whereas in other cultures women are expected to relinquish their autonomy and become completely dependent on male family members and caregivers, example some Hispanic cultures. Family beliefs about illness, including family involvement in patient care and acceptable levels of patient dependence on family members, are also influenced by cultural values and are important factors in treatment planning and implementation. The need for autonomy or dependency appears to be strongly influenced by cultural values, with significant implications for caregivers and medical decision-making. Religion is another area that can determine patient acceptance of illness, the suffering it entails, and acceptable behaviors regarding death and dying. Finally, acceptable practices regarding dying and bereavement vary significantly across cultures, with behaviors and customs often having significantly different meanings. Developmental life stages. Although women of all ages may have some feelings about the loss of reproductive organs, the stage of a woman's life may influence the degree of her feelings. Typically, an older woman who has completed her childbearing will respond differently to the loss of her reproductive organs than will a younger, childless woman. Erickson's, 1963, developmental life stage model outlines normal developmental milestones and describes how failure to achieve gynecologic oncology 311 mental stage goals threatens a woman's normal and healthy maturation. Psychologic issues of cancer across the developmental lifespan involve altered relationships, dependence versus independence, achievement disruptions, integrity of body image, and existential issues. Rowland, 1989. Young adulthood, age 19 to 30, according to Erickson, 1963, the developmental tasks of young adulthood are separation and individuation and intimacy versus isolation. During this period, the young person establishes an autonomous and stable sense of self. Cancer interrupts these tasks at a time when a young woman should have increased autonomy and independence. She must rely instead on her parents for physical as well as psychological care. Life goals must be readjusted or redirected, limitations integrated, and relationships realigned, all within the context of complex medical treatment and side effects, example alopecia, nausea, vomiting, surgical scars, weight loss/gain, fatigue, ostomies, vaginal stenosis, fistulas, anxiety, or depression. Sexual functioning. Gynecologic cancer interrupts a young woman's establishment of healthy, intimate, and romantic relationships by challenging the integrity of her body image, example impaired feelings about oneself as a sexual person, dampening of sexual feelings, and by altering established relationships, example unsteady romances unable to weather the demands of cancer. Cancer may strike before the young woman has become sexually active, established a stable sexual identity, explored romantic relationships, or explored reproductive goals. Postoperative psychosexual problems in women who have had a hysterectomy appear to be more prevalent in women with the following profiles. 1. preoperative history of depression, sexual dysfunction, or other psychologic disturbances. 2. Age less than 35 to 40 years. 3. Limited education. 4. Conflict about future childbearing. 5. Poor understanding of the surgery and its consequences. 6. Belief that the uterus has unique psychologic and sexual importance. And 7. Absence of pelvic pathology. Bachman. 1990. In evaluating sexual problems in the young woman, it is important to determine her sense of her sexual self, her previous sexual functioning, the extent of her physical impairment because of the disease, the etiology of the sexual problem, and the status of her romantic relationship. 312 Psychological Aspects of Women's Healthcare, 2nd edition. Family relationships and reproduction. Although young women with gynecologic cancer have more reproductive choices than ever before, the issue of reproductive loss remains primary and fundamental. Today, assisted reproductive technologies offer many women, depending on the type of cancer, the opportunity to extend or preserve their reproductive ability. Patients increasingly expect caregivers to protect their reproductive options and/or consider their reproductive futures as part of treatment. Gynecologic cancer can be less traumatizing when caregivers offer information on family-building alternatives such as in vitro fertilization, donor oocytes, surrogacy, and/or gestational carrier. Work achievement disruptions during this era typically involve postponement or relinquishment of education or career goals and redefinition of life plans and long-held hopes and dreams. The completion of education and/or the establishment of a career are important tasks of this stage. Failure to proceed on course puts many young women out of sync with their peers, thus increasing social and economic pressure and precipitating reassessment of original goals and life plans. Existential issues. Existential issues focus on the question how and why me, on feelings about death or dying, and on incorporation of the illness and its consequences into one's sense of self. The specter of potential death does not fit into young people's schema of life and/or that of their peers. Combined with the typical self-absorption and egocentricity of this stage, it is understandable that many young women feel isolated and detached, even from caring friends and family. Issues of survivorship may enhance feelings of inability to relate to peers or difficult romantic attachments. Having lost important friendships and relationships, these women may gain an altered perspective, a new internal schema and inner strength, and a better sense of their internal resources, all of which affect their relationships with others as well as with themselves. Mature adulthood, ages 31 to 45, often considered the most stable era of life. Mature adulthood is characterized by personal maturity, consolidation of career, and development of stable gynecologic oncology. 313 relationships, including nurturance of the younger generation through either parenthood or mentorship. Erickson, 1963, defined this stage as generativity versus stagnation, contending that failure to achieve a productive and creative sense of self leads to personal impoverishment, pseudo-intimacy, excessive dependence, or premature disengagement from society. Emphasis on generativity during this era highlights the childbearing losses of women who had postponed childbearing or had experienced infertility or childbearing losses, example miscarriage. Although unusual, gynecologic cancer during pregnancy is considered a reproductive crisis, especially if the pregnancy lost is the woman's only or final pregnancy. Sexual functioning. The impact of cancer on sexuality is largely determined by the type of cancer and its treatment, example cervical dysplasia treated by cone biopsy versus invasive vulvar cancer requiring total exenteration. Both estrogen and/or testosterone deficiency caused by absent ovarian function due to surgical or radiation-induced menopause, resulting in vaginal shrinking and reduced lubrication, may contribute to sexual problems and feelings of being old before my time. Side effects of cancer treatment such as scarring, depression and anxiety, hot flashes, ostomies, or the use of vaginal dilators are often interpreted as insults to one's sense of self and body integrity. The most common sexual problems encountered by women with gynecologic cancer are painful intercourse, lack of arousal, less satisfaction with sex, and less enjoyment of intercourse, Anderson and DeProssi 1989a, 1989b, Crum and Lombardi 1993. Women who do not follow advice regarding the use of vaginal dilators and/or do not resume their pre-illness level of sexual functioning are more likely to develop physical and sexual changes that ultimately affect sexual satisfaction. Interestingly, most women believe that cancer could be transmitted through sexual intercourse, a factor often overlooked in caregiver discussions of sexual functioning with women and their partners. Crum and Lombardi 1993. Suggestions for enhancing sexual functioning include arousal-enhancing rather than anxiety-reducing techniques, lubricants, example Astroglide, variation of sexual positions, controlled depth of penetration to manage pain, and the use of vaginal dilators. Scover 1997. Family relationships and reproduction for women who are mothers. Their role as mother is often significantly affected by cancer. Women are typically distressed and anxious about their inability. 314 Psychological Aspects of Women's Healthcare, 2nd edition ITY to care for their children, find trustworthy caregivers, and deal with their children's response to their illness as well as the possibility that they may not live to raise their children. Many women feel guilty for being irritable with normal childish behaviors, example bickering, pushing limits, or disappointed by their children's inability to provide them with comfort and support. In a study of children's responses to their mother's cancer, Hilton and Alford 1996, the developmental level of the child was the definitive factor. With preschoolers, the dependency needs of the child made child care a primary concern, whereas with teenagers, increased home and caregiving demands interrupted the adolescent's moves toward independence, creating role confusion and increasing family tension. Furthermore, parents were unaware of increased distress or psychologic symptoms in their children. Work for many women, diminished productivity at work represents myriad losses: personal fulfillment, financial remuneration, a social sphere, personal direction, and life structure, meaning, or purpose. Anderson and DeProssi, 1989b, found that although women with cancer were not able to work as many hours as their healthy counterparts, their career paths remained intact. Nevertheless, cancer treatment often results in missed raises or promotions, lost opportunities to change positions, pressure to make up for time away, and fatigue that prevents work performance at previous standards. Petzel et al. In Press. Furthermore, both illness-related job disruptions and the high cost of medical care may threaten long-term personal and familial financial commitments, example children's educations, mortgages. Rowland 1989. Existential issues. Cancer is a traumatic event in which many women experience a shattering of assumptions about themselves and the world in which they live. 1. The world is benevolent. 2. The world is meaningful. And 3. The self is worthy. Janoff Bowman 1992. The existential struggle involves giving meaning to the cancer experience and regaining a belief in a predictable and benevolent world. Midlife or older adulthood, age 46 to 65, according to Erickson, 1963, the developmental task of midlife is integrity versus despair, characterized by achieving a balance between the triumph of one's accomplishments and the despair of one's failures. Inadequate resolution der gynecologic oncology 315. This error results in despair about one's achievements and disappointments. Although midlife is often a stage of reflection and self-examination during which individuals redirect energies and replot life goals, cancer can trigger identity crises and distress in women who fear aging or for whom womanhood and/or feminine identity is linked to reproductive ability, sexual organs, and/or sexuality. Cancer treatments may accelerate aging at a time when many women are already adjusting to typical midlife changes such as increased weight, diminished skin elasticity, or musculoskeletal problems. In fact, some women simply cannot tolerate the physical limitations or alterations in appearance imposed by cancer and/or aging, thus precipitating serious psychologic distress. Sexual functioning. Anderson and DeProssi, 1989a, in a longitudinal study, found that although sexual functioning was significantly disrupted for women with gynecologic cancer, their marital and other social relationships remain satisfactory. In a study of cancer patients' spouses, Savo et al. 1986, men assumed the supportive role preferred by their wives, but the women interpreted this role reversal as rejecting and insensitive, thus leading to relationship distress. However, in a study of experiences of the male partners of women with gynecologic cancer, Lalas et al. 1995, found that both partners experienced sexual intercourse as much more negative after treatment had been completed, and most men reported impaired sexual desire. Men found it difficult to know how to behave and communicate with their wives, with most reporting that they had nobody to whom they could speak openly about their wife's cancer. Furthermore, most men had not obtained basic information about their partner's disease, leading many researchers to conclude that increased involvement of spouses in cancer treatment and decision-making leads to better adjustment in both the patient and the spouse. Anderson and Aprasi 1989a, Scover 1997. Family relationships and reproduction. It is not uncommon for women to operate as the emotional kingpin in families, providing emotional connection, stability, and direction in the family system. Not surprisingly, when these women are unable to perform their various roles as mother, daughter, sister, and/or wife, they experience discomfort and the family system is destabilized, often with distressing results. Cancer has the potential for affecting a woman's unfinished business with family. 316 Psychological aspects of women's healthcare, 2nd edition members, or triggering the re-emergence of old issues or conflicts. Relationship distress may affect multiple relationships or be confined to a single relationship, example marriage, parent/child, and may include recognition of a chronically unhappy marriage, spouses who are unavailable, unreliable, or uninterested as the demands of cancer treatment and emotional dependence intensify. Cancer often precipitates long postponed personal reflection or relationship examination that results in the realignment of personal priorities, revamping of relationships, or resetting of personal goals in an attempt to make one's remaining years as meaningful, productive, and pleasant as possible. Women in this stage are typically less involved in beginning parenthood and more likely to be launching children. However, whether their children are very young, adolescents, or independent adults, women's roles as mothers and caretakers often remain significant, and they may grieve the loss of these roles. Alternatively, during this era many women have responsibility for the care of parents or older family members. Within this context, cancer may trigger family adjustments such as the placing of older family members in residential care, which often triggers feelings of guilt, regret, or worry. Relinquishing these important nurturing roles can be very difficult for many women, especially if it also means relinquishing their own independence and autonomy, example having to live with their own children. Work anger, frustration, and disappointment may arise when cancer requires curtailment of career goals, precipitates early retirement, or creates financial insecurity. Women may feel frustrated by their inability to pursue career goals or enjoy a pleasant and worry-free retirement. Feelings of discouragement and depression are understandable when women must spend their golden years being ill and watching their hard-earned retirement savings go to medical bills. Some patients choose less expensive medical treatments or even contemplate suicide as a means of protecting their spouse and family from financial ruin. Rowland 1989. Existential issues characteristic of the midlife era is heightened introspection and reflection, which may lead to potential despair about failures, unattained goals, or the meaning of one's life. Rowland 1989. Depression may be associated with less denial and greater recognition of death as a possible outcome of the Gynecologic Oncology 317's. Overemphasis on death, despair about one's lack of accomplishments, or introspection may put a woman at risk of self-imposed isolation or of premature surrender to the illness. Rowland 1989. Struggles with existential issues often involve such questions as is this what I lived and worked for, why me, and what now? Aging adulthood, age 66 and older, late adult transition involves reworking the past, finding a balance between social and self-involvement, making peace with inner and external enemies, and coping with death, Levinson 1986. It also involves adapting to changes associated with normal aging, such as physical and mental deterioration or limitations imposed by other health problems. Family relationships. Aging and illness often involve relinquishing status and authority within the family and within society. For many women, cancer precipitates the abdication of leadership roles. They are no longer the primary family caretakers, but rather the responsibility of the younger generation. Issues of autonomy and independence often surface as women grapple with feelings of being a burden to spouses, children, or grandchildren. An important task is finding new purposes in life and adapting to losses of health, work, friends, and family, which for many women involves creating a legacy for their families or getting their affairs in order. Sexual functioning. Threnove and Clay, 1994, investigated the extent of sexual problems and the prevalence of sexual activity in women aged 52 to 63 with gynecologic cancer. Little or no desire for sexual relations was the most common sexual problem found, 74% of women and 42% of their partners, although 54% of the women were sexually active. Only 22% of the women with a partner expressed dissatisfaction with their sexual life or lack thereof. Sexual activities were not related to diagnosis or stage of disease. Despite decreased sexual desire and dyspareunia, a large percentage of women continued to be sexually active, leading the study authors to conclude that patients and their partners should be given information on sexual changes caused by their disease, reassured about regaining sexual capacity, and informed about the feasibility of sexual satisfaction. 318 Psychological Aspects of Women's Healthcare, 2nd edition. Work retirement. A normal transition at this stage typically involves yielding of authority and status and the review of one's life successes and failures. These normal transitions can be complicated by abrupt changes or interruption of an enjoyable retirement by illness, medical treatment, or adapting to physical disabilities, decreased income, or limited mobility. Existential issues. In one recent study, Cicciarelli 1997, of 388 adults over age 60, most expressed a wish to continue living if they faced a terminal illness or non-terminal illness that resulted in sustained lower quality of life, immobility, extreme dependency, pain, or loss of mental faculties. A minority, 10%, favored ending their life under such circumstances. These adults tended to be of higher socioeconomic status, less religious, more lonely, placed a higher value on the quality of life, and expressed greater fear of the dying process. Brown et al., 1994, asked women with gynecologic cancer about their reactions to a poor prognosis and their preferences for withdrawing or withholding life-sustaining technologies. Only 5% anticipated giving up, whereas 78% expressed resolve to continue the fight against their disease. Most preferred receiving in-home care and would refuse artificial life-sustaining measures such as ventilator support, 90%, surgery for another life-threatening condition, 34%, artificial nutrition, 37%, and antibiotics, 22%. These women anticipated managing their disease with a fighting spirit. Although many would reject life-sustaining measures, far fewer would take active measures to shorten their lives. Disturbed psychologic response. Although several studies suggest that the initial, short-term response to cancer may include psychologic distress and impaired social functioning, most cancer patients adjust successfully and, over time, do not differ on most psychologic outcome measures from individuals with benign disease. The vast majority of psychologic problems in women with cancer involve the efforts of psychologically stable individuals to adjust to cancer and its treatment. Women at risk for disturbed response are more likely to have a history of maladaptive coping strategies, previous severe psychiatric disorder, low levels of social support, and/or a history of previous suicide attempts. The most common types of psychologic disturbances in cancer patients are depression, gynecologic oncology 319, and anxiety. Most cancer patients experience heightened anxiety and depression at diagnosis and at crisis points in the disease or treatment. However, up to 50% of women develop a psychiatric disorder, most of which are adjustment disorders and mood problems, Derogatis et al. 1983, that can result in poor reporting of medical symptoms, poor adherence or refusal of treatment, deterioration of relationships, and delayed return to pre-illness functioning because of loss of motivation and pessimistic outlook. Pre-existing psychiatric problems can worsen during treatment, complicating care, example patients with a history of chemical dependency or abuse requiring special attention. Psychologic symptoms in cancer patients also warrant a search for organic causes, see Table 15-1. Social problems in families relating to alcoholism, criminal activity, cultural pressures, poverty, physical or sexual abuse, and other forms of maltreatment should be considered, especially in elderly or vulnerable patients. Depression. When sadness becomes depression, women must not only manage the burden of cancer but the consequences of depression, which often increase the level of disability, decrease compliance, increase suicidality, and lead to poorer outcome. Roth and Holland 1994. Major depression occurs in approximately 25% of cancer patients, with the highest prevalence in those with the greatest disability and most distressing symptoms. McCoy 1996, Valenti et al. 1994. Women at increased risk of depression have a history of affective disorder or alcoholism, poorly controlled pain, concurrent illness, advanced illness, poor prognosis, and severely disfiguring treatments, and are being treated with medications that produce depressive symptoms. Buchberg et al. 1984, Massey 1989b, Massey and Holland 1989. Psychiatric consultation should be considered when depressive symptoms last longer than 2 weeks, worsen rather than improve, or interfere with the patient's ability to function or cooperate with treatment. See Tables 15-2 and 15-3. Prolonged and severe depressive symptoms usually require combined psychotherapy and somatic treatment. Typically, the decision to prescribe a psychotropic medication depends on the level of distress and how significantly the patient's symptoms impair her daily functioning. It should be remembered that inadequate attention and detection are the biggest barriers to effective treatment. The most commonly used antidepressants for cancer patients in the past were the tricyclic antidepressants, example amitriptyline, nortriptyline, imip. 320 Psychological Aspects of Women's Healthcare, 2nd edition, Table 15-1. Medications that may induce depression: analgesics/anti-inflammatory, ibuprofen, indomethacin, baclofen, cocaine, opiates, morphine, codeine, pentazocine, penicillin, phenylbutazone, anticonvulsants, carbamazepine, ethosuximide, phenobarbital, phenytoin, primidone, antihistamines, antihypertensive agents, clonidine, guanethidine, hydralazine, hydrochlorothiazide, methyldopa, propranolol, reserpine, spironolactone, antimicrobials, ampicillin, cycloserine, diapsone, grizofulvin, isoniazid, metronidazole, nalidixic acid, nitrofurantoin, procaine, penicillin, streptomycin, sulfonamide, tetracycline, antineoplastic, serodioprin, 6-azuridine, L-asparaginase, bleomycin, cisplatin, cyclophosphamide, doxorubicin, mithramycin, vinblastine, vincristine, antiparkinsonian agents, amantadine, bromocriptine, levodopa, hormones, ACTH, corticosteroids, estrogen/oral contraceptives, immunosuppressive agents, miscellaneous, amphetamine withdrawal, caffeine, cimetidine, digitalis, disulfiram, halothane, inderal, metoclopramide, where methysergide, methrizamide, phenylephrine, neuroleptics, fluphenazine, haloperidol, prochlorperazine, sedatives/tranquilizers, barbiturates, chloral hydrate, diazepam, ethanol, flurazepam, major tranquilizers, minor tranquilizers, triazolam, alprazolam, stimulants, amphetamine, abuse, diethylpropion, fenfluramine, abuse, methylphenidate, drugs that have a high incidence of depressive side effects. Source: Valenti S.M., Saunders J.M., Cohen M.Z., Evaluating Depression Among Patients with Cancers. Cancer Practice 2:65, 71, 1994. Reprinted with permission. Ramin, Massey 1989b, see Table 15-4, which were started in low doses, 25 to 50 milligrams, given at bedtime and increased slowly over days to weeks until symptoms improved. Usually the peak dose is lower than that tolerated by physically healthy patients. Heterocyclic antidepressants, including the second-generation antidepressants, example trazodone, have been found useful as sedating medications in agitated patients and those with insomnia. The Gynecologic Oncology 321 Table 15-2. Discriminators of depression from medical illness, guilt and self-reproach, psychomotor retardation, recurrent suicidal thoughts, difficulty concentrating, confusion, forgetfulness, social withdrawal, isolation, increased irritability, problematic anger, increased relationship disruption, disturbances, anhedonia, preoccupation with, or obsessive, negative thoughts, anxiety, panic attacks, newly emergent phobias. Table 15-3. Assessment Guide for Major Depression in Cancer Patients, Risk Factors, Precipitants, History, Past/Present, Stress from Affective Disorder, Symptoms, Meaning of Cancer, Sad Facial Expression/Mood, Chemical Dependency, Unmet Needs, Decreased Interest in Self, Physical Abuse/Self-Injury, Pain/Symptom Distress, Anhedonia, Poor Control of Pain/Symptoms, Anxiety/Fears, Social Withdrawal, Advanced Stages of Cancer, Financial Concern, Somatic Symptoms, Anorexia, Insomnia, Fatigue, Medications with depressive side effects, automatic negative thinking, inadequate social supports, drugs causing depression, impaired body image, slow thought, concentration, thoughts of suicide, changed work/family roles. Source: Valenti S.M., Saunders J.M., Cohen M.Z., Evaluating Depression Among Patients with Cancers. Cancer Practice 2:65, 71, 1994. Reprinted with permission. Most commonly used antidepressants for cancer patients at present are selective serotonin reuptake inhibitors, example fluoxetine, sertraline, paroxetine, fluvoxamine, which have fewer side effects, lower cardiac risks, hypertension, and anticholinergic effects than do the tricyclic antidepressants. Newer anti-322 Psychological Aspects of Women's Healthcare, 2nd edition, Table 15-4. Medications commonly used to treat depression. Medications: dosages, start dose/primary side effects and daily dose. MG comments: tricyclic antidepressants, TCAS. All TCAS may cause cardiac arrhythmias. Blood levels are available for all but doxepin. Get baseline EKG. Amitriptyline, Elabel, 10, 25/50, 100 sedation, anticholinergic, orthostasis. Imipramine, Tofranil, 10, 25/50, 150 intermediate sedation, anticholinergic, orthostasis. Desipramine, Norpramin, 25/75, 150 little sedation or orthostasis, moderate anticholinergic. Nortriptyline, Pamelor, 10, 25/75, 150 little anticholinergic or orthostasis, intermediate sedation, therapeutic window. Doxepin, Synquan, 25/75, 150 very sedating, orthostatic, intermediate anticholinergic, potent antihistamine. Amoxapine, Ascendin, 25/100, 150 sedation, risk of tardive dyskinesia, extrapyramidal side effects. Maprotilene, Ludiomil, 25/50, 75 moderate sedation, risk of seizures. Bupropion, Wellbutrin, 15/200, 450 may cause seizures in those with low threshold, initially activating. Trazodone, Decyral, 50/150, 200 sedating, not anticholinergic. 20/20, 60 headache, nausea, anxiety, insomnia, very long half-life, maybe even longer in debilitated patients. Heterocyclic 2nd generation. Antidepressants: selective serotonin reuptake inhibitors. Serotonin reuptake inhibitors have no anticholinergic or cardiovascular side effects. Fluoxetine, Prozac, sertraline, Zoloft, 50/50, 150 nausea, insomnia, diarrhea. Paroxetine, Paxil, 20/20, 60 nausea, somnolence, asthenia, muscle spasm. Gynecologic Oncology 323 Table 15-4.
Medications commonly used to treat depression. Continued. Medications dosages: start dose/primary side effects and daily dose. MG comments: psychostimulants should be given in 2 divided doses at 8 a.m. and noon, can be used as antidepressant, analgesic adjuvant, and to counter sedation of opiates may cause nightmares, insomnia, psychosis, anorexia, agitation, restlessness. Diamphetamine, dexedrine, 2.5/5, 30 methylphenidate, Ritalin, 2.5/5, 30 Pemeline, Cillard, 18.75/37.5, 150. Follow liver tests. Monoamine oxidase inhibitors, MAOIs. MAOIs are orthostatic, risk of hypertensive crisis, strict dietary and medication restrictions, should never be used with meperidine isocarboxazid, Marplan, 10/20, 40 hypertensive/hypotensive phenelzyme, Nardile, 15/30, 60 drug/diet interactions. Tranasipromin, Parnate, 10/20, 40 source. Roth A.J., Holland J.C., Treatment of Depression in Cancer Patients. Primary Care and Cancer 14:23, 29, 1994. Reprinted with permission of Primary Care and Cancer, Melville, New York. Depressants such as nefazodone, Sursone, and bupropion, Wellbutrin, promise relief for depression without sexual side effects. Psychostimulants, example methylphenidate, are being used increasingly to treat depression in cancer patients, especially those suffering from depressed mood, apathy, low energy, poor concentration, and weakness. In small doses they are helpful in countering the effects of morphine, and response is more rapid than that for tricyclic antidepressants. Finally, psychopharmacology with cancer patients requires alertness for interaction with other medications, chemotherapy, and medical conditions. See Table 15-4. Anxiety and panic disorders. Anxiety is ubiquitous in cancer patients, typically occurring at turning points of illness such as diagnosis, recurrence, treatment failure, and even at term. 324 Psychological Aspects of Women's Healthcare, 2nd edition. Nation of Successful Curative Treatment when patients fear the loss of close monitoring or the supportive relationships of medical staff. Anxiety can also be situational, secondary to pain, underlying medical conditions, hormone-secreting tumors, medications, treatment, example hospitalization, needles, or as a side effect of medications. Massey, 1989a. The most common pre-existing chronic anxieties, predating cancer diagnosis, are phobias, example claustrophobia, and panic disorders, although anxiety disorders such as generalized anxiety disorder and post-traumatic stress disorder are often activated by cancer or its treatment. Anxiety is often complicated by pain, nausea, and depression. Evaluation of the cause of anxiety may lead to immediate control of symptoms, with the long-term outcome dependent on etiology. Psychotherapy, medication, and behavioral interventions are usually effective in the short term, but are least effective in the management of long-standing anxiety disorders. Anxiolytic or antidepressant medications are often effective. Self-regulatory therapies, example hypnosis, meditation, biofeedback, progressive relaxation, guided imagery, and cognitive behavioral techniques, have also been effective with anxiety disorders. Nausea, vomiting, and pain symptoms such as nausea, vomiting, and anticipatory nausea may develop either before or during chemotherapy. Patients differ in how prone they are to nausea and vomiting depending on their neurologic makeup and their anxiety level. Some chemotherapeutic medications are more likely to cause nausea than others. Approximately 45% of cancer patients experience nausea, vomiting, or both within the 24 hours before chemotherapy. These symptoms appear to be caused by the interplay of associative learning and the stress associated with chemotherapy. Cancer pain regrettably continues to be undertreated, and severe pain is experienced in 60%, 90% of patients with advanced cancer. Poorly controlled pain results in heightened levels of anxiety and depression. Despite patient beliefs or myths, Cancer patients rarely abuse pain medications or become addicted to them. Psychologic techniques such as hypnosis, relaxation training, biofeedback, distraction, guided imagery, acupuncture, acupressure, massage therapy, biofeedback, and sensation redefinition may assist in pain control. Antidepressant medications are often used successfully as an additional pain management technique. Mastrovito 1989. Gynecologic Oncology 325 Psychologic treatment. The first psychiatric group in the United States devoted to the study of the psychosocial consequences of cancer and surgical treatment was established by Sutherland in 1950, Holland 1989. The emerging field of psycho-oncology has two dimensions: 1. The impact of cancer on the psychologic function of the patient's family and staff, and 2. The role that psychologic and behavioral variables may have in cancer risk and survival, Holland 1989. Care of cancer patients increasingly involves a team of professionals specializing in oncology, including psychoncologists, psychiatrists, psychologists, social workers, and psychiatric nurses with special interest and/or training in the psychologic aspects of cancer and its treatment. Psychoncologists are familiar with cancer diagnosis, prognosis, and treatment, the psychosocial issues of cancer for the patient and her family, and their own personal responses to patients who have a life-threatening illness. Consultation liaison psychiatry developed in the early 1970s when psychiatrists, acting as hospital consultants for inpatients, expanded their responsibilities to include a liaison role. They conducted multidisciplinary teaching rounds and groups that focused on psychologic and behavioral problems, ethical dilemmas, and conflicts between patients and staff and among staff members. Artis and Levine 1973. Psychiatrists, as psychoncologists, provide consultation liaison services as well as outpatient psychopharmacologic care and psychotherapy. Multidisciplinary teams including social workers, psychologists, specially trained nurses, and clergy may offer support groups for patients and their families as well as individual patient care. Components of effective interventions include an emotionally supportive context in which to address fears about the disease, information about the disease and its treatment, behavioral and cognitive coping strategies, relaxation training to lower arousal and enhance sense of control, focused interventions for disease-specific problems, and social support. Anderson 1997. 5 patterns of coping with cancer were identified by Dunkelskeder et al. 1992. 1. Seeking or using social support. 2. Focusing on the positive. 3. Distancing. 4. Cognitive escape avoidance. And 5. Behavioral escape avoidance. They found that women with cancer use a large repertoire of behaviors to cope flexibly rather than rigidly adhering to a particular coping style, with distancing being the most commonly used pattern. The goals of psychotherapy are to help the patient regain a sense of self-worth, to correct misconceptions, to integrate the present illness into a continuum of life experiences, and to provide practical help in managing. Treat 326 Psychological Aspects of Women's Health Care. 2nd edition. Meant side effects, Roth and Holland 1994. Psychotherapy emphasizes past strengths, supports previously successful ways of coping, and mobilizes inner resources. The length of therapy must be tailored to the patient to reduce symptoms to a tolerable level. In addition, family members may be helpful as part of the therapy, or group attendance may be beneficial. Adjuvant psychologic therapy emphasizes fostering a positive attitude, helping the patient adhere and cope with treatment, and reducing emotional distress. Morey and Greer 1989. It is a cognitive behavioral therapy based on the cognitive model of adjustment to cancer in which appraisals, interpretations, and evaluations that the individual makes about cancer determine her behavioral reactions. Therapy involves mobilizing coping behaviors, fighting spirit, denial, fatalism, helplessness/hopelessness, anxious preoccupation, and finding problem-oriented solutions. The problems encountered may be emotional, example depression, interpersonal, example problems communicating with spouse, or related to the cancer type, example body image problems of vulvar cancer patients. Self-help and mutual support programs date from the 1940s, when the American Cancer Society began its volunteer visitor programs offering practical help for patients at home, Mastrovito et al. 1989. These visitor programs offer a dimension of help beyond the scope of professional practitioners. Support volunteers, example Gilda's Club, typically have personal experience with cancer, good communication skills, emotional stability, the ability to model good coping skills, sensitivity, empathy, and good listening skills. Alternative or complementary cancer therapies are increasingly being used, although safety and efficacy standards have not been developed in these products or approaches. Castellet et al. 1984, reported the 6 most widely used alternative therapies today to be metabolic therapy, diet treatments, megavitamins, mental imagery approaches, spiritual or faith healing, and immunotherapy. Patients also report the use of homeopathic therapies, massage, tai chi, acupuncture, acupressure, nutrition, and herbal therapies. These treatments may have direct effects, placebo effects, side effects, and or potential drug interactions. When taking a patient's history and developing a treatment plan, it is important to consider any alternative treatments the patient may be using, example St. John's wort. Conclusion: for women of all ages, gynecologic cancers are responsible for a significant amount of mortality and morbidity, including physical suffering and psychogynecologic oncology. 327 Social distress. Adding to the distress for women are the high degree of uncertainty of the illness, its prognosis, and its treatment, as well as the lack of social awareness or community support. Breast cancer often steals the limelight of women's cancer. Gynecologic cancers often linger in the shadows, receiving much less attention, funding, support, or consumer education. Yet the toll of gynecologic cancers on the reproductive, sexual, and psychologic lives of women, both young and old, is profound. Therefore, it is important that caregivers be cognizant of the complex lives women live, the unique and powerful meanings of their reproductive organs, the potentially devastating impact of gynecologic cancer and its treatment on their physical and psychological health and well-being, and the social costs in their lives. The grief expressed by women with gynecologic cancer is not simply for the loss of good health, it is also for the loss of the parts of themselves that some feel make them uniquely women. References: Anderson B. L., DeProssi C., Controlled Prospective Longitudinal Study of Women with Cancer, I. Sexual Functioning Outcomes. J. Consult ClinPsychol 57:683, 691, 1989. Anderson B. L., DeProssi C., Controlled Prospective Longitudinal Study of Women with Cancer, 2. Psychological Outcomes. J. Consult ClinPsychol 57:692, 697, 1989. B. Anderson B. L., Psychological Interventions for Individuals with Cancer. Clinicians Research Digest Supplemental Bulletin, Vol. 16, 1997. Artis Lake Lavine, American Samoa, Dr., Patient Relation in Severe Illness, a Seminar for Oncology Fellows. An English J. Med 288:1210, 1214, 1973. Bachman G.A., Psychosexual Aspects of Hysterectomy. The Jacobs Institute of Women's Health. 1:41, 49, 1990. Brown D., Roberts J.A., Elkins T.E., et al., Hard Choices, The Gynecologic Cancer Patient's End-of-Life Preference. Gynecol Uncle 55:355, 362, 1994. Buchberg J.D., Penman D., Holland J.C., Depression in Hospitalized Cancer Patients. Psychosome Med 46:199, 212, 1984. Castellet B., Lusky J., Strauss B.A., et al., Contemporary Unorthodox Treatments in Cancer Medicine. An Intern Med 101:105, 112, 1984. Cicciarelli V.G., Relationship of Psychosocial and Background Variables to Older Adults' End-of-Life Decisions. Psychol Aging 12:72,
83, 1997 Derogatis L.R., Morrow G.R., Fedig J., et al., The Prevalence of Psychiatric Disorders Among Cancer Patients. JAMA 249:751, 757, 1983 Dunkel-Sketter C., Feinstein L.G., Taylor S.E., et al., Patterns of Coping with Cancer. Health Psychol 11:79, 87, 1992 328 Psychological Aspects of Women's Healthcare, 2nd edition Erickson A., Childhood and Society, 2nd edition. New York, Norton, 1963 Hilton B.A., Alfred H., Children's Experiences with Mother's Early Breast Cancer. Cancer Pract 4:96, 104, 1996 Holland J.C., Historical Overview, in Handbook of Psycho-Oncology. Edited by Holland J.C., Roland J.H. New York, Oxford, 1989, pp. 3-12 Janoff Bowman R., Shattered Assumptions, Toward a New Psychology of Trauma. New York, Free Press, 1992 Crum S., Lombardi J., Changes in Sexual Behavior Following Radiation Therapy for Cervical Cancer. J. Psychosome Obstet Gynecol 14:51, 63, 1993 Lalasse, Jacobson L., Lalasso, et al., Experiences of the Male Partner in Cervical and Endometrial Cancer, a Prospective Interview Study. J. Psychosome Obstet Gynecol 16:153, 166, 1995 Levinson D.J., A Conception of Adult Development. American Psychologist 41:3, 13, 1986 Massey M.J., Anxiety, Panic, and Phobias, in Handbook of Psycho-Oncology. Edited by Holland J.C., Roland J.H. New York, Oxford, 1989a, pp. 300-309 Massey M.J., Depression, in Handbook of Psycho-Oncology. Edited by Holland J.C., Roland J.H. New York, Oxford, 1989b, pp. 283-290 Massey M.J., Holland J.C., Overview of Normal Reactions and Prevalence of Psychiatric Disorders, in Handbook of Psycho-Oncology. Edited by Holland J.C., Roland J.H. New York, Oxford, 1989, pp. 273-282 Mastrovito R., Behavioral Techniques, Progressive Relaxation and Self-Regulatory Therapies, in Handbook of Psycho-Oncology. Edited by Holland J.C., Roland J.H. New York, Oxford, 1989, pp. 492-501 Mastrovito R., Moynihan R., Pars on Net L., Self-Help and Mutual Support Programs, in Handbook of Psycho-Oncology. Edited by Holland J.C., Roland J.H. New York, Oxford, 1989, p. 502-507 McCoy D.M., Treatment Considerations for Depression in Patients with Significant Medical Morbidity. JFAM Pract 43 S35, S44, 1996 Maury S., Greer S., Psychological Therapy for Patients with Cancer, A New Approach. Washington, D.C., American Psychiatric Institute, 1989 Newsom J.T., Knapp J.E., Schultz R., Longitudinal Analysis of Specific Domains of Internal Control and Depressive Symptoms in Patients with Recurrent Cancer. Health Psychol 15:323, 331, 1996 Parker S.L., Tony T., Boulder S., et al., Cancer Statistics, 1997. C.A. Cancer J. Clin 47:5, 27, 1997 Petzel S.V., Burns L.H., Hamble, et al., Self-Management, Psychological Adjustment and Coping During Treatment for Ovarian Cancer, A Feasibility and Adherence Study. Submitted for publication, 1997 Roth A.J., Holland J.C., Treatment of Depression in Cancer Patients. Primary Care and Cancer 14:23, 29, 1994 Gynecologic Oncology 329 Roland J.H., Developmental Stage and Adaptation, Adult Model, in Handbook of Psycho-Oncology. Edited by Holland J.C., Roland J.H. New York, Oxford, 1989, pp 25-43. Sabo D., Brown J., Smith C., The Male Role and Mastectomy, Support Groups and Men's Adjustment. J. Psychosoc Uncle 4:19, 31, 1986. Cover L.R., Sexuality and Fertility After Cancer. New York, John Wiley and Sons, 1997. Thronovi, Clay M., Sexuality Among Gynecologic Cancer Patients, a Cross-Sectional Study. Gynecol Uncle 52:10, 13, 1994. Trill M.D., Holland J.C., Cross-Cultural Differences in the Care of Patients with Cancer, a Review. Gen Hosp Psychiatry 15:21, 30, 1993. Valenti S.M., Saunders J.M., Cohen M.Z., Evaluating Depression Among Patients with Cancer. Cancer Practice 2:65, 71, 1994. This page intentionally left blank. 16 Women and HIV Infection. Jan Moore, Ph.D. Don K. Smith, M.D., M.S., M.Ph. Epidemiology of HIV/AIDS in Women. Global HIV/AIDS Epidemiology. The World Health Organization, 1998, estimated that of the 5.2 million adults, age 15 years, infected with HIV in 1998 worldwide, 40% were women. Of the 32.2 million adults living with HIV/AIDS, 43% were women. Women as a proportion of new HIV infections in 1998 ranged from 5% in Australia and New Zealand to 50% in sub-Saharan Africa, with other regions in the 15%, 35% range. More than 95% of HIV-infected people live in the developing world. Sub-Saharan Africa, which contains only 10% of the world's population, was home to 70% of those infected in 1998 and the site of 80% of HIV/AIDS deaths that year. In 1998, AIDS was responsible for an estimated 2 million deaths, 5,500 funerals a day. An estimated 1/7 HIV infections in sub-Saharan Africa and 1/10 infections worldwide occurred in 1998 alone. Half of these African infections occurred in women. In India, HIV infection rates among antenatal women are greater than 1% in urban areas of at least 5 states and 13.6% among women in Pune with sexually transmitted diseases, STDs, who reported that their only risk factor was sex with their husbands. In most regions of the world, it is estimated that more than 90% of HIV infections among women are acquired heterosexually, often from husbands. 332 Psychological Aspects of Women's Healthcare, 2nd edition, or regular sex partners. An additional contributor in some regions, example Africa, Asia, is unsafe blood transfusion, which is of particular concern for women in association with pregnancy and childbirth. In North America and Europe, intravenous drug use contributes significantly to the HIV epidemic in women. Although less than 1% of new infections globally in 1998 occurred in the United States, most of our data about disease trends, manifestations, and progression in women come from the United States and, to a lesser extent, Europe. AIDS case surveillance. In the United States, reported AIDS cases are the most commonly used measure of the HIV/AIDS epidemic in the United States. Through December 1997, 98,468 cases of AIDS in women had been reported to the Centers for Disease Control and Prevention. 15% of all persons ever reported with AIDS in the United States, Centers for Disease Control and Prevention. 1997b. In 1997 alone, 13,105 cases of AIDS in women were reported, accounting for 22% of the AIDS cases reported that year. In 1997, most of the women reported to have AIDS were Black, 60%, or Hispanic, 20%. Centers for Disease Control and Prevention. 1997b. Compared with the 1997 AIDS incidence rate per 100,000 population for white women, the rate for black women was nearly 13 times higher and that for Hispanic women was 7 times higher. Table 16, 1a. HIV case surveillance in the United States. 3 factors have led to a decreased ability to rely on reported AIDS cases as a primary indicator of the size and trends in the epidemic of HIV infection. First, the time from HIV infection to the development of AIDS can extend for 10 years or longer, so that even accurate AIDS surveillance does not give a timely indication of trends in HIV infection. Second, because of the recent availability and increasing use of highly active antiretroviral therapy and prophylaxis for opportunistic infections, which delay the onset of AIDS in many HIV-infected people, reported AIDS cases are now declining while the numbers of HIV-infected people living without having developed AIDS are increasing. Centers for Disease Control and Prevention 1997d. Last, these same medical therapies are reducing mortality among people with AIDS, thus increasing the number of people living with AIDS. The combination of Table 16, 1a. Female adult/adolescent AIDS cases reported in the United States in 1997 of Black, N%, Hispanic, N%, White, N%, Asian/Pacific Islander, N%, American Indian/Alaska Native, N%. Intravenous drug use 2,511, 32, 750, 29, 907, 36, 11, 17, 14, 39, heterosexual 2,790, 35, 1,174, 46, 991, 40, 30, 47, 13, 36, blood product 122, 2, 31, 1, 41, 2, 5, 8, 2, 6, 2,457, 31, 623, 24, 546, 22, 18, 28, 7, 19, total number 7,880, 2,578, 2,485, 64, 36 rate/100,000, 38.8, 21.33.01.54.7b. No identified risk reported. A women and HIV infection table excludes 133 women with unknown race/ethnicity. At time of AIDS case report. B. 333 334 Psychological Aspects of Women's Healthcare, 2nd edition. These factors means that reported AIDS cases no longer provide a representative picture of the HIV epidemic. For these reasons, the Centers for Disease Control and Prevention has recommended that all states develop routine, confidential HIV surveillance systems to more accurately measure the epidemic. Annual data for 1997 were reported for the 27 states that have surveillance for HIV among adults, Table 16, 1b, but the reporting states do not include several states with high rates of infection among women, e.g., New York, so the data are not yet nationally representative. In the 27 states that had integrated HIV and AIDS surveillance from January 1994 through June 1997, the number of people reported with HIV infection, not AIDS, was compared with the number first reported after they had already developed AIDS. Of people in whom HIV infection was the initial diagnosis, 28% were women, compared with 17% of AIDS diagnoses, 57% were Black, compared with 45% of AIDS diagnoses, and 32% were aged 13 to 29, compared with 14% of AIDS diagnoses. Of HIV diagnoses among people aged 13 to 24 years, 44% were women and 63% were Black. These data strongly suggest that young women, especially Black women, are continuing to be infected with HIV at high rates. Centers for Disease Control and Prevention 1998b. Modes of exposure to HIV for women in the United States in 1997, 32% of women reported with AIDS had a history of intravenous drug use and were assumed to have become infected with HIV through this route. See Table 16, 1a, Centers for Disease Control and Prevention 1997b. Heterosexual contact accounted for 38% of AIDS cases in women, this proportion having steadily increased from approximately 15% in 1983. The number of women infected with HIV through heterosexual contact may be underestimated. Women who inject drugs frequently have male sex partners who also inject drugs or have other risk factors, therefore, these women may have become infected with HIV through sexual contact. Additionally, approximately 28% of women who have AIDS report that they have none of the established risk factors. At least a portion of these cases includes women who were heterosexually infected by partners whose HIV status or risk history was unknown to the woman, including sexual contact with a bisexual male. Women who have multiple sex partners are at increased risk for HIV because their chance of encountering an HIV-infected partner is greater than Table 16, 1b. Female adult/adolescent HIV, not AIDS, cases reported in the United States in 1997 of Black, N%, Hispanic, N%, White, N%, Asian/Pacific Islander, N%, American Indian/Alaskan Native, N%. Intravenous drug use 386, 13, 57, 19, 204, 21, 1, 7, 9, 43, heterosexual 992, 33, 112, 37, 375, 39, 4, 29, 5, 24, 23, 1, 2, 1, 13, 1, 0, 0, 0, 0, 1615, 54, 134, 44, 362, 38, 9, 64, 7, 33, 3016 305 954 1421 Blood product B. No identified risk reported. Total number from 27 states that reported HIV cases among adults in 1997. Table excludes 269 women with unknown race/ethnicity. At time of AIDS case report. B. Women and HIV infection 335 336 Psychological aspects of women's health care, 2nd edition. That for women with fewer partners. These women are also at increased risk for acquiring other STDs that may facilitate HIV transmission, thus contributing to a higher incidence of HIV infection. Holmberg et al. 1989, Royce et al. 1997. Finally, although recent data suggests some leveling, the National Survey of Family Growth has shown that first sexual experiences are occurring at younger ages. Centers for Disease Control 1991. The literature suggests that women who begin sexual intercourse at a young age are more likely to have multiple partners and thus to be at greater risk for HIV infection than are women who delay intercourse. Greenberg et al. 1992. These factors may contribute to a significant increase in the still small number of AIDS cases among adolescent and young adult women, the latter of whom may presumably have been infected as adolescents. Transfusion recipients and recipients of other blood products now account for a small and declining percent of women with AIDS, 4%. Virtually all new cases of transfusion-related AIDS are associated with the receipt of blood before 1985, i.e., before HIV antibody screening of blood donations was implemented. Ward et al. 1988. Female-to-female sexual transmission of HIV has been of interest and concern to healthcare providers and HIV-infected women. 3 cases of female-to-female transmission have been reported in the medical literature: Marmer et al. 1986, Monson and Capelin 1987, Perry et al. 1989. However, a review of AIDS cases in 164 women who reported having sex only with other women revealed that in all cases another risk factor was present. 93% of the women had a history of intravenous drug use and 7% had a history of blood transfusion before March 1985, Chu et al. 1992. None of these cases was attributable to female-to-female sexual transmission. HIV/AIDS mortality in the United States. Mortality rates clearly demonstrate the severe impact of AIDS on women, particularly black women. As early as 1990, AIDS and HIV-related diseases were the sixth leading cause of death among women aged 25 to 44 years in the United States, Centers for Disease Control and Prevention 1993b, and the leading cause of death among black women of this age group. In 1996, HIV/AIDS was the fourth leading cause of death among all women aged 15 to 44 and continued to be the leading cause of death among black women, figure 16:1. Women and HIV infection 337, figure 16:1. A. Death rates among all women ages 25 to 44 years, 1982 to 1996. B. Death rates among African American women ages 25 to 44 years, 1982 to 1996. 338 Psychological Aspects of Women's Healthcare, 2nd edition. Manifestations of HIV infection in women. The first case of AIDS in a woman in the United States was reported in August 1981, Centers for Disease Control 1981, and the first description of the clinical and epidemiologic characteristics of women with AIDS appeared in May 1982, Masser et al. 1982. However, because of the early severe impact of the epidemic on homosexual/bisexual male communities, almost all early studies of the natural history of HIV infection were conducted in cohorts of white homosexual men living in AIDS epidemic centers such as New York and San Francisco. Studies of blood transfusion recipients and intravenous drug users have included women but not in sufficient numbers to definitively examine gender differences in HIV disease progression. In recent years, several studies have followed up with groups of women over varied periods of time and have attempted to describe aspects of the course and clinical manifestations of HIV infection in women, including two large prospective cohort studies of women with HIV infection and behaviorally matched, uninfected women, Barkan et al. 1998, Smith et al. 1997. Except for gynecologic findings and mental health, these studies have shown few gender-based differences in HIV disease manifestations and disease progression. Recent findings suggest that the clinical implications of viral load may differ by gender, Farzad Egan et al. 1998, Sterling et al. 1998, but confirmatory studies are not yet completed. Non-AIDS defining conditions following the occurrence of acute antiretroviral illness in some patients at the time of HIV infection, Flanagan et al. 1992, Kinloch-Delos et al. 1993, Shacker et al. 1998, Tyndall and Cooper 1991. A long period of asymptomatic HIV infection occurs during which HIV establishes a chronic infection, primarily involving lymph nodes. Over several years, untreated HIV infection leads to the gradual impairment of the immune system by several mechanisms, eventually leaving the infected person susceptible to the many opportunistic infections and malignancies that define AIDS. The hallmark of HIV disease progression, a decline over time in CD4+ T lymphocytes, has been prospectively studied in a few cohorts of women and heterosexual men. These studies have suggested no substantial difference between HIV-infected men and women in immunologic decline, Chasen et al. 1992, Selwyn et al. 1992. Because women experience a mild form of immunosuppression during pregnancy, including a decline in CD4+ T lymphocytes, women and HIV infection 339, Bigger et al. 1989, the effect of pregnancy on disease progression in women was a matter of concern at first. However, larger prospective controlled studies have shown no increase in disease progression associated with pregnancy, suggesting that pregnancy has little or no independent effect on the progression of HIV disease. Bredel and Lean 1991, Desha et al. 1993. Several studies report that the prevalence and persistence of human papillomavirus infection are higher in HIV-infected women than in uninfected women and are strongly associated with the development of cervical dysplasia, the precursor to invasive cervical cancer, Feingold et al. 1990, Wright and Son 1996. Other studies of HIV-infected women have shown an association between immunosuppression and severe grades of dysplasia on Pap smear or cervical biopsy results, Mayman et al. 1991, Schaefer et al. 1991. In addition, studies of treated cervical dysplasia suggest that HIV-infected immunosuppressed women have high rates of recurrence or persistence of dysplasia after receiving standard therapies, Fröchter et al. 1996, Mayman et al. 1990. AIDS-defining conditions. The occurrence of AIDS-defining conditions differs somewhat for men and women, but the available data suggest more similarities than differences. A recent analysis of gender differences among AIDS cases diagnosed from 1988 through mid-1991 indicated similar prevalence for most, but not all, AIDS-defining conditions when differences in race/ethnicity and the mode of transmission were controlled. In a comparison of 7,183 female and 21,776 male intravenous drug users, only esophageal candidiasis, herpes simplex virus, HSV, and cytomegalovirus were significantly more frequent among women than among men, whereas toxoplasmosis, cryptococcosis, histoplasmosis, Kaposi sarcoma, and lymphomas were significantly less common in women. Fleming et al. 1993. Few studies have been published about the causes of death among HIV-infected women, either alone or in comparison with those of HIV-infected men. Among women in the United States aged 15 to 44 years who died in 1987 and whose death certificates mention HIV/AIDS, the leading causes of death were drug abuse, 26.5%, followed by pneumocystis carinii pneumonia, 19.7%, other pneumonia, 14.1%, and septicemia, 9.8%. Chu et al. 1990. HIV/AIDS manifestations in developing countries. Few studies have examined the manifestations and progression of HIV disease in representative cohorts of women in developing countries. The limited 340 psychological aspects of women's health care, second edition data available suggest no significant differences in survival rates of women compared with men, Morgan et al. 1997a, but suggests survival rates for adults of both genders may be half that of adults in developed countries, Mockroft et al. 1996, Todd et al. 1997. Similarly, time to AIDS appears shorter in developing countries, Anzala et al. 1995, Morgan et al. 1997b. Studies have not rigorously examined potential gender differences in the manifestations of HIV disease in these populations, but all gender-specific conditions described in North American and European women, example HPV infection/cervical dysplasia, vaginal candidiasis, pelvic inflammatory disease, have also been found in women in developing countries. Healthcare issues for women with HIV infection critical to optimal medical, psychologic, and social service care for women are 1. The early diagnosis of HIV infection, 2. The provision of education both about HIV disease and the importance of early care, and 3. Access to and adherence support for the use of highly active antiretroviral therapy and prophylaxis for opportunistic infections. Accumulating evidence indicates that many opportunities for identifying women with HIV infection are missed, Bokalu et al. 1993, Schoenbaum and Weber 1993. Standard recommendations for HIV testing rely largely on the patient's history of behaviors associated with the risk of HIV infection. However, standard risk history questions failed to identify most asymptomatic HIV-infected women in studies in which results from blinded testing are available. Providers are often reluctant to ask sensitive questions about sexual and drug use behaviors, and women are frequently unwilling to disclose such behaviors to providers whom they do not know or trust. Bokalu et al. 1993, Centers for Disease Control and Prevention 1994, Schoenbaum and Weber 1993. In addition, women may be unaware of behaviors of their sexual partners that place them at risk of heterosexual transmission, Dahl et al. 1991. HIV infections in pregnancy. Recent medical advances in the ability to reduce HIV transmission from mother to infant have increased the emphasis on routine HIV counseling and testing of pregnant women. The Public Health Service issued recommendations in 1995 that all pregnant women be counseled and offered voluntary women and HIV infection 341 HIV testing in prenatal settings, Centers for Disease Control and Prevention 1995. Early data suggest that most women in prenatal care in the United States are being offered HIV testing, Royce et al. 1998, and that approximately 80% accept, Fernandez et al. 1998, Royce et al. 1998. Surveillance data on HIV-infected pregnant women indicate that about 80% know their HIV status by the time of delivery, Wordley et al. 1998. Interventions to overcome barriers to prenatal HIV testing, example lack of prenatal care, misperceptions of no risk for HIV by women and their health care providers, and logistical problems related to getting a test, are being planned and are expected to result in even higher rates of testing. Widespread HIV testing of pregnant women is hoped to not only decrease rates of perinatal transmission but also to ensure that HIV in women is diagnosed and treated earlier in the course of the disease. Treatment of HIV infection in women. After HIV infection is diagnosed, several conditions must exist for women to receive appropriate treatment for the infection and its related conditions. 1. Providers of high-quality healthcare services must be available. 2. Women must have financial access to these services. And 3. These women must use accessible services and adhere to recommended follow-up and therapy. Healthcare professionals experienced both in women's healthcare and HIV-related treatment are not easily found. For example, providers may be very knowledgeable about the treatment of HIV, but because of their inexperience with socioeconomically disadvantaged women, they alter treatment decisions based on expectations derived from the socio-demographic rather than the clinical characteristics of their patients. Centers for Disease Control and Prevention 1994, Stein et al. 1991. Providers experienced in women's health care frequently are not familiar with HIV-related treatment issues and so may not prescribe the most effective antiretroviral or prophylaxis therapies. Bokalu et al. 1993. This situation is especially worrisome because mortality rates of patients with AIDS appear to be related to the level of experience of medical personnel in the treatment of AIDS. Stone et al. 1992. Treatment of HIV infection in women is not gender-specific, and published guidelines for the content and periodicity of physical and laboratory examinations, vaccinations, and the selection of appropriate drug therapies should be followed. Centers for Disease Control and Prevention 1997A, 1997E, 1998E, 1998F. Recommendations for screening and treatment of gynecologic and obstetric conditions in HIV-infected women are also available. 342 Psychological Aspects of Women's Healthcare, 2nd edition, Centers for Disease Control and Prevention 1997A, 1998C, 1998F. Recent advances in the use of potent antiretroviral combination therapies have provided unprecedented delays in the progression of HIV disease. Collier et al. 1996, Deeks et al. 1997, Palala et al. 1998. To achieve this benefit, however, patients must adhere to complex drug regimens. Non-adherence to antiretroviral therapy may result not only in treatment ineffectiveness but also in the development of drug-resistant HIV strains. Particular concern has been raised about non-adherence by HIV-infected persons living in disadvantaged situations. Data collected on poor, inner-city, HIV-infected women indicate that they are less likely to be taking antiretroviral medication than are infected men. Solomon et al. 1998. It is unclear, however, how much of this gender difference can be attributed to the unwillingness of health providers to prescribe state-of-the-art drugs to disadvantaged persons, some of whom use illicit drugs, and how much can be attributed to women's failure to fill prescriptions and adhere to prescribed treatments. All patients, regardless of gender, race/ethnicity, or income have reported difficulty in following the current recommended regimens for HIV treatment, Kramer and Matson 1991, Epstein and Kluss 1982, Glasgow 1991. HIV-infected women who have many competing life stresses are likely to have great difficulty maintaining drug regimens. They may need assistance in working out a realistic schedule for taking medications and in developing support networks to assist them in maintaining highly complex treatment regimens. Without these supportive services, women may be unable to fully benefit from available medical advances in treatment. Principles of care in developing countries. Widespread availability of affordable HIV testing is not found in most developing countries, thus, identifying HIV infection in women prior to serious illness is uncommon. With increasing availability of inexpensive rapid testing technologies and the dissemination of HIV test counseling protocols appropriate to these settings, it is anticipated that greater numbers of women, and their male partners, will learn their HIV status in a timely fashion. Because long-term use of antiretroviral medications is not logistically or financially feasible in most developing countries, treatment issues are focused on prevention, early identification, and treatment of opportunistic or comorbid infections, especially tuberculosis, bacteremia, and diarrheal disease. DeCock et al. 1993, Grant et al. 1997, Lucas et al. 1993. In addition, recent documentation of the effectiveness of short, relatively inexpensive courses of antiretro women and HIV infection 343 viral treatment in late pregnancy for reducing perinatal transmission, Centers for Disease Control and Prevention 1998a, is anticipated to increase access to HIV testing for women and thus their use of the prevention and treatment therapies available to them. Psychosocial issues and HIV infection among women in the United States. Although all serious, debilitating illnesses have been shown to affect psychologic and social functioning, Anderson et al. 1989, Mann and Zautre 1990, Revenson and Felton 1989, HIV infection may have a greater impact than most medical conditions. The stigma associated with the disease and the activities related to its acquisition, example illicit drug use, sexual behavior, the potential for discrimination against oneself and one's family, and the greater likelihood that members of one's family or social circle are also infected present unique psychologic and social challenges for HIV-infected people. Most research on the psychosocial effects of HIV has been conducted with gay men, the population initially most affected by the AIDS epidemic. Gay men affected by HIV in the early phase of the epidemic, however, tended to be white, well-educated, and to have substantial financial and social resources. Because the epidemic has moved to intravenous drug users and women, the socio-economic face of the epidemic has changed dramatically. Centers for Disease Control and Prevention 1993a, 1995, those most affected by the second wave of the epidemic have been poor and from racial/ethnic minority groups. Poor, urban, minority women, a group already experiencing myriad stressful life events, elevated psychologic distress, and few social and economic resources, have been hit particularly hard by HIV and AIDS. Because of the vulnerability of this group, particular concerns have been raised about many women's ability to cope with the added stress of living with HIV infection or the prospect of becoming infected. In this section of the chapter, we review the limited literature available on the psychologic and social issues for women related to getting an HIV test, receiving test results, adjusting to a positive diagnosis, and living with HIV infection. Issues that present particular challenges to HIV-infected women compared with infected men are addressed, including 1. Confronting one's risk for HIV, 2. Disclosing HIV status to sex partners, other adults, and children, 3. Changing sexual behavior, 4. Making reproductive decisions, and 5. Making plans for the future. 344 Psychological Aspects of Women's Healthcare, 2nd edition. HIV antibody testing. Non-pregnant women typically are not offered HIV testing unless they present to the medical system with HIV-related symptoms. Studies have shown that approximately one-half of HIV-infected women are not diagnosed until they enter the healthcare system with HIV-related symptoms or an AIDS-defining illness. Beaver and Catalan 1993. Women, non-whites, and people at heterosexual risk are likely to be detected later in their course of disease than are men, whites, drug users, and gay men. Sorvolo et al. 1998. A primary reason women are not tested earlier is that their risk for HIV is frequently overlooked or not assessed by healthcare providers. Schoenbaum and Weber 1993. Additionally, women may overlook or misperceive their own risk for HIV and thus fail to seek testing. Recent studies have shown that failure to acknowledge risk for HIV is the primary reason that people, including women, delay or do not obtain HIV testing. Lehman et al. 1998. Confronting HIV risk may be particularly difficult for women. Not only must they assess their own behavioral risk, but they must also examine the potential risk behaviors of male partners, i.e., intravenous drug use or sex with other partners. Although some women are unaware of the risk behaviors of their sex partners, Dahl et al. 1991, others deny or overlook evidence of their partner's HIV risk. In a study including high-risk, uninfected women, approximately 63% reported inconsistent condom use in the 6 months prior to the study. Moore et al. 1998b. When asked the reasons for non-use of condoms at last incident of unprotected intercourse, approximately 85% said that their partner was not at risk, although only a small proportion actually knew the HIV status of their partner, and many had earlier acknowledged their partner's involvement in risk behaviors. Confronting partners with their risk behavior can cause considerable turmoil in a relationship. Anticipation that the relationship will be disrupted or the partner will be made upset may prevent women from initiating any discussion with their partner about HIV. Harrison et al. 1995. In a study of women who knew or suspected that their partner had other sex partners, the most frequently reported reasons for not broaching the issues of partner's risk behavior or of his getting an HIV test were concerns that the partner would feel accused of infidelity or of having a disease and that he would be displeased with the woman for bringing up the subject. Moore et al. 1995. Many healthcare professionals and researchers have written about women's fear of violence from their partner as a primary obstacle to initiating discussions about HIV. Data available on the subject suggests that although fear of women and HIV infection 345 abuse may be the reason for lack of confrontation for some women, many more women do not bring up issues related to HIV for fear of displeasing or upsetting the partner. Harrison et al. 1995. Moore et al. 1998b. Additionally, recent data suggests that only a small proportion of women decline HIV testing for fear of abusive repercussions from male partners. Marr et al. 1998. The threat of violence, however, is a real concern for at least a portion of women at risk for HIV. Gillen et al. 1997, Moore et al. 1995. And healthcare professionals must be mindful of this possibility as they help women face their own and their partner's HIV risk. Women may need support not only in deciding to obtain an HIV test but also in taking the steps to get the test. They may have informational needs such as where to go for a test, what to expect from the testing situation, and the implications of different test results. Once women have been tested and are waiting for test results, support needs are likely to be even greater. Research suggests that waiting for HIV test results is highly stressful for both men and women, particularly for persons perceiving themselves to be at high risk for HIV. Ikovics et al. 1994, Jacobson et al. 1990. People with few social supports and a history of prior psychiatric difficulties are typically more distressed during this time. Kelly et al. 1993, Perry et al. 1990b. Women without sufficient internal or external resources to deal with the waiting period are likely to need help generating internal coping strategies and external sources of social support to get through this time. Pre-test counseling often includes helping women identify persons to whom they can disclose that they are awaiting HIV test results and who could offer support during the waiting period. They also may need help anticipating and planning how they would cope with a positive test result. Receiving HIV test results. Negative results. Depression, anxiety, and suicidal thoughts tend to decrease in most people after notification of negative results. Emotional stabilization is a well-established positive outcome of learning one's status. Ostro et al. 1989, Perry et al. 1990a, 1990c. Reduced depression and anxiety, however, are sometimes accompanied by a return to old patterns of risk behavior. Research has shown that both men and women reduce high-risk sexual activity after testing and while awaiting results, but gradually resume risk behaviors after receiving a negative diagnosis. Ikovics et al. 1994, G. Marks, Length of time since testing HIV seropositive and prevalence of sexual activity, unpublished 346 Psychological Aspects of Women's Healthcare, 2nd edition data, 1993. Ikovics et al., 1994, interviewed women about sexual risk behavior prior to HIV testing, when they returned for results 2 weeks later, and again 3 months after receiving negative results. The authors found that sexual risk-taking decreased during the waiting period but returned to pre-test rates at the 3-month assessment. In some cases, receiving a negative test result may actually confer a feeling of invulnerability or immunity, resulting in an increase in risk behaviors above those seen prior to testing. Women receiving negative test results need support in maintaining the reductions in risk behavior they achieved while waiting for test results. They may need reminders that a negative test result does not mean they cannot nor will not become infected with HIV in the future, nor does it mean that their sex partner is uninfected. Women who receive negative HIV test results should encourage sex partners to be tested. Until the partner receives a negative test result and the couple decides to practice monogamy, protection should be used during each sexual episode. Positive results. Women's advocates, healthcare providers, and public health professionals have been concerned that a positive HIV diagnosis may cause severe psychologic reactions, i.e., anxiety, depression, suicide, and social ramifications, i.e., loss of partners, children, friends, family, job, and healthcare benefits, for women who have relatively few internal and external resources to help them cope. Chung and Magrob 1992, Ikovics and Rodan 1992. Particular concerns have been raised about the consequences of a positive HIV diagnosis for pregnant women, a group already vulnerable to adverse psychologic and social events. Lester et al. 1995. Only limited data have been published on the psychologic consequences of an HIV diagnosis for women. Studies from mixed gender samples and other populations, example gay men, intravenous drug users, have shown that many people experience depressive symptoms and anxiety when they learn of their HIV infection. Cleary et al. 1993, Jacobson et al. 1990, Ostro et al. 1989. However, most persons do not experience severe psychiatric disorders such as clinical depression or suicidal thoughts and attempts. When these disorders do occur, they do so more often in people with a prior history of psychiatric disorder. Perry et al. 1993. Additionally, after a period of adaptation to the diagnosis, most newly diagnosed people return to levels of depressive symptoms and anxiety typical of similar uninfected populations. Du et al. 1990, Perry et al. 1990a. For example, Perry et al. 1990, found that 2 months after HIV testing, people diagnosed with HIV did not differ on suicidal thoughts, women, and HIV infection 347 wishes, and intent from those receiving a negative diagnosis. For both HIV-infected and uninfected people, lower scores on psychopathology ratings were found at the 10-week follow-up compared with scores prior to learning their serostatus. Studies comparing men and women are rare, but the available data suggest that women experience more distress and depression after diagnosis than do infected men. Cleary et al. 1993, Fleischman and Fogel 1994, Perry et al. 1993, although gender differences tend to be less striking when socioeconomic status and drug use are similar between the two groups. Brown and Rundell, 1993, reported few occurrences of depression, suicidal ideation, or other psychiatric disorders among a group of HIV-infected women in the military. 41% of these women qualified as having a psychiatric diagnosis, but hyposexuality or sexual dysfunction constituted the majority of these cases. Few studies have reported on the adverse social events and losses experienced by women after receiving a positive HIV diagnosis. Early studies of gay men reported some loss of health care benefits, confidentiality, economic resources, i.e., housing, income, and insurance, and social support and relationships. Bayer et al. 1986, Lowe et al. 1989. Advocates and public health practitioners have been particularly concerned about the social and economic repercussions of HIV testing of pregnant women, a group already at social and economic risk. Lester et al. 1995, followed up 22 HIV-infected pregnant women and a comparison group of 20 uninfected pregnant women. They found no evidence of increased economic loss among infected women and greater satisfaction with social supports among infected than among uninfected women. HIV-infected women, however, reported higher levels of healthcare discrimination, personal isolation, and anxiety than did uninfected women. Additional data on this issue among pregnant and non-pregnant women are sorely needed to assess potential negative, unintended consequences of HIV testing and to ensure that newly diagnosed HIV-infected women receive the social support services they need. Disclosure of test results is of primary concern to newly diagnosed men and women. Hayes et al. 1993, Marks et al. 1991, Semple et al. 1993. In a study of the psychobiologic stressors of HIV-infected women, Semple et al. 1993, reported that most women viewed disclosure as one of their most pressing concerns following HIV diagnosis. Data indicate that most HIV-infected women disclose their status to at least one person. Gillen et al. 1997, Lester et al. 1995, Simone et al. 1995. Generally, disclosure is made most frequently to partners/spouses/lovers, with rates reported between 85% and 100% in various studies. Gillen et al. 1997, Lester et al. 1995, Simone et al. 348 Psychological Aspects of Women's Healthcare, 2nd edition 1995. Disclosure is then made to close friends and immediate family members, followed by extended family, co-workers, and acquaintances. Most women cite fear of abandonment or rejection as their primary reason for failing to disclose HIV status to other adults. Gillen et al. 1997, Simone et al. 1995. Available data suggest, however, that women frequently receive supportive reactions from others when they disclose. Simone et al. 1995, and in one study, HIV-infected women reported more satisfaction with social support from friends and family than did uninfected women. Lester et al. 1995. Several studies have reported disrupted relationships, primarily with sex partners, following women's disclosure of HIV results. Simone et al. 1995, found that 6 of 30 male partners reacted to the woman's disclosure of her serostatus by leaving the relationship. Gillen et al. 1997, reported that 8% of newly diagnosed women anticipated violent reactions from their partner on disclosure of their HIV infection. Of those expecting violence, 4% actually experienced some violent reaction when the partner was told, and another 4% who had not anticipated such a reaction reported violence at follow-up. Violent reactions from partners were not direct physical attacks to the woman but instead involved activities such as throwing objects against the wall or kicking the television. Women frequently need assistance in deciding when and how to tell sex partners about their HIV status and in anticipating partner reactions. In some states,
Infected persons must tell their sex partners of their serostatus, or authorities will locate partners and inform them of their exposure to HIV. Women's advocates have suggested that partner notification laws may place women at risk for violence from male sex partners who learn of their exposure to HIV. North and Rothenberg, 1993. Although data suggests that partner violence is not a frequent reaction to disclosure, Gillen et al. 1997, women should be assisted in anticipating partner response and in planning when, where, and how to tell partners, particularly those with a history of domestic violence. Additionally, women may need information about where to go for help if their partner becomes violent. Women also must decide if and when to talk to their children about their HIV infection. Few data are available on the extent to which infected women disclose their HIV status to their children, but much has been written about mothers' concerns with regard to informing children. Armistead and Forehand, 1995, Semple et al. 1993. Armistead and Forehand, 1995, interviewed HIV-infected women about decisions and challenges they faced, and found that women perceived disclosure to children as the most emotionally difficult issue they faced. The authors discuss several reasons mothers may choose women and HIV infection 349 not to disclose their HIV status to their children, including 1. Desire to protect children, 2. Fear that children will feel stigmatized by their illness, 3. Concern about children's feelings toward them and the way they contracted HIV, and 4. Concern about children's ability to keep a secret and not tell others about their disease. Women must take into account several factors when making the decision to disclose to a child, including the child's age, coping ability, the status of mother's illness and functioning, and the likelihood that the child will hear about the mother's illness from others. Women are likely to need assistance in thinking through repercussions to children and in deciding what the child should be told. Few data are available to guide women in their decisions. Drayman, 1993, writing about the professional's role in helping mothers decide about disclosure to children, states that although professionals can help the parent explore the consequences related to disclosure and non-disclosure, whether or not to disclose is a highly personal and demanding choice about which the parent is the best judge. p. 21. Living with HIV coping and adjustment. Few data have been reported on adjustment and coping by women living with HIV infection. Available data suggests that asymptomatic HIV-infected women and uninfected women from similar socioeconomic backgrounds differ little in their social and psychologic functioning. Lipsitz et al. 1994, Moore et al. 1999, Pergamai et al. 1993. For example, Moore et al. 1999, in a study that included HIV-infected and uninfected women, reported high levels of depressive symptoms and adverse social events in both groups, with no difference in the number of depressive symptoms between the groups and more adverse social events in the uninfected group. Example: insufficient money for necessities, physical assaults, and removal of children from the home. Intravenous drug and crack use were more important predictors of psychosocial dysfunction than was HIV status. However, the women in this study were at a relatively early stage of infection. Studies of men have shown that distress increases with the onset of HIV-related symptoms or with the diagnosis of AIDS. Belkin et al. 1992, Rabkin et al. 1991. Most studies of HIV infection in women have not followed participants to the later stages of disease and the development of AIDS. HIV-infected women are likely to show higher levels of psychosocial dysfunction as they become more sick, and differences between infected and uninfected women may become more striking. Considerable attention has been given by AIDS researchers to the effects of psychosocial stress on HIV disease progression. Psychologic stressors have 350 psychological aspects of women's health care, second edition, been shown to affect the onset of illness by negatively impacting the immune system. Herbert and Cohen 1993, Persky et al. 1987, and thus researchers have speculated about the possible effect of stress on people with HIV infection. Glazer and Kyakolt Glazer 1987.
Data collected from men's cohort studies throughout the United States present an inconsistent picture of the importance of social and psychologic factors on rates of immunologic decline. Barak et al. 1993, Lyksos et al. 1993, although it appears that if an effect exists, it is likely to be small. Perry and Fishman 1993. This topic has been of great interest to researchers and clinicians of HIV-infected women because of the high levels of psychosocial stress found in this population. Data addressing this issue in women have not been published, although they should soon become available from the ongoing longitudinal studies of HIV-infected women. Sexual behavior. Many HIV-infected women modify their sexual behavior after learning their diagnosis. Hankins et al. 1998, Moore et al. 1998c. Although most remain sexually active, i.e., approximately 70% in the early stages of disease, more HIV-infected women than uninfected women, matched on socio-demographics and risk behaviors, report being abstinent. Hankins et al. 1997, Zierler et al. 1999. Additionally, more infected, 54%, than uninfected women, 26%, report always using condoms with male partners. Moore et al. 1998a. Among infected women not consistently using condoms, Moore et al. 1998b, found that approximately one-half reported having an HIV-infected partner. Of those women with an uninfected partner, approximately half used condoms for all episodes of vaginal sex. Among the inconsistent users or non-users of condoms, approximately 60% indicated that their uninfected partner knew of the woman's HIV status but elected not to use condoms. Currently, the only methods of HIV protection known to be effective are abstinence and use of the male condom. Because men wear condoms, they can elect not to use them and thus not to protect themselves. These data point to the importance of involving uninfected partners of HIV-infected women in safe sex counseling to ensure that they understand the risks they are taking and work to change unsafe sexual behaviors. Without the male partner's cooperation, HIV-infected women will be unable to ensure that their sex partners are protected. Reproductive decision-making. HIV-infected women are faced with difficult decisions about continuing a current pregnancy or becoming pregnant in the future. In the early phase of women and HIV infection 351, the HIV epidemic, the possibility of transmission from mother to child was expected to greatly change the childbearing plans of infected women and result in pregnancy termination among those already pregnant. Early studies, however, reported that HIV serostatus was not associated with pregnancy termination. Johnstone et al. 1990, Selwyn et al. 1989, nor with becoming pregnant in the future. Barbasi et al. 1989, Sunderland et al. 1992. More recent studies suggest that HIV-infected women have less desire and intention to become pregnant than do matched, uninfected women. Lester et al. 1995, and that infected women may change childbearing plans after learning their serostatus. Hankins et al. 1998. It is unclear how these desires and intentions affect contraceptive behavior and pregnancy rates. With the publication of the AIDS Clinical Trials Group 076, 1998, results, which showed a 2/3 reduced risk of perinatal HIV transmission with a zidovudine regimen, more infected women may see pregnancy as a realistic option. Data collected after the publication of 076 results are not yet available on women's decisions to terminate pregnancy or avoid future pregnancies. The decision to bear a child is likely to be difficult for HIV-infected women despite medical advancements that have greatly reduced chances of having an infected child. Centers for Disease Control and Prevention 1997c. Women still must deal with issues related to their own mortality and the effect that this disease will have on the child's quality of life. With the advent of new medications to improve length and quality of life of infected persons, women may feel they have a better chance of raising their children, and thus more infected women may decide to reproduce. Planning for the future. Despite promising new therapies, many HIV-infected women will face declining health and the prospect of early death.
The needs of people preparing for disability or death have been written about extensively. Kastenbaum and Eisenberg 1972, Kubler-Ross 1969, 1975. Because HIV-infected women are relatively young compared with many other women with declining health, they have the additional need to plan for the future of dependent children. In many families with children, the HIV-infected mother has been the only parent providing care, Schabel et al. 1995, and so an alternative placement must be sought for children when the mother becomes debilitated. Contemplating the alternative care of one's children can be an overwhelming task for mothers. Armistead and Forehand, 1995, discuss reasons HIV-infected women may delay or avoid planning for the future of their children, including 1. Having to face their own impending death, 2. A lack of AL 352 psychological aspects of women's health care, 2nd edition alternative caregivers whom the mother trusts to raise her children, 3. Negative experiences with welfare agencies, and 4. Lack of access to legal services necessary for making formal custody arrangements. In some large metropolitan areas, agencies have been organized for the specific purpose of helping women make decisions about the future of their children and ensuring that these plans are legally documented and carried out when the woman can no longer care for her children. New York City's Early Permanency Planning Program, for example, assists HIV-infected mothers in planning for future placement of children and assists children in making the transition to the new family, Levine 1995. These programs are relatively new, concentrated in only a few metropolitan areas, and may reach relatively few HIV-infected women. One study has shown that most HIV-infected women with children are unaware of or have not contacted available child care agencies, Schabel et al. 1995. Other studies report that most infected women do not make formal plans for transferring guardianship of children, and thus the fate of children is left primarily to surviving relatives, Lester et al. 1995, Levine 1995. HIV-infected women repeatedly indicate that the well-being of their children is their most pressing concern, Armistead and Forehand 1995, Semple et al. 1993. Legal, social service, and psychologic assistance are needed to help them confront, plan for, and transition their children into acceptable alternative placements. Summary: as the number of HIV-infected women in need of health care services swells in the coming years, these biomedical and psychosocial issues will become increasingly salient to medical providers caring for women's health. It is imperative that care providers, administrators, funders, and advocates build the expertise and services necessary to improve HIV counseling and testing services for women, the risk reduction interventions to lower the rates of new infections, and the medical, psychologic, and social service care for women who are already infected. References: AIDS Clinical Trial Group 076, Public Health Service Task Force Recommendations for the Use of Antiretroviral Drugs in Pregnant Women Infected with HIV. 1 for Women and HIV Infection. 353 Maternal Health and for Reducing Perinatal HIV-1 Transmission in the United States. CDC MMWR 47, RR21, 30, 1998. Anderson B., DeProssi C., Controlled Prospective Longitudinal Study of Women with Cancer, 2, Psychological Outcomes. J. Consult ClinPsychol 57:692 697, 1989. Anzala O.A., Najekerki N.J.D., Bueo J.J., et al., Rapid Progression to Disease in African Sex Workers with Human Immunodeficiency Virus Type 1 Infection. J. Infectis 171:686, 689, 1995. Armistead L., Forehand R., For Whom the Bell Tolls, Parenting Decisions and Challenges Faced by Mothers Who Are HIV Seropositive. Clinical Psychology, Science and Practice 2:239, 250, 1995. Barba C. M., Chasen R., Anderson J., et al., Knowledge of HIV Serostatus and Pregnancy Decisions, Abstract No. MBP 10, in Abstracts of the International Conference on AIDS, Vancouver, Canada, June 4–9,
1989 Barkin S.E., Melnick S.L., Preston Martin S., et al., The Women's Interagency HIV Study, WIHS Collaborative Study Group. Epidemiology 9:117, 125, 1998 Bayer R., Levine C., Wolf S.M., HIV Antibody Screening, An Ethical Framework for Evaluating Proposed Programs. JAMA 256:1768, 1774, 1986 Bieber S., Catalan J., Women's Experience of HIV Testing, The Views of HIV-Positive and HIV-Negative Women. AIDS Care 5:177, 186, 1993 Belkin G.S., Fleischman J.A., Stein M.D., et al., Physical Symptoms and Depressive Symptoms Among Individuals with HIV Infection. Psychosomatics 33:416, 427, 1992 Bigger R.J., Pawat S., Minkoff H., et al., Immunosuppression in Pregnant Women Infected with Human Immunodeficiency Virus. AMJ Obstet Gynecol 161:1239, 1244, 1989 Bocalubo, Rabin D.L., Coughlin S.S., et al., Knowledge, Attitudes, and Practices of Obstetrician Gynecologists Regarding the Prevention of Human Immunodeficiency Virus Infection. Obstet Gynecol 81:131, 136, 1993 Bredel R.P., Lean C.L.S., The Natural History of HIV and AIDS in Women. AIDS 5:1283 1292, 1991 Brown G.R., Rundell J.R., A Prospective Study of Psychiatric Aspects of Early HIV Disease in Women. Gen Hosp Psychiatry 15:139, 147, 1993 Burak J.H., Barrett D.C., Stahl R.D., et al., Depressive Symptoms and CD4 Lymphocyte Decline Among HIV-Infected Men. JAMA 270:2568, 2573, 1993 Centers for Disease Control, Follow-up on Kaposi Sarcoma and Pneumocystis Pneumonia. MMWR 30:409, 410, 1981 Centers for Disease Control, Premarital Sexual Experience Among Adolescent Women, United States, 1970 to 1988. MMWR 39:929, 931, 1991 Centers for Disease Control and Prevention, Update, Acquired Immunodeficiency Syndrome, United States, 1992. MMWR 42:547, 557, 1993 A 354 Psychological Aspects of Women's Healthcare, 2nd edition Centers for Disease Control and Prevention, Update, Mortality attributable to HIV infection/AIDS among persons aged 25 to 44 years, United States, 1981 to 1991. MMWR 42:481, 486, 1993 B Centers for Disease Control and Prevention, HIV Prevention Practices of Primary Care Physicians, United States, 1992. MMWR 42:988, 992, 1994 Centers for Disease Control and Prevention, HIV/AIDS Surveillance Report, Vol. 7. Centers for Disease Control and Prevention, Atlanta, Georgia, 1995. Available online at http://www.cdc.gov/hiv/stat/hazarlink.htm Centers for Disease Control and Prevention, Anergy Skin Testing and Preventive Therapy for HIV-Infected Persons, Revised Recommendations. MMWR 46:1, 12, 1997 A Centers for Disease Control and Prevention, HIV/AIDS Surveillance Report, Vol. 7. Centers for Disease Control and Prevention, Atlanta, Georgia, 1997b. Available online at http://www.cdc.gov/hiv/stat/hazarlink.htm Centers for Disease Control and Prevention, Update, Perinatally Acquired HIV/AIDS, United States, 1997. MMWR 46:2, 8, 1997 C Centers for Disease Control and Prevention, Update, Trends in AIDS Incidence, United States, 1996. MMWR 46:861, 867, 1997 D Centers for Disease Control and Prevention, USP/IDSA Guidelines for the Prevention of Opportunistic Infections in Persons Infected with Human Immunodeficiency Virus. MMWR 46:1, 46, 1997 E Centers for Disease Control and Prevention, Administration of Zidovudine during late pregnancy and delivery to prevent perinatal HIV transmission, Thailand, 1996-1998. MMWR 47:151, 154, 1998 A Centers for Disease Control and Prevention, Diagnosis and Reporting of HIV and AIDS in States with Integrated HIV and AIDS Surveillance, United States, January 1994 to June 1997. MMWR 47:309, 314, 1998 B Centers for Disease Control and Prevention, 1998 Guidelines for Treatment of Sexually Transmitted Diseases. MMWR 47:1, 115, 1998 C Centers for Disease Control and Prevention, Public Health Service Task Force Recommendations for the Use of Antiretroviral Drugs in Pregnant Women Infected with HIV-1 for Maternal Health and for Reducing Perinatal HIV-1 Transmission in the United States. MMWR 47:1, 30, 1998 E Centers for Disease Control and Prevention, Report of the NIH Panel to Define Principles of Therapy of HIV Infection and Guidelines for the Use of Antiretroviral Agents in HIV-Infected Adults and Adolescents. MMWR 47:1, 82, 1998 F. Chasen Re, Taylor E., Margot Lick J.B., et al., Immune Serum Markers and CD4 Cell Counts in HIV-Infected Intravenous Drug Users. J-AIDS 5:456, 460, 1992 Chu S.Y., Bueller J.W., Berkelman R.L., Impact of the Human Immunodeficiency Virus Epidemic on Mortality in Women of Reproductive Age, United States. JAMA 264:225, 229, 1990 Women and HIV Infection 355 Chu S.Y., Hamid Ta, Bueller J.W., Update, Epidemiology of Reported Cases of AIDS in Women Who Report Sex Only with Other Women, United States, 1980 to 1991. AIDS 6:518, 519, 1992 Chungjai, Maghrab MM, A Group Approach to Psychosocial Issues Faced by HIV-Positive Women. Hospital and Community Psychiatry 43:891, 894, 1992 Cleary PD, Devonder NV, Rogers TF, et al., Depressive Symptoms in Blood Donors Notified of HIV Infection. AMJ Public Health 83:534, 539, 1993 Collier AC, Coombs RW, Schoenfeld et al., Treatment of Human Immunodeficiency Virus Infection with Sequinavir, Zidovudine, and Zalcitabine. An English JMet 334:1011, 1017, 1996 Kramer J., Matson R., Monitoring Compliance with Anti-Epileptic Drug Therapy, Inpatient Compliance in Medical Practice and Clinical Trials. Edited by Kramer J., Spilker B. New York, Raven, 1991, pp 123-137 DeCock K.M., Luca S.B., Lucas S., et al., Clinical Research, Prophylaxis, Therapy, and Care for HIV Disease in Africa. AMJ Public Health 83:1385, 1389, 1993 Deeks S.G., Smith M., Hollandley M., HIV-1 Protease Inhibitors, A Review for Clinicians. JAMA 277:145, 153, 1997 Desha M.M., Pape J.W., Desvarios M., et al., A Prospective Study of HIV Seropositive Asymptomatic Women of Childbearing Age in a Developing Country. J-AIDS 6:446, 451, 1993 Due, Ragne M., Nimmerwicks P., Infection with Human Immunodeficiency Virus and Vulnerability to Psychiatric Distress. ArchGen Psychiatry 47:737, 744, 1990 Dahl L.S., Peterson L.R., White C.R., et al., Human Immunodeficiency Virus Type 1, Infected Blood Donors, Behavioral Characteristics and Reasons for Donation. Transfusion 31:704, 709, 1991 Draymond B., Adolescents in Families with AIDS, Growing Up with Loss, in a Death in the Family, Orphans of the HIV Epidemic. Edited by Levine C. New York, United Hospital Fund, 1993, pp 13-23 Epstein L.H., Cluspier, A Behavioral Medicine Perspective on Adherence to Long-Term Medical Regimens. J. Consult Clin Psychol 50:950, 971, 1982 Farzad Egan H., Hoover D.R., Astembersky J., et al., Gender Differences in the Relationship Between HIV-1 Load and Progression to AIDS, Abstract number 133784, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998 Feingold A.R., Vermund S.H., Burke R.D., et al., Cervical Cytologic Abnormalities and Papillomavirus in Women Infected with Human Immunodeficiency Virus. J. AIDS 3:896, 903, 1990 Fernandez M.I., Wilson T., Moore J., et al., Acceptance of HIV Testing Among Women in Prenatal Care in Miami, New York City, and Connecticut, Abstract number 43142, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 July 3, 1998 356 Psychological Aspects of Women's Healthcare, 2nd edition Flanagan T.P., Imam N., Lang N., et al., Decline of CD4 lymphocyte counts from the time of seroconversion in HIV-positive women. J. Women's Health 1:231, 234, 1992 Fleischman J.A., Fogel B., Coping and Depressive Symptoms Among People with AIDS. Health Psychol 13:156, 169, 1994, Fleming Place Cecilski California Byers R.H., et al., Gender Differences in Reported AIDS Indicative Diagnoses. J. Infectis 168:61, 67, 1993 Fruchter R.G., Mayman M., Sidleys A., et al., Multiple Recurrences of Cervical Intraepithelial Neoplasia in Women with the Human Immunodeficiency Virus. Obstet Gynecol 87:338, 344, 1996 Gillen A.C., Ocampo P., Faden R.R., et al., Women's Disclosure of HIV Status, Experiences of Mistreatment and Violence in an Urban Setting. Women Health 25:1931, 1997 Glazer R., Kyakold Glazer J., Stress-Associated Depression of Cellular Immunity, Implications for Acquired Immune Deficiency Syndrome, AIDS. Brain Behave Immun 1:107, 112, 1987 Glasgow Re., Compliance to Diabetes Regimens, Conceptualization, Complexity, and Determinants, in Patient Compliance in Medical Practice and Clinical Trials. Edited by Kramer J., Spilker B. New York, Raven, 1991, pp 209-224 Grant A.D., Joman G., Smets P., et al., Profound Immunosuppression Across the Spectrum of Opportunistic Disease Among Hospitalized HIV-Infected Adults in Abidjan, Côte d'Ivoire. AIDS 1:1357, 1364, 1997 Greenberg J., Magder L., Errol S., Age at First Coitus, a Marker for Risky Sexual Behavior in Women. Sex Transum Dis 19:331, 334, 1992 Hankins C., Gendron S., Tranti, et al., Sexuality in Montreal Women Living with HIV. AIDS Care 9:261, 271, 1997 Hankins C., Tranti, Lapointe N.,
et al., Sexual Behavior and Pregnancy Outcome in HIV-Infected Women. J. Acquire Immune Defic SYNDR Hum Retroviral 18:479, 487, 1998 Harrison J.S., Moore J.S., Duran S., HIV-Related Communication and Condom Use Among Hispanic Women and Their Male Partners. Presented at the HIV Infection in Women Conference, Washington, D.C., February 1995 Hayes R.B., Mikusic L., Polak L., et al., Disclosing HIV Seropositivity to Significant Others. AIDS 7:425, 431, 1993 Herbert T.B., Cohen S., Depression and Immunity, a Meta-Analytic Review. Psychol Bull 113:472, 486, 1993 Holmberg S.D., Horsberg C.R.J.R., Ward J.W., et al., Biologic Factors in the Sexual Transmission of Human Immunodeficiency Virus. J. Infectis 160:116, 125, 1989 Ikovics J.R., Rodan J., Women and AIDS in the United States, Epidemiology, Natural History, and Mediating Mechanisms. Health Psychol 11:1, 16, 1992 Women and HIV Infection 357 Ikovics J.R., Morrill A.C., Burin S.E., et al., Limited Effects of HIV Counseling and Testing for Women, a Prospective Study of Behavioral and Psychological Consequences. JAMA 272:443, 448, 1994 Jacobson P.B., Perry S.W., Hershta, Behavioral and Psychological Responses to HIV Antibody Testing. J. Consult Clin Psychol 5831, 37, 1990 Johnstone F.D., Brettel R.P., McCallum L.R., et al., Women's Knowledge of Their HIV Antibody State, Its Effect on Their Decision Whether to Continue the Pregnancy. BMJ 300:23, 24, 1990 Kastenbaum R., Eisenberg R.B., The Psychology of Death. New York, Springer, 1972 Kelly J.A., Murphy D., Barr G.R., et al., Factors Associated with Severity of Depression and High-Risk Sexual Behavior Among Persons Diagnosed with Human Immunodeficiency Virus, HIV, Infection. Health Psychol 12:215, 219, 1993 Kinloch Delos S., DeSauce Shore P., Saray J.H., et al., Symptomatic Primary Infection Due to Human Immunodeficiency Virus Type 1, Review of 31 Cases. Clin Infectis 17:59, 65, 1993 Kubler Rossi, On Death and Dying. New York, Macmillan, 1969 Kubler Rossi, Death, The Final Stage of Growth. Englewood Cliffs, New Jersey, Prentice Hall, 1975 Lehman J.S., Hecht F.M., Fleming P.L., et al., HIV Testing Behavior Among At-Risk Populations, Why Do Persons Seek, Defer, or Avoid Getting Tested in the United States? Abstract number 43103, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998 Lester P., Partridge J.C., Chesney M., et al., The Consequences of a Positive Prenatal HIV Antibody Test for Women. J. AIDS Hum Retroviral 10:341, 349, 1995 Levine C., Orphans of the Epidemic, Unmet Needs in 6 U.S. Cities. AIDS Care 7S57S62, 1995 Lipsitz J.D., Williams J.B.W., Rabkin J.G., et al., Psychopathology in Male and Female Intravenous Drug Users with and Without HIV Infection. AMJ Psychiatry 151:1662, 1668, 1994 Low B., Steinbrook R., Cook M., et al., Voluntary Screening for Human Immunodeficiency Virus, HIV, Infection, Weighing the Benefits and Harms. And Intern Med 110:727 733, 1989 Lucas S.B., Haunoe, Peacock C., et al., The Mortality and Pathology of HIV Infection in a West African City.
AIDS 7:1569, 1579, 1993 Likso CG, Hoover Dr., Cuccioni M., et al., Depressive symptoms as predictors of medical outcomes in HIV infection. JAMA 270:2563, 2567, 1993 Marr, J., Seaman, G.M., Peterson, J., et al., Partner Violence and Women's Decision to Have an HIV Test, Abstract number 43110, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998 Mayman M., Fruchter R.G., Siruri, et al., Human Immunodeficiency Virus Infection and Cervical Neoplasia. Gynecol Uncle 38:377, 382, 1990 358 Psychological Aspects of Women's Healthcare, 2nd edition Mayman M., Tarragon N., Vieira J., et al., Colposcopic Evaluation of Human Immunodeficiency Virus Seropositive Women. Obstet Gynecol 78:84, 88, 1991 Mann S.L., Zatra A.J., Couples Coping with Chronic Illness, Women with Rheumatoid Arthritis and Their Healthy Husbands. J.B. Hobmet 13:327, 342, 1990 Marks G., Richardson J.L., Maldonado N., Self-Disclosures of HIV Infection to Sexual Partners. AMJ Public Health 81:1321, 1322, 1991 Marmer M., Weiss L.R., Leiden M., et al., Possible Female-to-Female Transmission of Human Immunodeficiency Virus, Letter. And Intern Med 105:969, 1986 Masser H., Michelis Mott, Wormser G.P., et al., Opportunistic Infection in Previously Healthy Women, Initial Manifestations of a Community-Acquired Cellular Immunodeficiency. And Intern Med 97:533, 539, 1982 Mocroft A., Johnson Mott, Philipson. Factors Affecting Survival in Patients with the Acquired Immunodeficiency Syndrome. AIDS 10:1057, 1065, 1996 Monson O.T., Capelan J.M.B., Female-to-Female Transmission of HIV, Letter. Lancet 2:40, 41, 1987 Moore J., Harrison J.S., KKL, et al., Factors Associated with Hispanic Women's HIV-Related Communication and Condom Use with Male Partners. AIDS Care 7:415 427, 1995 Moore J., Schumann P., Schoenbaum E., et al., Severe Adverse Life Events and Depressive Symptoms Among Women with, or at risk for, HIV infection in 4 cities in the United States of America. AIDS 13:2459, 2468, 1999 Moore J., Saul J., Van Vanter N., et al., Factors Influencing Relationship Quality of HIV Serodiscordant Heterosexual Couples in HIV and Social Interaction. Edited by Derliga V.J., Barbie AP 1000 Oaks CA, Sage Publications, 1998a, pp 165-192 Moore J., Schoenbaum E., Warren D., et al., Barriers to Condom Use Identified by HIV-Infected and At-Risk Women, Abstract number 23420, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998 B. Moore J., Schoenbaum E., Warren D., et al., Patterns of Condom Use Reported by HIV-Infected and At-Risk Women at 3 Time Periods, Abstract number 23404, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998 C. Morgan D., Malamba S.S., Maud G.H., et al., an HIV-1 Natural History Cohort and Survival Times in Rural Uganda. AIDS 11:633, 640, 1997 A. Morgan D., Maud G.H., Malamba, et al., HIV-1 Disease Progression and AIDS-Defining Disorders in Rural Uganda. Lancet 350:245, 250, 1997 B. North R.L., Rothenberg K.H., Partner Notification and the Threat of Domestic Violence Against Women with HIV Infection. An English J. Met 329:1194, 1196, 1993 Ostro D.G., Monjan A., Joseph J., et al., HIV-related symptoms and psychological functioning in a cohort of homosexual men. AMJ Psychiatry 146, 737-742, 1989 Women and HIV Infection 359 Palila F.J., Delaney K.M., Mormon A.C., et al., Declining Morbidity and Mortality Among Patients with Advanced Human Immunodeficiency Virus Infection. An English J. Met 338:853, 860, 1998 Pergamai A., Gala C., Burgess A., et al., The Psychosocial Impact of HIV Infection in Women. J. Psychosome Res 37:687, 696, 1993 Perry S., Fishman B., Depression and HIV, How Does One Affect the Other? JAMA 270:2609, 2610, 1993 Perry S., Jacobsberg L., Fogel K., Orogenital Transmission of HIV. An Intern Med 111:951, 952, 1989 Perry S., Jacobsberg L., Fishman B., Suicidal Ideation and HIV Testing. JAMA 263:679, 682, 1990 Perry S., Jacobsberg L., Fishman B., et al., Psychiatric Diagnosis Before Serological Testing for the Human Immunodeficiency Virus. AMJ Psychiatry 147:89, 93, 1990 B. Perry S., Jacobsberg L., Fishman B., et al., Psychological Responses to Serological Testing for HIV. AIDS 4:145, 152, 1990 C. Perry S., Jacobsberg L., Card-Cal, et al., Severity of Psychiatric Symptoms After HIV Testing. AMJ Psychiatry 150:775, 779, 1993, Persky View Kempthorne Rawson J., Sheck LRB, Personality and Risk of Cancer, 20-year follow-up of the Western Electric Study. Psychosome Med 49:435, 444, 1987 Rabkin J.G., Williams J.B.W., Remy N.R.H., et al., Depression, Distress, Lymphocyte Subsets, and Human Immunodeficiency Virus Symptoms on 2 occasions in HIV-positive homosexual men. ArchGen Psychiatry 48:111, 119, 1991 Ravenson T., Felton B.J., Disability and Coping as Predictors of Psychological Adjustment to Rheumatoid Arthritis. J. Clin Consult Psychol 57:344, 348, 1989 Royce R.A., Sina A., Cates W.J.R., et al., Sexual Transmission of HIV. An English J. Met 337:1072, 1078, 1997 Royce R.A., Walter E., Fernandez I., et al., HIV Counseling and Testing Among Parturients Sampled at 4 U.S. Sites, Preliminary Findings, Abstract Number 43117, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998 Chabal B., Diaz, T., Chu S.Y., et al., who are the primary caretakers of children born to HIV-infected mothers. Results from a multi-state surveillance project. Pediatrics 95:511, 515, 1995 Shaker T.W., Hughes J.P., Shetty, et al., Biological and Virologic Characteristics of Primary HIV Infection. An Intern Med 128:613, 620, 1998 Schaefer A., Friedman W., Mielk M., et al., The Increased Frequency of Cervical Dysplasia Neoplasia in Women Infected with the Human Immunodeficiency Virus is related to the degree of immunosuppression. AMJ Obstet Gynecol 164:593, 599, 1991 Schoenbaum E., Weber MP,
the under-recognition of HIV infection in women in an inner-city emergency room. AMJ Public Health 83:363, 368, 1993 360 Psychological Aspects of Women's Healthcare, 2nd edition Selwyn P.A., Carter R.J., Schoenbaum E. et al., Knowledge of HIV antibody status and decisions to continue or terminate pregnancy among intravenous drug users. JAMA 261 3567, 3571, 1989 Selwyn P.A., Alcabes P., Hartle D., et al., Clinical Manifestations and Predictors of Disease Progression in Drug Users with Human Immunodeficiency Virus Infection. An English JMet 327:1697, 1703, 1992 Semple S.J., Patterson T.L., Temoshik L.R., et al., Identification of Psychobiological Stressors Among HIV-Positive Women. Women Health 20:15, 36, 1993 Simone J.M., Mason H.R.C., Marks G., et al., Women's Self-Disclosure of HIV Infection, Rates, Reasons, and Reactions. J. Consult Clin Psychol 63:474, 478, 1995 Smith D.K., Warren D.L., Villahove D., et al., Design and Baseline Participant Characteristics of the Human Immunodeficiency Virus Epidemiology Research, HER, Study, a prospective cohort study of human immunodeficiency virus infection in U.S. women. AMJ Epidemial 146:459, 469, 1997 Solomon L., Stein M., Flynn C., et al., Health Services Used by Urban Women with or at Risk for HIV-1 Infection, the HIV Epidemiologic Research Study, HERS. J. Acquire Immunodefic SYNDR Hum Retroviral 17:253, 261, 1998 Sorvelo F., Kern P., Bunch G., et al., Early HIV Detection, Successes and Failures, Abstract number 43104, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998 Stein M.D., P.J., Moore v., et al., Differences in Access to Zidovudine, AZT, among symptomatic HIV-infected persons. J. Gen Intern Med 635, 40, 1991 Sterling T., Lyles C., Quinty C., et al., Gender-specific differences in HIV-1 RNA level in a longitudinal study of HIV-1 seroconverters, Abstract number 13379, in Abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998 Stone v. CGR, Hertz T., et al., The Relation Between Hospital Experience and Mortality for Patients with AIDS. JAMA 268:2655, 2661, 1992 Sunderland A., Minkoff H.L., Hant J., et al., The Impact of Human Immunodeficiency Virus Serostatus on Reproductive Decisions of Women. Obstet Gynecol 79:1027 1031, 1992 Tyndall B., Cooper D., Primary HIV Infection, Host Responses and Intervention Strategies. AIDS 5:1, 14, 1991 Todd J., Baylor R., Grosskirth H., et al., HIV-associated adult mortality in a rural Tanzanian population. AIDS 11:801, 807, 1997 Ward J.W., Holmberg S.T., Allen J.R., et al., Transmission of Human Immunodeficiency Virus, HIV, by blood transfusion screened as negative for HIV antibody. An English JMet 318:473, 478, 1988 World Health Organization, AIDS Epidemic Update, December 1998. Available online at http://www.who.in/emc-hiv/December1998/WADAR98e.pdf. Accessed August 22, 2000 Wordley PM, Fleming PL, Lindegren ML, et al.,
Prevention of Perinatal Transmission in the U.S., a population-based evaluation of prevention efforts in 4 states, Abstract Women and HIV Infection 361 number 23282, in abstracts of the 12th World AIDS Conference, Geneva, Switzerland, June 28 to July 3, 1998. Right TCJR, Sun XW, Anogenital papillomavirus infection and neoplasia in immunodeficient women. Obstet-Gynecol Clin North AM 23:861, 893, 1996. Zierler S., Meyer K., Moore J., et al., Sexual Practices in a Cohort of U.S. Women with and Without Human Immunodeficiency Virus. JAM Med Women's Association 54:7983, 1999. This page intentionally left blank.